looking for evidence of megacolon. In case if small bowel loops are dilated, we can say that this is an impending megacolon. And even if in a patient like this, we have to do a X-ray abdomen every day, it's okay. Viral markers were negative. This is again important because reactivation of viruses can happen if there is evidence of silent infection with immunosuppressive therapy. EBV virus was done, which was positive. IgG is positive. This is again important because people who are EBV negative, if we have to use immunosuppressive, when you use azathioprine, there is a risk of complications. Lymphoreticular malignancies risk is high, so we should focus on this. TPMT and NGTT were done, which were wild type. Lipid profile becomes important when we decide for use of cyclosporin. Lipid profile and magnesium are two tests which we do when we consider use of cyclosporin. And C. diff, as Dr. Atul mentioned, was done, which came out to be positive. Now, in our institute, when we say positive, it means it's GDH and toxin positive both. So this was the sigmoidoscopy. And I'd like to share with the residents that there are two scales what we use for severity of ulcerative colitis, Mayo score and ulcerative colitis endoscopic index of severity. Now, if a patient has ulcers or hemorrhages, according to Mayo score, it straight away goes into stage 3. In Mayo score, there's no further categorization into ulcers, into superficial ulcers or deep ulcers. Similarly, if there's a hemorrhage, it is stage 3. There's no categorization whether the hemorrhage is mucosal or luminal. Now, these 2 points are taken into consideration when we grade them according to ulcerative colitis endoscopic index of severity. And in this, if you look at the picture, the vascular pattern is completely lost. There is a bleeding, it's mild luminal bleeding, as we can see, and there are mucosal hemorrhages, and the ulcers are there, which are superficial ulcers. Now, if they're deep ulcers, then it goes to 3 scores. So UCEAS is 6 and Mayo score is 3. So there is an approximation between the two scales. 5 and 6 correlate, 6 and more than 6, 6 and up to 8 correlate with the Mayo 3. So to sum up the investigations which are required in a patient like this, that we have to look at the inflammatory markers, rule out infections, radiology is important, endoscopy is important. Endoscopy has a special role because we grade according to the 2 scales, and we same time we look for the presence of deep ulcers. The 2 implications of deep ulcers if we come across. One, that deep ulcers are suggestive. I'm saying suggestive of a CMV infection. Second, that patients who have deep ulcers, they do not so well. The prognosis becomes worse in patients who have deep ulcers on sigmoidoscopy. The point to remember is in acute severe ulcerative colitis, we do a limited, unprepared sigmoidoscopy with least amount of aerial suppression. So I'd like to involve audience also, that as I mentioned that according to us, it's the toxin and the GTH positive. Anybody among the residents, audience will like to say that in their institute, what is the policy? Do they do PCR first or PCR or toxin first or GTH or toxin or GTH or PCR first, or they go by the same policy as we have? Anybody among the audience would like to take up this question? Yeah, and I mean, anybody from PGI, that what is the departmental policy? What is your screening test? Do you start with PCR and GTH, or you go with GTH plus toxin together? Because PCR and GTH, they are sensitive, but they are not specific.
We will do combination of GDH and toxin or PCR plus toxin.
Okay. So it's the same policy. Thank you. Now, this is what is shown here, that for specificity, we need to do toxin. The problem is toxin is that it gets denatured if we keep it too long. So stool handling is very important when we are testing for stool C. diff. We should inform micro department that we are sending a sample and the processing should be done immediately. And if a patient is not producing stool, if a patient is in megacolon, or so we can take a rectal swab. So C. diff is an important issue, and here I would like to have an expert opinion from Dr. Vishal that how often do they come across C. diff in their clinical practice of patients with acute severe ulcerative colitis, and how to differentiate between infection or just a colonizer.
So I'll take the first question, the second question first, that it is very important for all of us to know that difficile positivity is not equal to difficile disease. But in a setting of active flare, when we are testing, we have to take it as equal to disease. So in this particular patient where you have acute exacerbation, if difficile test is positive, EIA is positive, you will have to treat this as a disease. Outside of IBD, if you're testing, I mean, the paradigm is that you test only individuals who are symptomatic, and the lab should process these samples only if it's a liquid stool rather than a solid stool. Now, so in this particular patient, difficile positivity, I think we need to treat. Now, how commonly we find, difficile? Till now, largely we had been using EIA. So we know that EIA for toxin is a less sensitive test. We have seen it in less than 10% of patients. So it will be around, I think, 2 to 5% of patients that we have a difficile positivity. The other, of course,
please.
Yeah, which group of patients do you suspect? So I think every flare of IBD, every acute severe colitis should be tested for difficile. And in which patients would you, clinically suspect? If you have a bleeding, which is a lot of bleeding, it is more likely to be due to disease activity. On the other hand, if you have an increased frequency of stool and not much of bleeding, that may suggest that it is likely to be difficile. Again, nothing is like 100%, but these are the clinical things which may suggest. The pseudomembranes are not as frequently seen in IBD patients on a sigmoidoscopy. So eventually you have to test each of the flares for difficile.
Yeah, thank you, Vishal. Very important message is that for all flares, C. diff should be tested. And to share with you, I mean, we are seeing more and more of C. diff in patients with IBD. So much so, it should be around more than 10% of our patients with flares turn out to be C. diff positive. So I think we need to awaken up to the situation that C. diff is coming up, is becoming more and more a problem in our country. And another point to remember is that it's our usual concept was that patients who have been on antibiotics, they are more likely to be positive. But now we are getting cases with community-acquired C. diff infections, patients with IBD, first diagnosis IBD. I mean, they have also been found to be positive at times. So this is where is the importance that C. diff should be worked up for all patients with acute severe ulcerative colitis. Now, regarding treatment, vancomycin is the standard treatment. For non-severe cases, it's 125 milligram 6 hourly, but its tablet is not available. So what we have to resort to is 250 milligram 6 hourly. Fidaxomicin is the other option. Again, it's very expensive and not available. But matrigil as a first-line therapy may not be very effective in our country because of widespread resistance. In patients with fulminant disease, we have to hike up the dose, and there we can combine it with intravenous metronidazole. And for patients who have ileus, we can use rectal therapy. Now, question is, this patient turned out to be C. diff positive and has been on steroids. So what do we do? Do we stop steroids or do we continue steroids? Now it's very difficult to know whether the major part of the disease is by the C. diff or by IBD. That as this patient has a background of IBD and C. diff came later, so we cannot afford to stop steroids. Steroids should be continued. The debate can be about the immunosuppressive, whether immunosuppressive should be initiated if required or not. This immunosuppressive therapy as such is not an absolute contraindication. Depending upon the condition of the patient, we start C. diff treatment, and within a few days, if there's no recovery, we can start immunosuppressive therapy. And this patient was put on intravenous fluids to begin with, and we take care of electrolytes. It's very important to supplement potassium. Daily requirement should be at least 62 millimoles per day. Hemoglobin should be maintained, target should be about 10, and hydrocortisone intravenous is the standard dose. And this patient was put on vancomycin. And two additional things what I've shown here, this patient was given was low molecular weight heparin and the importance of enteral nutrition. Now, this patient has been having a bloody stools, but even then, this patient was put on low dose, low molecular weight heparin. So what is the concept? That IBD as such increases the risk of thrombotic complications. The drugs used for IBD can further modulate the risk of venous thrombosis. So there are studies which have shown that the risk of thrombotic complications in patients with the IBD is 3 times more than the general population. The risk is more during active disease. The risk further rises sixfold further if a patient has acute severe ulcerative colitis and in a hospitalized patients. And the guidelines state that we should put them on thromboprophylactic therapy till the time they are in the hospital. And patients who have additional risk factors for thrombotic complications, they should be continued. Or if a patient has developed thrombotic complications, in that situation also we should continue prophylaxis for a longer time. The other important issue which I mentioned was nutrition. I would like to have an expert opinion from Dr. Vishal again, that how should we nourish these patients? Is our concept changing? And what are the ways of improving the nutritional status in these patients? As I mentioned earlier, that nutrition screening and assessment should be done for patients with severe disease. Dr. Vishal, please.
I think this is a very important question because this is a neglected area. As sir emphasized earlier, that we must look at the electrolytes because the paradigm right now is enteral nutrition. So there are 3 randomized trials which compared bowel rest with TPN with enteral nutrition, and it was found that enteral nutrition is better than TPN or bowel rest. Now, there was a recent randomized study which was published in APT from All India Institute, which compared exclusive enteral nutrition, where around 62 patients were randomized, and half of them got a peptide-based formulation only for the initial 7 days. And what they found was that numerically, the risk of steroid failure was lower in this particular group, although it did not achieve a statistical significance, but I think there was an 18% difference, and the difference persisted over long term also. So this means that if we were to translate into clinical practice, that first of all, there is no role for nil per oral. People have to be on enteral nutrition. And if you want to improve steroid response rates, exclusive enteral nutrition could be one strategy. I think we need more evidence for that, but I think for a resource limited setting where the biologics can be costly, I think we want to improve the steroid response rates, and this could be one potential strategy in these patients. One caveat is that many of the patients who come to us, they have been kept nil per oral on IV fluids. They have not been, getting calories. So they would be at a risk for a refeeding syndrome. Very important to correct electrolytes before we embark on, giving the adequate calories.
Yes, I think it's very important message is that enteral nutrition is very important. I'm saying underlying enteral nutrition. The only indication of TPN in such patients will be if a patient has an IDS. And as Dr. Vishal mentioned about the refeeding syndrome, I think phosphorus is a test which we should incorporate in these patients to know whether a patient is likely to develop refeeding syndrome. If a patient has low phosphorus, has low potassium, and has low magnesium, the risk of refeeding syndrome is high in these patients. Now, this risk can happen if a patient has been nil orally for 2 or 3 days or more than 3 days. So, as we've been discussing, that nutritional assessment is important. And the coming to the study, Dr. Vishal referred to a study from AIMS in which they compared enteral nutrition EEN formula feed for 7 days with the standard of care, and they found that these patients they do better, albumin status is better, the stay is cut short, though colectomy rate did not differ at 6 months. So as he rightly said, that more data is required, but this is the initial important study. Now we've been saying that what to do for ulcerative colitis. So the other aspect of looking at it is what should not be done in such patients. So let's see what Dr. Atul has to suggest, that what should not be done. Dr. Atul, please.
What is very important here is that the patient, as far as patient is concerned, he says my stools have to be controlled. So there would be a tendency to give anti-motility. So that is the first thing that should not be done. The second is to avoid any kind of painkillers, because that would mask any kind of complication which is can expect. And the third is the antibiotics. Nowadays, they say that there is really no role of antibiotics to be given in such patients of acute severe ulcerative colitis until unless there is evidence of Clostridium difficile infection or any other infection, or we are expecting that the patient is gone into a toxic megacolon or a perforation-like situation.
So can I interrupt here? You see, the typical Western recommendation you go to, they have a problem. There is always a skepticism about antibiotic. Now, are there data from India? How commonly other infections such as Entamoeba histolytica, Shigella, and E. coli can cause exacerbation? And second is, if you have, for benefit of doubt, would you like to give antibiotic? The reason is, if you read Indian consensus of IBD, it recommends antibiotic.
So there are two aspects to it. By and large, a patient who comes to me in the hospital with a setting of acute severe ulcerative colitis, I believe has already been given an oral course of antibiotics, by and large 99.9%. So he would have been given a course of ciprofloxacin, tinidazole, or any combination like that. So from what that point is clear that he would have already been treated for that. As far as treating for acute severe ulcerative colitis is concerned, actually speaking, it is our fear or apprehension which makes us put on patients on antibiotics. In the real sense, the first 72 hours or 96 hours where we are treating, until unless there is real evidence of something like toxic megacolon where we are really worried, maybe actually speaking, it is more for our benefit than for the patient's benefit.
Yes, more for our reassurance. But in case if there is a stool culture positive or something like that,
Yes,
then one
certainly,
can.
certainly.
This is what we generally
we-
said. But we should emphasize that too many antibiotics should be avoided. Now, the other thing what we can avoid is that at this stage, 5-ASA do not have any role. So there could be a remote possibility that paradoxical diarrhea can be precipitated by 5-ASAs. So in such a situation, we should avoid using 5-ASA. And oral iron, because these patients are anemic, so we should not be giving them iron. These are some of the things which can make the matters worse. So coming back to the patient, we do the assessment on day 3. After 72 hours, this patient had persistently increased frequency of stool. CRP on day 5 also remained high, and on day 3 and day 5, both days, it remained high. So coming back to the audience again, I mean, I'm sure that all residents are familiar with the treatment of ulcerative colitis. So which index do they use in a day-to-day practice? Oxford index or our local AIMS index? Anybody among the audience, residents? Somebody from PGI? Before Dr. Usha asks.
I'm from Maine, so we use both of these indices, sir. But fecal calprotectin is rarely available in a time in which we can make a decision. So we often rely on the Oxford Index.
Sorry, so I couldn't hear. You said that you use Ames and Oxford
So
both.
Ames index, the problem is that fecal calprotectin is rarely available within a reasonable time frame. The reports are not available within, say, 24 to 48 hours right now due to the lack of available kits. Oxford index is commonly used right now.
Right, right. So these are the two. Oxford is the most commonly used index. Ames is a recent one. The few points of caution, what we should keep it in mind that when we do calprotectin, we should do fecal calprotectin before we put in a scope. So we should take the sample before we send the patient for sigmoidoscopy. Otherwise, after sigmoidoscopy, we should not be doing calprotectin for 48 hours. And nowadays, POC kits are available which can give immediate results for calprotectin. So this can be a good tool. Now this is again the same. There are other indices like there's a Ho index also, but Oxford is the most widely used. Now we've been talking to gastroenterologist. Dr. Kaman has been silent. He must be feeling that what kind of discussion is going on. So this patient had acute severe ulcerative colitis and found to be C. diff positive, has been on treatment, has not done well. At this stage, Dr. Kamal, your opinion, will you say, yes, it's enough, you want to go for surgery, or you will give a chance to physicians to move on and say, okay, you can try your rescue therapy, then come back to me.
Morning, everyone. Thank you, Dr. Spoot, for the questions. It is an important question. In fact, it is key question. If you can answer that, you'll define the outcome of the patient. But in reality, it is very difficult to answer that questions. Today is the 5th day of corticosteroid. Initially on 3rd day, she showed some improvement in clinical status in the form of stool came down to 9 per day. But today on 5th day, again, it is increasing. CRP is more than 50. She is toxic. So we have to decide whether to go for surgery or we continue with the medical treatment. Steroid is the cornerstone of medical treatment, definitely. And now she has been kind of labeled or diagnosed as a steroid resistant situation. So what is next? Next is we have got second line treatment modalities, which can be better than a steroid in these situations. Or we do surgery. I'm a surgeon. My job is to do surgery. But in these situations, I am really not very keen on doing the surgery in this particular patient right now. Of course, I should not delay my decision of doing surgery also, because management of acute severe ulcerative colitis is time bound. You have to intervene in a timely fashion. You cannot delay it more. In fact, surgery should not be considered as a last resort. It should be done timely. All the evidence has pointed out that surgery should be done within 8 to 10 days. If you delay it, the complications are more. So what I mean to say is, I will have a close collaboration with my gastroenterologist and daily monitoring of the patient, along with this, all the criteria. So I will request them.
Okay, so you will agree
For,
that yes.
yeah,
rescue
next
therapy can be-
escalation of the medical therapy.
Right, thank you.
Yeah.
So Dr. Atul, what medical options are available at this stage as rescue therapy with the new drugs being available? What do you think? What are the newer therapies or what all options do we have?
Biologicals is one, cyclosporin is second, and around the corner, tofacitinib is being reported in case reports and case series as of now. So option, really speaking, is between these three. although we don't have much data on tofacitinib, but steroids, cyclosporin and infliximab probably are the two which should be mainly considered.
Right, right. Thank you. So rightly mentioned that two main important drugs which have been time tested, cyclosporin and infliximab have been the drugs. And there is some data about the TAC and tofacitinib. This is the hot debate nowadays, whether tofacitinib, what should be the place of tofacitinib in the therapeutic armamentarium of ulcerative colitis, and of course surgery. Now coming to cyclosporin, the action is fast. The dose now 2 milligram per kg is accepted. And the caution what we should know for the residents is that we should use it in a glass bottle, and monitoring of the blood levels is important. And we should be looking for adverse effects, hypertension or renal toxicity, neurotoxicity. These are some of the important side effects. And remember that cyclosporin maximum what has been used is for 3 to 6 months. We have to bridge it to either immunosuppressive therapy or other drugs. Like there have been some studies in which they have combined with Vido, because Vido's action is slow. The cyclosporin acts fast. So we can combine cyclosporin with other drugs, though the data is very, very limited. I think there's no doubt about the efficacy of infliximab in this state. Now, comparison between the two, cyclosporin and infliximab, there have been two important landmark studies, CICEP study and construct trial. Both have shown that the colectomy, the colectomy rate is more or less the same between the two. If we use either cyclosporin or we use infliximab, we can save more than 50% of the patients from colectomy. Now, if the two drugs have equal efficacy, almost same percentage of adverse effects, the question becomes how to choose between the two. So going back to Dr. Vishal for comments, I will request them to be brief because time is running out. Between the two drugs, how will we choose which one to use?
So both of these are, as pointed out, equally efficacious. So largely it is the patient profile and the risk of adverse effects which define our choice of a particular agent. Now, if individuals have already been on thiopurine in adequate doses, that's a relative contraindication for cyclosporin because first of all, the responses are poorer. And secondly, you need to shift them to add thiopurine as a maintenance. And if there has been, it's a thiopurine refractory disease, it may not be a very good choice in that setting. Second is, of course, the risk of adverse effects. The problem is that cyclosporin, there are a large number of adverse effects, and that has created a fear about this drug in the general community. Now, the important thing is that most of the adverse effects, and especially the serious adverse effects, have been noted with the 4 milligram per kilogram dose, including, the risk of seizures with, low cholesterol. And these have been pointed out again and again. I must point out that if you look at the series which talk about the adverse effects, the dose used largely has been 4 milligram, whereas for acute severe 2 milligram per kilogram works very well. And we have been using this drug, even in low cholesterol situations. Infliximab, what are the patients where you would not want to use infliximab is, where you expect that the response is less likely. So that's the situation where you have a very high CRP, that is a lot of inflammatory burden is there, and a low albumin, which means that there is a GI sink and likely a loss of infliximab through the GI tract. So in these individuals, you would either not use infliximab or use maybe an intensified regimen with a higher dose. So these, and of course, risk of infection is there with both of these. So although the Western literature and evidence tends to, suggest that infliximab is the drug, I think in India, especially with cost issues, cyclosporin is a very, very important drug for, treating acute severe colitis in steroid refractory cases.
Yeah, thank you. I mean, both the trials showed equal efficacy, and then they evaluated the patient's preference and the physician's preference, and the both were in favor of infliximab. And what I have an impression that all of us are using more infliximab than cyclosporin, though we know that cyclosporin's efficacy is good. But as Dr. Vishal had mentioned, that patients who are already on azathioprine, there we should not be using cyclosporin. Now, the RCTs have shown there is no difference. The efficacy is the same. The advantage of cyclosporin could be it has a shorter half-life. It's in hours, while infliximab has it in weeks. So if a patient has to go for surgery, cyclosporin is more likely to get cleared off from the blood faster as compared to infliximab. Now, if we use infliximab and patient has very low albumin and has profuse diarrhea, I mean, there is a loss of the drug in the stools. There we have to either intensify the dose or increase the dose. So what I mean by intensified treatment is that the standard treatment has been to use infliximab at 0, 2, and 6 weeks. While in such a patient who's sick, we can give all 3 doses in first 3 weeks. So it could be either 0, 3, and 20, or 0, 1, and 20. Or we can go up to 10 milligram per kg. So these are the 2 ways to have better results.
Dr. Sood, shall we ask the residents? Any of them wants to make some comments
Yeah,
regarding to this?
there are questions for them. Yeah,
We should involve
thought
them.
I'll just go through and then give 2 minutes for them in the end also. So this is a trial by us and AIMS together. In acute severe ulcerative colitis patients, where we could achieve remission with infliximab, we used azathioprine simultaneously, and we found that good number of patients where we can't put them on maintenance therapy with infliximab, and patients on combination of 5 ASA and azathioprine, they also do fairly well. The 2 important messages out of the study are that patients who are not affording maintenance with infliximab should be given a combination therapy, and relapses do happen in such cases. But the subsequent relapses may not be steroid refractory as the initial case has been. Tofacitinib, there are case series and case reports where tofa's role has been shown in patients with acute severe ulcerative colitis. TAC also, there is a data that it may do better, but the data for TAC is in patients with moderately severe disease rather than acute severe ulcerative colitis. So sequential therapy can be tried, cyclosporin and infliximab, one after the other, but I'm not very much for this because in our country, the risk of infections is very high. So if we give too many drugs, the immunosuppression is really very profound and the risk of infection is very substantial. So just one liner that where should we not offer rescue therapy? That patients who have diarrhea, who have bleeding per rectum with the stools, they are inflammatory diarrhea. They are the kind of patients who are likely to respond to drugs. While if you have a patient who's just got exsanguinating hemorrhage, who's just pouring out blood, he is not the kind of patient who's likely to respond to rescue therapy. We should not try or waste time on a rescue therapy for a patient like this. So coming to the questions for the audience again, that what is their experience on tofacitinib, because this is a new drug and everybody wants to use it more and more. Anybody among the residents would like to give opinion that whether tofacitinib should be used in acute severe ulcerative colitis, and if yes, what should be the dosage? Anybody among the audience?
Before that, can I ask Kiko? Yeah, I think Dr. Sood pointed out very well, and Vishal said, is very common marker we can use is CA. That is, you do a CRP albumin ratio, and you do it at the beginning. It's so easy. You get the patient admitted and do it stat and get the report in 2 hours, and you follow that. And most of the world are doing that, and they are really avoiding the Oxford criteria. Now, Oxford criteria was made when there was no biological. So Oxford criteria is going down, and you don't follow that most of the places now. And look at CAR, and you do a CAR on day 3. The CRP albumin ratio, if it is less than 0.6, your patient is responding. And if a patient is not responding, you go to interferon, as you said very well, that you do it at 0 and 3, and then you go the second dose. So that's very important changes which has come over last few years, as Vishal has doubt. And in that case, you will decide whether your accelerated interferon will give you a response or there's no response, and hand over the case to Dr. Kaman at the earliest. Otherwise, we will be landing into soup. Now, about the tofacitinib, as the residents are not asking anything or passing a comment, yesterday we talked about a lot of guidelines. Guidelines are given, guidelines we followed in all cases. Now, TOFA is always the first line. When you fail your biologicals, TOFA is a guideline. But I always pass, sorry, sounding much? Yeah, we always think that TOFA, you fail biologicals and you give TOFA. But in a country like ours, I think there are situations where these are the patients who cannot afford a biologicals. I'll straightaway try and rule out the few complications by doing tests and then start TOFA on day one. And TOFA is being in Western world is given on OPD therapy. So I think this a lot of discussion on TOFA is required, Dr. Sood. Dr. Sood was my, fortunately, my senior resident, and Uday was my batchmate.
Thank you.
PGI.
I think the time is up, but we have to move on. Goshal has, Kinsuk has raised this issue about the TOFA, and is rightly mentioned about the index. The only problem with the CRP is not high in all patients with ulcerative colitis. So there are some patients who just have a normal CRP with a very severe disease. So
Dr.
those,
Sood, will they give us some more time? How many more minutes? Shall we ask for 5 more minutes?
I think 5 minutes we have to wind
Okay.
up. So the TOFA's dose is, normally we use 10 milligram twice a day. For acute severe ulcerative colitis, we use it 10 milligram 3 times a day for 7 days. Then we have to reduce it to 10 milligram twice a day. So this patient, we put her on infliximab 10 milligram per kg infusion, and azathioprine was added. She didn't respond by day 5, so she was taken up for surgery. And coming back to Dr. Kaman again, he was hinting that this patient may not respond. So if you go back to this patient, the important messages were that when we were looking at the true Lovitz criteria, this patient had 3 variables which were indicative of a severe disease: tachycardia, low hemoglobin, and high CRP. And patients who got 3 markers, they have a 70–80% chances that patient will require surgery. So, and day 4, I mean, the true Lovitz, this Oxford score, again, after 3 days of steroids, predicted that this patient got severe disease. Endoscopy, if we look at Mayo's endoscopy, you see EA score was 6. So there were pointers that this patient has severe disease and the chances of requirement of surgery are very high. Dr. Kaman, please, what is your policy on this patient? Luckily was not on infliximab for a long time. She just received 1 dose. Now, what is your opinion that patients who are on infliximab for a long time or cyclosporine for a long time, what are the response rates? So what are the problems which can come up in those patients compared to patients who are relatively not exposed to these drugs?
Yeah. Okay. So lack of time, I'll be point blank and will very short. I'll not go into the nitty-gritties. Yeah, the first question is EPA upfront or stage surgery. EPA means ileal pause anal anastomosis. It is a very complex surgery. The patient, this index patients, you can see, she's sick, she's toxic. In that situation, an emergency situation. Already she had all the immunocompromised drugs, corticosteroid for a long time. So in this situation, I will do a stage surgery, definitely. It will not be a definitive surgery. I will do a subtotal colectomy and I will manage the distal stum the way mucous fistula or a closure. Then do an ileostomy. Then I will wait maybe for 4 to 6 weeks or 6 to 8 weeks. That is the thing. So coming to the second question, laparoscopic or open. Laparoscopy today is a reasonable alternative to the open surgery, but it should not be taken on face value. Most of this, reports coming from laparoscopics are biased in the sense they have come from a high volume, very technically efficient centers who are doing frequently kind of surgeries. But in most of the centers, it is not being done.
Right.
Yeah.
But in
yeah.
Yeah.
So open is still the gold standard for doing this kind of surgery. But yes, laparoscopy has got equal, outcomes has been
Right, right.
there.
In yeah, if I can, sorry.
Coming to
in a
the
young
positioning
girl-
of the ileorectal anastomosis, I'm sorry. Yeah.
in a young girl. if
Oh,
you
yeah,
do
that
pelvic-
is another important thing. I was coming there. She is only 21 years old. That has to be taken into consideration. And her disease duration is only 1 year. So she is expected to have a kind of, familial infertility and sexual dysfunction issues if we do this EPA procedures, because the pelvic dissection will destroy the autonomic nervous systems. And there has been the evidence is showing that up to 30 to 50% female especially will have sexual dysfunction and infertility. So that has to be also discussed. That has to be counseled to the patients. Then the third questions will come there, like ileorectal anastomosis. That is still a good option, particularly in young patients, if you are keeping in mind that her future fertility and pregnancies are concerned, I think.
Right, right. Thank you. So in a young girl, I mean, these issues, infertility issue has to be kept in mind, and their laparoscopic surgery may have an advantage over open surgery, or we delay stroma formation, or we delay a pouch formation later on. Thank you very much. I think we have to stop. If I have to just give a carry home message in 2 or 3 lines, I would like to share with the residents that in a patient with acute severe ulcerative colitis, we should keep it in mind that after the initial basic workup, the important issues are thromboprophylaxis, nutrition, and rule out infections. And a timely surgery is required in such patients. Thank you very much. Thank you.
Okay, I think before we finish, me as a pathologist, I felt that pathology has been totally excluded, Dr. Sood. In routine practice, I think you should not practice that. I
No,
will
no, no,
advise
no.
you should all the time have a biopsy, because we know that CMV is one important cause for relapse, and CMV till the time, serology may be negative, but the CMV infection in such case is localized. So serology would never be positive.
Very right.
So
It
I
is-
think, and that is one aspect. Another aspect is 21 years old. In 1 year, going into toxic megacolon, one has to be very, very careful. I think the biopsy proving is very, very
No,
important.
no, very
May
right.
not be even ulcerative colitis.
No, 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 ma'am.
May not be even ulcerative colitis. You have to have a relook to your case if it is really genuinely a good case.
No, no, absolutely right. When we
Yeah.
do sigmoido, we always do biopsy. And in main, one of the two reasons for doing a sigmoido. One is to confirm active disease. Second is to rule out infections like CMV. It's a routine. We look
Yeah.
for CMV inclusion bodies, and we do IHC. Thank you for
Yeah, I
addition.
think,
Just because of lack of time.
Yeah,
So
I think
because-
the take home is ulcerative colitis should never be made in first go, especially in a developing country like ours, where we have to consider so many other conditions.
Yeah, yeah, I think
Chronic
that
and
was not the-
biopsy, Dr. Sood, let me complete, please. A biopsy is never diagnosed for ulcerative colitis, and a biopsy, what you have is chronic active colitis, right? That can be seen in many other conditions, including tuberculosis without the granulomas and ischemic and other vasculitic disorders. Yeah, I think one should never just get carried away with the clinical presentation. Take a biopsy, try and prove. This is a teaching for the residents, right? And don't get carried away. Just, your pathology is giving you a diagnosis of ulcerative colitis and a sigmoidoscopy biopsy. You have to consider many other conditions. And according to me, I have done this for the last 40 years, more than 40 years. You should never make a diagnosis of ulcerative colitis from a given biopsy. Dr. Gosal?
Thank
yeah.
you so much. I think because of shortage of time, we'll go to the next lectures. I thank Dr. Sood for the presentation and for the panelists for active discussion. I thank the audience for their participation. We expected more interaction, but let us expect that in the next session. Thank you so much. Yeah, so we saw that an acute ulcerative colitis was being managed. Unfortunately, that patient required surgery. But obviously, if she did not require surgery, you have to maintain the remission after achieving the remission. So we have a short talk of 15 minutes by Dr. Saurabh Kedia on maintaining remission after an acute episode of ulcerative colitis. Dr. Saurabh Kedia is a very active worker in IBD, an upcoming star from All India Institute of Medical Science.
Thank you, sir. Good morning, everyone. I would like to thank Dr. Usha ma'am for this opportunity. So,
I think we'll ask the panelists back on the stage. Actually, you should have been, yeah, given it, at least keep it on the table, the schedules. Yeah. Please call the panelists back on the, all of you back on the stage. Come, come. Yeah, please go ahead. Thank you. Sorry to disturb.
thank you, ma'am. Yeah, so till now we have learned that what is ASUC. It's a medical emergency requiring hospitalization and time-bound management, and the algorithm for managing ASUC. So at day 3, we use the Oxford criteria to predict response, and then at day 5 to day 7, we decide whether the patient responded or not. And patient who has responded to IV steroids is switched to oral steroids, and patients who don't respond are either advised medical rescue therapy or colectomy. The rescue therapy being infliximab, cyclosporin, tacrolimus, or ruxolitinib. So in the next 10 to 15 minutes, we would like to discuss about how do we manage the patients who have survived the initial index episode without colectomy. So how do we maintain these patients? So what would be the goals of long-term maintenance in these patients? Avoidance of colectomy is the most important goal. It has been discussed in most of the studies. Additionally, we would like to prevent relapse, avoid steroid use in the long term, improve the quality of life, reduce the risk of colorectal cancer, and reduce the risk of adverse events such as infections and malignancy. How do we achieve these goals? Before understanding this, we need to know about the natural history of ASUC after the index hospitalization. This can be related to patients who have responded to the steroids initially, or to the patients who did not respond to steroids but responded to the rescue therapy. We would like to know the risk of further episodes of ASUC in these patients, the long-term risk of colectomy, long-term hospitalization, the steroid use, and the adverse events. And we would also like to know what are the predictors of these long-term outcomes and what is the impact of maintenance treatment on these long-term outcomes. So if we look at the long-term history or the natural history in patients who have responded to steroids, so this was a very old study which included patients admitted between 1975 and 1982, prior to the immunosuppressive era. 61 patients of ASUC, about 50% had colectomy in the initial episode, and 1/3 had colectomy in the long term. And about 2/3 of patients underwent colectomy after the index hospitalization. This was there when there were no immunosuppressives and no pyrotics. So a very poor long-term outcome with patients with ASUC. Then we have the Oxford cohort, the landmark Oxford trial, which defined the Oxford criteria for predicting remission. When this cohort was followed in the long term, 49 patients were there in the initial study, of which 14 underwent colectomy. So 32 patients were then followed up for the median follow-up of 120 months. And of this, 50% patients underwent colectomy with an overall colectomy rate again of 65%. In this cohort also, the immunosuppressants were used only in less than 50% of patients. We then had the further follow-up from this Oxford cohort with about 186 patients, which defined that about 1/4 of patients overall with ulcerative colitis do develop ASUC in their disease course, of which 1/3 present in the first ind or index episode. Importantly, 1/3 of patients who have ASUC are likely to develop another episode of ASUC, and the repeat episodes of AUC further graven the prognosis as compared to 20% index colectomy, the colectomy rate increases to 50% after the second episode. What about Asia? So we have 2 studies from Asia, one from India. From 2003 to 13, we had 179 patients, of which 19 had the index colectomy, 160 who survived the colectomy, 1/4 over the next 4 years underwent colectomy, 41% patients were steroid dependent, and like the Oxford cohort again, 1/3 patients had repeat ASUC. Similar data from the Korean study of 100 patients, about 15% initially had initial colectomy, And again, about 15 to 20% patients had colectomy over the next 10 years. So what do we learn from these studies? That the long-term course of ACOC, even after steroid response, is not benign. Overall colectomy rate in ACOC at long term is about 20 to 60%. The rates are declining over the time because of improvement in the medical management. Even after response, the long-term colectomy rates ranges from 16 to 20 to 30%. Up to 2,000 patients will relapse. 1/3 will have a repeat episode of ACOC, and the colectomy chances increases in the repeat episodes, and 40% patients will become steroid dependent. So we can say that an episode of ACOC redefines the natural history in a patient of ulcerative colitis. Now, what are the predictors of these outcomes? If we look at all these cohorts, the Ames, Korean, Oxford, or the recent French cohort, they have clearly shown that the early response, that is day 5 to day 7 response, predicts the long-term outcomes. And there are favorable outcomes in patients who have complete response. So complete response has been defined as stool frequency of less than 3 with no blood in the stool. So there is lower colectomy in this group of patients, lower hospitalization and lower ACOC episodes, lower steroid dependence, and longer time to relapse. So the short-term response is the most important predictor of long-term outcome in this group of patients. What are the other predictors? We again look at the Ames cohort. Then through a machine learning algorithm, it was defined that in addition to the short-term response at day 7, presence of extraintestinal manifestations, past history of steroid use, and longer disease duration at ACOC were predictors of poor outcomes. If we look at other studies, then again the markers of disease severity, such as past anti-TNF use and endoscopic severity at admission, were again predictors of poor outcomes. Interestingly, both from the Ames cohort and in the other cohorts, the disease extent and index of hospitalization does not determine the outcome, and both patients with left-sided as well as extensive colitis have similar outcome. So it is the quantum of inflammation or the severity of inflammation which determines or decides the outcomes, and the extent of disease doesn't play a major role in these patients. Now, what is the impact of maintenance treatment? So if you look at the earlier Swedish cohort, which we had discussed just now, where no immunomodulators were used, there were about 65% overall colectomy. If you look at the Oxford cohort, about 50% patients received azathioprine. However, in this cohort, what the authors showed was that the patients who received azathioprine had a higher relapse as compared to those who didn't. But both complete as well as incomplete responders had similar outcomes. They had received azathioprine. So what the authors concluded was that azathioprine probably improved the outcome in patients who were incomplete responders and brought them to have similar outcomes as compared to the complete responders. Similarly, if we look at the Ames cohort, again, as a use was similar between patients with and without colectomy long term. But again, if we compare with the Oxford cohort, azathioprine could have improved the outcomes in the complete responders. Then there are two recent studies which have compared the long-term outcome in patients who received azathioprine versus those who didn't. So this was a study from France of 152 steroid responders, of which 100 were naive and 42 had experienced immunomodulators in the past. Overall, 2/3 had a relapse in the long term, 10% had colectomy. But if when comparing the patients who received only 5-ASA, patients who received azathioprine, and patients who received anti-TNF, it was shown that the 5-ASA group had the highest relapse rates, the azathioprine group had the intermediate relapse rates, and the anti-TNF group had the lowest relapse rates. So azathioprine does play a role in reducing the relapse rates in these patients as compared to the 5-ASA alone. However, its equivalence or superiority as compared to anti-TNF cannot still be determined because we have only few or short data with lower number of patients. Then this study from Boston, again 185 patients, of which 133 survived the initial episode, 10% underwent colectomy, and in this cohort, 46 were initiated on azathioprine and 77 maintained only on 5-ASA. Unlike the previous study, this study showed that the time to colectomy following hospitalization or the colectomy-free survival was similar in the two groups. So azathioprine did not improve the outcomes, but in this study, patients who were in the azathioprine group had a higher CRP as compared to patients who were in the AS5-ASA group, again indicating that patients who had more severe disease, azathioprine was given, and azathioprine did have some effect in improving their long-term outcomes. What is the effect of nutrition? Dr. Sood had already talked about the EN trial from Ames, And in this trial, in the patients who had the follow-up for more than 6 months, it was seen that the long-term outcomes in the form of colectomy or repeat hospitalization were lower in the EN group as compared to the standard of care group. But again, this was data from the single center, and more data is required before we can recommend, or we can say that the exclusive interleukin also improves the long-term outcome of these patients. What do the guidelines say? The ECO guidelines say that in patients who are immunomodulator naive, after they improve with the steroids, should be maintained with azathioprine. And in patients who have been immunomodulator refractory or intolerant, should be maintained with biologics. There are issues which are still unclear, which include is that do all patients with ASUC who improved after steroids be escalated to infliximab? We don't have the answer as of yet, but an active trial, which is a multi-center European trial, which is comparing infliximab versus thiopurine in this group of patients, may provide us the answer. And what is the role of adjunctive therapies like diet, nutrition, or microbiome manipulation in this setting still remains to be answered. So to summarize, patients with acute severe colitis, even after steroid response, have aggressive long-term disease course. Early steroid response is the most important predictor of long-term outcomes. All these patients should be maintained with thiopurines as they improve their outcomes. The role of anti-TNF is unclear in this setting. Now, coming on to the patients who don't respond to IV steroids, who are given rescue therapy and who respond to the rescue therapy. The two most common rescue therapies are infliximab and cyclosporine. Before we compare or look at the data of infliximab and cyclosporine, one question which arises is, do the patients who respond to steroids and do the patients who respond to rescue therapy, after response, do they have a similar outcome or they have a different outcome? This question was answered in this recent European study, wherein they looked at the long-term outcomes of acute severe colitis in the rescue therapy era. So there were around 300 patients who avoided early colectomy, of which 200 were steroid responders, about 130 improved after the rescue therapy. So over about 44 months of follow-up, it was shown that the long-term risk of colectomy was lower in the patients who had responded to steroids versus those who had responded to rescue therapy. So rescue therapy does improve the short-term outcome of these patients, but its impact on the long-term outcomes as compared to the patients who had responded to steroids may be not as good. Now, what about the comparison of infliximab and cyclosporine? Now, we have already learned that short-term response to these agents is similar. There is no difference in the colectomy rates at short-term between patients who receive infliximab versus patients who receive cyclosporine. This meta-analysis looked at the long-term outcomes in these patients. More than 1,600 patients, 3 RCTs and 12 cohort studies. Patients in cyclosporine were maintained with azathioprine. Patients who received infliximab, some were maintained with azathioprine and some were maintained with both infliximab and azathioprine. The result from this meta-analysis said that amongst all the studies, till 3 years, the colectomy rates were higher in the cyclosporine group as compared to the infliximab group, but there were similar outcomes after 3 years. However, on subgroup analysis, in the RCTs, there was no difference. The difference was only in the observational studies. And importantly, the adverse events and mortality was seen in both the groups. So in the long term also, both cyclosporine and infliximab fared equally. However, and similarly, if we look at the long-term follow-up of the CISIF trial, the landmark trial, which compared cyclosporine and infliximab, so there was 6.5 years of median follow-up. And again, the overall colectomy rate in both the groups till 7 years was similar, highlighting the fact again that cyclosporine and infliximab have equal long-term response rates. But if we look at the further results of this long-term outcome of the CISIF trial, then we see that within first year of cyclosporine use, there were 70% failures, and 50% patients who received cyclosporine initially and had responded required infliximab to maintain their remission. Only 50% patients maintained on thiopurine alone. And if we compare the long-term outcomes with regard to the additional drug use, then it was significantly lower with infliximab as compared to cyclosporine, indicating that infliximab may have a better long-term outcome with cyclosporine. Again, this was again a post-hoc analysis of the same CISIF trial, where they look at the endoscopic remission. So we all know that mucosal healing improves the long-term outcomes in patients with ulcerative colitis. So in this study, they looked at the endoscopic remission rates at day 98, that is at 3 months, and they showed that the endoscopic remission was significantly higher with infliximab as compared to cyclosporine at 3 months, which could explain the higher requirement of drugs and higher requirement of infliximab in the cyclosporine group. So mucosal healing at 3 months could have led to better long-term outcome with infliximab. What are the predictors? As compared to similar to steroids, the disease severity at baseline is the most important predictor of long-term outcomes in the form of higher CRP being a poor predictor, lower albumin being a poor predictor, and endoscopic severity being a poor predictor. And as Vishal had already said, previous non-response to thiopurine has been a poor predictor of response to cyclosporine as well. If you look at the Indian evidence, then a study from Ludhiana of 24 patients with ASUC, of which 19 were followed over 37 months, 2/3 remained collecting free over a follow-up period of about 4 years. So to summarize, long-term outcomes in general are similar between cyclosporine and infliximab. However, infliximab may be better in terms of endoscopic remission and lesser drug requirement, and disease severity is the most important predictor again for these patients in terms of long-term outcomes. So there have been some modifications in the rescue therapy. Do they have any effect on the long-term outcomes? So accelerated infliximab regimen was already discussed in the previous session. Although it improves the collectivity in the short term, but in this retrospective study and meta-analysis, both in the study as well as in the meta-analysis, the long-term collectivity rates between the standard and the accelerated infliximab regimen was similar. The another concept is the cyclosporine bridge followed by biologics. So induction with cyclosporine followed by maintenance with either pembrolizumab or estacoimab. Dr. Sood had already talked about this concept. So data is building up, but there has been reasonable, or I may say reasonably good persistence, steroid-free remission, and collective survival over 2 years in patients who were induced with cyclosporine and treated with pembrolizumab. So this could be an option in patients who are thiopurine non-responders and have contraindication to infliximab. The medical study was already talked about. The strategy in low resource countries like India, wherein patients who are steroid refractory are induced with infliximab and then maintained with azathioprine. Up to 1/3 patients will maintain remission over 6 years, and this is much cheaper as compared to maintenance with infliximab. About the other two strategies, Dr. Sood has already talked about tacrolimus and tofacitinib. The long-term data is still building up for these studies, especially for tofacitinib, and we may have answer in the near future. So to summarize, for long-term maintenance in patients with acute severe ulcerative colitis, for patients who are steroid responsive, should be maintained with azathioprine. Biologics in patients who are intolerant or not responders to azathioprine. In patients who improve after medical rescue therapy, for patients who improve with cyclosporine, should be maintained with azathioprine. Vedolizumab may be an option in intolerant or refractory azathioprine patients. For infliximab, scheduled maintenance therapy with azathioprine for initial 6 to 12 months. Tacrolimus maintained with tacrolimus, and for tofacitinib should be maintained with tofacitinib. Our long-term data are still available. Thank you.
Thank you, Dr. Saurabh. So as you saw in the first patient, there was C. difficile. So infection is an important cause of flare of ulcerative colitis. So we'll learn from Dr. Amit Datta, Professor, Department of Gastroenterology, CMC, Vellore, what are the data on infection as a flare for inflammatory bowel disease. And the question will be at the end. Dr. Saurabh, you can join us.
Good morning and thank you, chairpersons. First of all, I thank the organizing committee and Professor Usha Datta for inviting me for this meeting. So the topic of my presentation is infection or IBD flare. So essentially, I'm going to discuss two scenarios in my presentation. You have a patient who comes to you with blood mixed stool. So there will be two settings. One is that this is the first presentation. He doesn't have any background history of IBD. And second is the patient is known case of IBD. So when somebody comes with first presentation, as Dr. Kim was pointing, there's so many other causes of blood mixed stool. So we have to differentiate that from an IBD. And somebody who comes with IBD already, what is the role infection is playing in the flare? That's the second scenario. So if you look at the acute infectious colitis in terms of etiology, the number of conditions which can cause this is quite big. Obviously, the most common being the infections, which can be bacterial like E. coli, Salmonella, Shigella, etc. The parasitic infection like Entamoeba, virus of which CMV is an important one, and sexually transmitted infections. So the long list of infections which can cause that syndrome. It can be the first presentation of IBD, and also things like drugs, ischemia, diverticulitis, radiation, GV, all of them can actually cause a similar. So situations like GVHD, radiation, etc., you'll have a setting and you'll know the probable diagnosis. The main difficulty lies in differentiating the IBD initial presentation with infection And that's what we're going to discuss in this subsequent part of this presentation. So we have to have a stepwise approach because every patient does not require all the investigations actually. So you always begin with a good clinical assessment, go on to the investigations of which stool test is very important. And in many patients, you may not have to go beyond that. And patients where they are not responding or diagnosis is not very clear, there you may have to go for a sigmoidoscopy and imaging. So we begin with the clinical assessment, which means a good history and examination. And that again include details of symptoms, the nature of symptoms, severity of symptoms, fever, previous history of known case of IBD. Medications again very important. You know, antibiotics can cause predisposed C. diff infection. Chemotherapy, nowadays we hear about the immune checkpoint inhibitors, which can cause colitis like an IBD, comorbid illness, then risk factors for infection like travel history, contact, food consumption, etc. And also a good examination, both systemic and general examination. And abdomen, you should specifically look for any tenderness or any guarding, bowel sounds, etc. Because that will tell you whether we should do imaging in that patient. So history obviously is not going to be very accurate in differentiating your acute infectious colitis from an IBD, but there are pointers in history which can tell you which may be more likely. So for example, in acute infectious colitis, most patients will probably come within 1 week of onset of symptoms. About 80% come within 1 week, whereas in IBD, about 40% come in 1 week and the rest will come a bit later. Other very important point, fever is an early symptom in acute infectious colitis. They may have fever right at the beginning or initial, whereas in IBD, fever may come a bit later. And also if you ask history in a bit more detail, some of the IBD patients may tell you that before the blood mixed stool happened, they had some change in the bowel pattern. They were generally feeling a bit unwell. So that may be a pointer as well. And obviously we have this extra intestinal manifestations like erythema nodosum, eye signs, etc. Now here are the joint symptoms may not be very helpful because they may be present in both infectious as well as IBD, but other things may help. So definitely a good clinical assessment gives you some idea about what is the likely thing. So once you have done this bit, then you go to the investigations. And as I said, that for investigations, the most important are the stool tests. And what we normally send is we send a microscopy, we send a culture. In microscopy, we're looking for interamoeba, strongyloids, etc. Culture, again, some organisms can grow in a routine culture. Some organisms will require a specialized culture media. And also the yield of culture is about 60%, it's not 100%. But these are the two common things we do. Then there are other tests, like for C. diff, you have to send the toxin, which was discussed in the panel discussion. Then there are ELISA-based tests also available. So the issue with the culture-based test is that they take time for the results to come. They don't show 100% sort of a positivity rate. And therefore, this non-culture method, the PCR method is actually gaining more and more popularity. And we have a multiplex PCR, which can give you a result very quickly. And in the same panel, you can get idea about the bacterial, the viral, parasitic infection in the similar panel. So you can get quicker results on more diverse organisms. You don't have to have separate culture for each. And results have shown that, studies have shown that it picks up about 30 to 35% more organism than water culture. So therefore, it's more sensitive. And there are commercial panels. This is the landmark study which was published in Lancet. This is the GEMS case control study, where they showed that for diarrheal illnesses, the multiplex PCR had a much better yield than your culture-based techniques. So obviously, when they have applied this in patients with acute colitis, what they have found is that with the help of this, because you're knowing the microbial, the organism responsible for symptoms, it has reduced the needs for further investigation like imaging or endoscopy or even the use of antibiotics. But again, this also has its limitations. One is that it may not be able to differentiate a colonizer from a pathogen, and this is true especially for a C. diff or a CMV. For cytomegalovirus, it's present as a commensal. C. diff also, so that's one limitation. And second is we can't do any direct antibiotics. We can do genetic marker for susceptibility, but we can't do a direct antibiotic susceptibility. So apart from the stool test, we do some tests to assess patient's general condition like blood counts, creat, electrolyte, CRP to look at the severity of inflammation, abdomen X-ray, patient has abdominal pain, there is guarding, we need the imaging. Fecal calprotectin not required in all the cases, but in patients where the symptoms are persisting, you may have to do this particular investigation. So based on this stool investigations and simple investigations, in most patients, we will have an answer about the infection based on the microbiological test. There are other pointers as well, which help you differentiate the two. So for example, anemia is less common in somebody with the first presentation with infectious colitis, whereas an IBD patient with first presentation, about 25% of patients may have anemia. Fecal calpro obviously elevated in both, but studies have shown that usually in infection, the calpro tends to be less than 600, but it's higher in patients with IBD. And so these are the main ways to differentiate. So by the time you do the stool test, blood test, you'll have an answer in significant number of patients. Many of the patients with infectious colitis actually improve within a week. So you don't have to go any further. But in some patients, you'll have to proceed because the symptoms are persisting. You don't know what the diagnosis is. And there you require imaging and endoscopy. Now, should you do imaging in all the patients? So the answer is not very easy for this, but essentially if the benefit is imaging gives you idea about the entire abdomen. Because in this patient, you cannot do a complete colonoscopy, so you will only be able to examine the rectum. Whereas imaging gives you the entire abdomen idea. So if somebody has got like abdominal pain, significant tenderness, guarding, those patients you need an imaging, because it can tell you the extent of disease. And imaging has other benefits also as well. Like, so it has, there are features I'll be showing in subsequent slide, which can tell you whether it's IBD versus infection. And things like ischemic colitis, diverticulitis can be easily diagnosed on a imaging. So there are few studies which have looked at how imaging can distinguish an acute presentation of IBD from an infectious colitis. So in infectious colitis, you seldom see enlarged lymph nodes. There is no fat stranding. There is no foam sign. And often there is an observation called empty colon. You don't see any stool in the colon. Whereas in IBD, you may have enlarged lymph nodes. They may be fat stranding. There may be prominence of vessels. So this is a picture again where you see that there is a thickened bowel wall. But again, the patient does not have, there's no other feature apart from bowel wall of infectious colitis. But here, if you see, there's a thickening of bowel wall, but there is a prominent blood vessels. There is a stranding of fat. This is an example of infectious colitis. Now, obviously, imaging can tell you some suggestive findings, but to make the final diagnosis, I think the key investigation here is actually histopathology. And for histopathology, you need to obviously do endoscopy. Now, these patients, you can't do a complete colonoscopy. There's a high risk of perforation. So what we do is an unprepared sigmoidoscopy. So these are the patients where you have not had an answer, symptoms are persisting. There's no, the microbiological tests have been negative. So you go for unprepared proctosigmoidoscopy. And when you do the sigmoidoscopy, you take a biopsy, which has to be sent for histopathology. And also we take a sample for CMV tissue, PCR. This is just endoscopic appearance of a patient who has colitis, ulcerative colitis, and the finding in the rectum. So histopathology, as I told you, is something, obviously the diagnosis rests on the clinical as well as the blood and all the endoscopy histopathological findings. But histopathology has a very important role. There are features which can tell you this is more likely to be IBD. So the two important things we see in IBD is there will be architectural distortion of the crypt and the basal plasma cytosis. Whereas in the infectious colitis, there may not be architectural distortion and the plasma cells may be more towards the luminal surface. So as you can see in this slide, this is the case. This side on the right hand side, you have ulcerative colitis. The inflammation is supposed to be more denser in a IBD compared to an infection. And also you can see this crypt branching and the distortion of crypt architecture, which is not seen in infectious thing. Then in case sometimes the pathology can give you the direct, you can see trophozoites of amoeba in the case of umbricolitis. This is a volcano-like lesion in pseudomembranous colitis. Then in ischemia, you'll see this hyalinization and hemorrhage in the lamina propria. CMV, the inclusion bodies will be noted in patients who have CMV infection. Obviously, CMV is much better appreciated on immunohistochemistry than a pathology. So obviously, because of lack of time, I'm not going to go to the treatment of individual condition. But just to summarize, when somebody comes to you, first time blood mixed stool, you have a big list of differentials. Infections are the most common cause. And you have to have a stepwise approach, starting with good clinical assessment, stool test, few blood tests. Diagnosis not yet clear, symptom persisting, you go for radiology, you go for proctosigmoidoscopy, pathology, and then manage it. That was the first part. Now, a few slides on this patients who are already a known case of IBD, and now they have come to you and they have come to you with a flare. So what is the role of infection in this flare actually? So IBD per se, there is an increased risk of infection. And in cases of flare, about 10 to 15% of patients with IBD have been found to have infection. So therefore, it is essential to look for infection in patients who are having IBD flare. So this is again a systematic review which showed that whether it's ulcerative colitis or Crohn's disease, both of them have a higher risk of infection, any infection or GI infection or viral infection. So this is just look at the data from our own country on infection in patients who come to you with acute colitis with IBD flare. This is a study from PGI by Dr. Rakesh Kochar and team published in 1993. They had 50 patients, 25 active, 25 quiescent disease. They found 2% parasites and more than 30% bacterial infection in this. Then subsequently a study from AIMS which had 49 patients. There were 12% parasitic infections, 8% CMV, 10% herpes simplex. Then from our own center in CMC Vellore, we had a paper in 2013 where there were 87 patients with acute severe colitis. 10% had parasitic infection, 2% had CMV, and 3.4% had C. difficile. And the study from our center in PGI showed that these infections were associated with the active disease and with worse outcome. This was not seen in the AIMS data. There's one more study from Lucknow, which had looked only at the CMV in 63 patients, and actually 16% of them roughly had a CMV infection, which was also linked with higher rate of surgery and mortality. And not only are studies from India, but even studies from West have shown that patients with IBD, when they come with flare, a significant proportion will have infection. So what is clear from this data from our country and from other parts is that when somebody with IBD comes with a flare, a significant proportion of infection, as was discussed rightly in the panel discussion which we had, and it has an impact on outcome. And because these patients are going to go on steroid therapy, immunosuppressant therapy, it's very important that we look for infection in every case of IBD which comes. So again, I want to re-emphasize, anybody with IBD, it comes with a flare, you have to look for infection. Okay. So what tests do we do? So what we routinely do in our center is we'll send stool for parasite ova, we'll do a culture, see if we do a GDH followed by toxin. And for every patient, when we do a proctosigmoidoscopy, we send the sample for obviously histopathology followed by immunohistochemistry and a tissue PCR. So these things we always do in all our patients. If you have multiplex PCR right now, we have it for the viral, but we don't have it the bacterial, so we're not using it. If you have multiplex, you can use it. Intermoeba, the issue with the parasite is that intermoeba dispar may not be differentiated from the pathogenic thing. So you need something like qPCR, which we have in our center, or an antigen or a serology to differentiate pathogenic intermoeba from the cum itself. Just a couple of slides on this. This has already been discussed in the panel discussion, but just to say that among the viral infections, CMV is the most important. The main thing is to differentiate a CMV colonizer from a pathogen, and therefore the stool test is not useful. You should be doing the tissue testing, which will be histopathology, immunohistochemistry, or a PCR. And both the British and the ECO guidelines have said that the more number of inclusion bodies you see, the more number of IHC positive cells you see, more likely it is pathogenic and cause of at least contributing to the symptoms or worsening the symptoms, and you have to treat. And the meta-analysis also shown that CMV infection is linked with steroid resistance. So the risk factors for CMV infection are female patient, somebody who's got pancolitis, increasing age. Steroids and azathioprine have been shown to be a risk factor, but somehow biological so far has not been shown to be conclusive as a risk factor for CMV. In terms of treatment, you give IV ganciclovir initially. This is the ECO guideline followed by the oral ganciclovir. The question is whether you should continue because steroid and azathioprine are risk factors. So should you continue immunomodulator or should you stop? The BSG guideline says you should continue. ECO says stop. In our practice, we tend to continue because we think we have to also manage the underlying disease, which was again Dr. Sood was discussing in the panel discussion. So we don't stop steroid immunomodulator, but we add therapy for CMV if there are a lot of inclusion bodies or IHC positive cells. And a couple of slides on C. diff infection. So among the bacterial infections, C. diff is the most common infection, which has been reported in most series. And C. diff infection, there is a higher risk of colectomy, higher mortality rate. It's a risk factor for toxic megacolon and perforation. And therefore, all the three, the ECO, BSG, ACG, all the guidelines say that whenever somebody comes with flare, you should do a test for C. diff toxin, again, which are discussed in the panel discussion. So again, for C. diff, the risk factors are, last slide. So we finished the risk factors for C. diff infection is somebody has a colonic, which is Crohn's colitis or ulcerative colitis. Use of antibiotics, again, which is a well-known risk factor for C. diff anyway. And here, biologicals have been shown to be. So for CMV, biologicals is a question mark. But for C. diff, biologicals have been shown to be a risk factor. Treatment, again, was discussed in the panel discussion. So here, I think in terms of steroids and azathioprine, there's not much of issue. We should continue. The question as a biological, and again, I think we should probably give priority to the IBD as well and not look at C. diff per se. But I think, again, there'll be a variation in practice in that way. So with that, I come to the end of my presentation. Thank you. So do I have time for one question, the audience question?
Yeah. There are 10 minutes, sir. Come join us here.
No, one question I had, I think this is a bit, one question I had for the students.
Yeah.
So this is the case scenario. So 44-year-old patient was admitted with acute severe colitis. Patient is given IV steroids. On day 4, his stool frequency is down to 4, and blood also, the minimal blood has come down. CRP is 60. Now he had a rectal biopsy initially when he came in, and there is a feature of acute severe UC. There's no CMV infection, no inclusion body, IHC negative for CMV, but the tissue PCR is positive for CMV infection. So what would be the preferred option for treating this patient? So I would like to sort of have a raise of hands. How many for option A? Okay, some hands. How many for option B? Okay, and how many for option C? That's good. So I think I'll also probably go by option C, because here again, if you see, you have not seen anything on the histopathology or IHC, and patient is improving. His CRP is 16, the stool frequency has come down, not blood in stool. So probably in such patients, I think CMV may be just so tissue PCR is not very helpful to decide starting of therapy. It may help you sometimes in monitoring therapy. Any opinion difference from audience or from the chairpersons?
So will you look at the degree of CMV infection in the tissue, that is number of copies in the PCR, or will you go by just positive and negative? So will you look at the number of copies of CMV in PCR?
And why test? I mean, why test on day 1?
So because we are doing proctosigmoidoscopy, so that's a chance you sense. The thing is, you need the results don't come immediately. So by day 3, you have to make a call about the rescue therapy.
I mean, we can keep the sample. My concern is that this is inappropriate. I mean, if you have and 70% are going to respond to steroids. So this is an additional tissue PCR we are doing, which is not going to help us and confuse the picture. So my argument would be not to test that.
Yeah, but I may have a difference of opinion. See, the reason I'll tell you, when you are doing a sigmoidoscopy, taking a biopsy, look at the number of copies of CMV. And if the number of copies are more than 250, I would start treatment, because on 5th day, the patient have a worse outcome. And then I say what I did right or wrong retrospectively, but patient had the outcome.
Kushal, I agree with you. For me also, I take Vishal's point, but I think we look at the logistics of how things happen. No, we cannot get result instant reaction. So the thing is, the time frame is quite short. So for us also, we need to have the information on day 3, 4. We really then can't say pathologist, please have a look at this and that. So the thing is more about logistic. In ideal world, yes, you can keep the sample and do it immediately, but in practical situation, there will be difference of opinion, but that's what we do, because that's sort of, so we don't waste time on day 3 or 5 deciding what the pathology will be.
With a very high
CMV
CMV
small
level.
thing.
Yeah.
With a
I
very
think it is
high
important to
CMV
have
load,
participant question as well, otherwise we'll be only talking. We have 10 minutes for the participants.
Yeah, please come and join us. Yeah. Thank you, Dr. Amit, for wonderful presentation. I think as a pathologist, again, I like to highlight many of you will be going to the periphery where there is no good set of pathology lab. I mean, histopathology labs will not be available. I just want to emphasize on one particular point. Ulcerative colitis is a misnomer. In a biopsy, you will not have an ulcer. It is a mucosal inflammatory condition. There is a mucosal ulcer only when the patient goes into toxic megacolon. Okay, and I think and picking up of CMV infection depends on there's a lot of variation. The quality of the pathologist, I would say. I'd say a well-trained pathologist is really required to give you a justified report. So all the time, all of you who has been getting trained from a well set up, good setup with histopathology lab, try and learn your histopathology, try and do justification when you have your posting. Please do not neglect your posting. At least you should be able to identify the basic things. I think with this, I open for questions from the hall. Yeah, Dr. Kingsuk.
Yeah, Amit, I think in 2022, if you don't talk on, Dr. Kim will answer COVID and IBD flare. So did we see anything? What was the pictures and how do we diagnose that? And how does it influence the IBD course?
Amit?
But details of that, we need details of that.
I think details, obviously, because of time, but COVID was mentioned as a cause in my list, but ma'am will talk about the pathology part of COVID.
Dr. Brajesh, Dr. Brajesh,
COVID colitis.
Dr. Brajesh, please.
3 queries. Dr. Datta, if you did not do tissue PCR quantification, is it worth doing serum quantified PCR for CMV and is beyond certain value, then you start treatment?
So, sir, serum, the
And-
problem.
And two questions more to Dr. Saurabh. One thing is, what is the current status of sphingosine 1 phosphate receptor modulators in induction as well as maintenance therapy of ulcerative colitis? Ozanamide and this thing. And second thing, Dr. Sood mentioned about enteral nutrition. You mentioned about nutritional therapy. I would like to know special enteral formulas for inflammatory bowel disease and dietary modification to maintain remission in ulcerative colitis. Three questions.
So for the tissue for the PCR and serum, the serum PCR, is not very specific for GI. It can be any infection. The PCR can go up actually.
No, copies. Copies.
So I'm
gone
telling you,
100,
sir.
gone to 50.
So I'm coming to the answer, sir. So what I'm saying is we don't routinely do a serum PCR in all the patients actually. Somebody where we think there is a lot of CMV inclusion body IC and we're going to treat for CMV infection. There again, I'm not talking by a very solid evidence, but in patients where we're going to treat for CMV infection, there before starting we send a PCR and after we give therapy, sometimes we look at the response, but we don't priori do for every patient when they come with the infection. This again is more of a center-based. I cannot back this by an evidence actually.
Just a minute. If IHC is negative and serum PCR quantity is very high, then will you not treat that?
So normally we don't do
Just
it. Sir.
ask
We don't do it.
Dr.
We don't normally do it, but there'll be
There is
different
cutoff
strategies.
value for that.
I just like to interrupt here. Why there is a localized activation of CMV in ulcerative colitis? Actually, CMV infection, we all are exposed to CMV. It is in the atmosphere. So when by the time we are born, we all are infected. But with maternal IgG, so I think the infection is controlled. But the infection remains redundant in the gut mucosa, in the colonic mucosa. That's the reason why there is local activation. So one has to differentiate between the local activation and systemic infection. And so that's why most of the time when there is a local infection in a case of ulcerative colitis of CMV, serology would be negative. Negativity of the serology doesn't exclude possibility of superadded CMV infection in the inflamed mucosa. That is one point. And I think about the serology being highly positive and CMV being negative in the colon, that would be different situation. You have to really evaluate your case properly, whether the patient has other disorders, whether the patient immune suppressed, something else, or is it truly ulcerative colitis or something else? I think you need to re-evaluate your case in that particular setting. I think now coming back to the Dr. Kimsuk's question, to answer that, actually COVID, it is, infection of the systemic infection of the endothelial cells. It's nothing to do with the colonic mucosa per se. So I think the colonic mucosa or the GI also gets involved as a part and parcel of the systemic endothelial cell activation. So it may not be really anything very specific. Okay?
So Dr. Bridges, you see, most of the IBD patient, when they have CMV activation, it is mucosal activation. They present with more blood in the stool, ulceration. So therefore, the situation that you are saying is uncommon. But if somebody has a high viremia, that means you have a high level of CMV in the blood, you have atypical lymphocyte, you have fever, you are talking about a systemic CMV disease, obviously it needs treatment. So any other question?
Sir, so regarding the first question, ozanimod, which is a SP1 modulator, has shown efficacy for both induction and maintenance, has been approved by FDA, but it's not available in India.
But what is the current status all over the world, not in India?
Dr. Bridges, sir, we give chance to others. Yeah, introduce yourself.
Ma'am, I am Dr. Shivam from KIMS Bhubaneswar. My question is, sir, what is it, how do you manage a patient who is a known case of TB, develops IBD, or a patient of ulcerative colitis started and develops TB 3 months later? So how do you manage such a situation?
So if a patient of, for example, a patient of IBD who is on anti-TNF develops tuberculosis, then anti-TNF needs to be stopped. Patients need to be started on treatment for tuberculosis. And after 2 months of ATT, if the patient still requires anti-TNF, he may be restarted. So 2 months of ATT ke baad anti-TNF can be started. If a patient of TB develops IBD again, if the TB treatment is appropriate, then IBD treatment can be started.
So among anti-TNF, which one will you choose in a patient like that?
So both infliximab and adalimumab have similar.
So
rates
is
of
there
inflammation.
any difference between vedolizumab, infliximab, and ADA?
So,
Dr.
so
Gusal, I
vedolizumab
think we
has
have three students. Okay,
Good morning. ma'am.
introduce yourself.
Good morning. My name is Dr. Saidlu. My question is, one patient came for 44 years, male patient, 10 years duration, complicated with CSVT, thrombotic embolic event, and craniotomy done. After that, patient is regular medication. He is responding clinically in remission stage 1 to 2 and without mucus, without blood. He is okay. But in colonoscopic view, Mayo grade 1 or 2, last 2 years is same, maintaining with Ajaran 100 mg, OD, Mesacol 1.2 grams, BD. So can I escalate the
Be specific. What is your question?
colonoscopically improvement of that patient patchy erythematous loss of mucosa with ulcerations is there. So can I increase the dose of Mesacol or Ajaran? Already patient on Ajaran 100 mg, Mesacol 2.4 grams. Which one is the best?
Who wants it? Dr. Gusal.
So I think these things have to be individualized. What are the goals of your therapy for that patient? So certainly this patient has had thromboembolic phenomena. You would want mucosal healing, and here you are already kind of 2 milligram per kilogram. You can go beyond that if you have 6 TGN measurements available, and certainly you can give mesalamine. You can increase mesalamine to 4.8, and you want to go to a better, let's say, endoscopic score or healing. So these are the things. So these goals are to be individualized, right?
The study where increasing from 2.4 to 4.6 improved the outcome. Go to the next.
Okay, I
Good
think we have
morning
one
to all.
more question. Yeah,
My
I think
question
that would
is-
be the last. Introduce yourself.
My name is Dr. Anshul. I am from IGMC. My question is that we have a case of acute colitis and we are unable to differentiate whether it is infective versus IBD, as you see first episode. And the biopsy takes 7 days to come. What will we do in those 7 days? Whether we add antibiotics, we give steroid, or we do not give steroid? And what will be the effect if we fail to give steroid and those 7 days? And what will be the outcome on the natural history of ulcerative colitis? And secondly, one more addition. Do we have any sub-stratification of the severe ulcerative colitis? Because more than 6 stools mean
Okay,
12
be
stools also
specific. You
14
can
stools.
talk to them later. Just be to the
Oh,
point.
okay, okay.
So we'll take up one question and then you give the next
about
person.
indeterminate colitis, whether it is infectious or ulcerative colitis, and what do we do till we have the biopsy report?
Yeah, so that's a good question. See, the first presentation when they come, obviously
Be short, please.
we cannot start steroid on the day one when the patient comes. Obviously, even the stool test will take 3-4 days for the result to come. Pathology also in 3 to 4 days time you can get the result. So till then, I think till you have any microbiological evidence, obviously empirically when somebody comes with first episode, we end up giving antibiotic. That's not
Yeah,
right,
that is
right
what
practice.
Indian consensus on UC says. Go to the next.
Okay, the next
But
person.
but if we fail to give steroid, what is the outcome on
So
the
what I'm
natural
saying,
history
yes,
of ulcerative
but
colitis?
that's a practical limitation we have. No,
You
this
can
question is
talk to
right.
Dr. Amit later on. Give a chance to your colleague. Okay.
Thank
Be
you.
short. Questions should be very short.
Introduce
Good morning,
yourself.
everyone. This is Dr. Abhishek from KIMS Bhubaneswar. My question is how to manage the recurrent Clostridium difficile infection in case of the severe ulcerative colitis.
I think that has been discussed in
Spanish
great
is-
detail. So you can talk with them over a cup of tea. I think for the shortage of time, we'll have to end.
So the first is give vancomycin again, and then you can taper it. And the second, you can actually do a FMT. Now there is growing evidence that FMT may be good enough for the first episode also. Recent Lancet GH study, not in IBD, but I think that is going to come, in IBD also.
I think with this we close the session. We thank everyone who had participated actively and also the organizers for giving us the extra time. Thank you very much.
The next session would be in a hybrid format, and one of the speakers would be joining us on a virtual mode. The session would be on nightmares during endoscopy and how do experts tackle them. And we'll have 4 talks given by prominent speakers in the field of gastroenterology. And I'll request the chairperson to come on the stage. The chairperson for these sessions are Professor Kochar. He is a former professor and head Department of Gastroenterology at PGI. Dr. Nirmaljeet Malli, sir. He is a senior consultant of gastroenterology in Ludhiana. Dr. P.K. Sethi, sir. He is a consultant in Kolkata. Then we have Dr. Brigadier Rajat Shukla, sir. He is a professor and head of the Department of Gastroenterology at Army Hospital R&R Delhi. And then we have Dr. Y.R. Reddy. He is a consultant gastroenterologist in Hyderabad.
Hello, good morning, everyone. So after an exhaustive discussion on ulcerative colitis, which is a wonderful session, we move on to something which is very, very important in our day-to-day life. That is ERCP and the nightmares encountered during ERCP. So it's a procedure which is given gastroenterology, I would say, a different platform with the ERCP and ERCP interventions, but this is fraught with danger and complications. And we have three very eminent speakers. My duty is to introduce first of them, which is actually if there is a bleed during or after ERCP. For this, I'll invite Professor T.S. Chandrasekhar, who all of us know, PGI alumni, and who is doing some wonderful work down south at Chennai. So Professor Chandrasekhar for bleed during ERCP.
At the outset, I'd like to thank Dr. Usha and Dr. Kocher and the big team of PGA. Had a great fortune to visit the department. It is totally transformed. What was a single endoscopy room, now it has changed into a multi, there's so many endoscopy suites are available. I'm very glad that, and this is with the reference to the endoscopy emergencies. Now it's easier to manage such things. Very important. And warm greetings to all the chairperson. And this is the 6th GA emergency PG program from PGA. I bring warm greetings from Chennai. The breaking bad, bleeding encountered during ERCP, post-ERCP bleeding. You see the rich vasculature around the common bile duct, and you see the rich blood supply to the ampulla of Vater. Now it will explain what had happened initially as a stone removal case. You see this now. We are very happy stone came out very well, and we are about to wind up the procedure and what has happened. So the rich vasculature of the ampulla cannot be ignored, should not be ignored, and you need to be in action. Now what will you do that? Take a deep breath, be calm, don't panic, and get into action. And while you are getting into action, recall the scientific background, which I am going to do it now. This can be immediate bleeding, ERCP, or can be very delayed. Incidence is 2%. Severe life-threatening can be 0.5%. And most of the time, will be stopping on his own, so we are not bothered about that. But if it happens, you have to gear up and to the tune of 0.5%. It's not a small number, but either way, this is a life need to be preserved. And Cotton et al. Nicely classified according to the need for blood transfusion and unplanned admission 4 to 10 nights, you lose your night sleep. And is going to be admitted for a day in ICU, that's a severe bleeding and can be classified moderate and mild bleeding. Most of us see, we don't need more admissions, and the unplanned admission is less than 4 nights and can no ICU admission. So let us see the scientific background before we are getting ready for the managing this, the bleeding, the risk factors for the post-ERCP bleeding. And most of the time, make sure that you coagulate with the anticoagulant drugs is taking cholangitis. More severe the cholangitis, more severe bleeding. Bleeding during years happen, is likely to have more bleeding after that also. And if you have a low ERCP case volume, then that will be the technical difficulty. Of course, more often we see nowadays the cirrhosis in association with ERCP. What happens is maybe a mild childhood cirrhosis due to ERCP and more dilated the CBD, and CBD stone pathology
particularly have more bleeding and periampullary diverticulum and precut. And less important, what contrary to this is aspirin and NSAID drug. Ampullary tumor, unless you do the ampulectomy, and the length of the sphincterotomy does not matter. And I will tell you that there is a small rider in that. Extension of prior sphincterotomy does not matter as far as the risk factor. There are some more risk factors, very important. Now, renal disease or dialysis and medication use, prolonged antibiotic usage and prolonged biliary obstruction and malnutrition. Now we got a scientific background now. Now what we should do that? Before ERCP itself, we should have done this to prevent this kind of thing. Coagulation screening, platelet count should not be less than 50,000, correct clotting defects in cirrhotic patients, known platelet dysfunction disorders, make out and correct it, and discontinuing clopidogrel. The very important clopidogrel and aspirin can be continued and warfarin should be discontinued. Low dose of aspirin and NSAID drug may be continued safely in endoscopy period. Now we know the guidelines are very, very clear about the antiplatelets, anticoagulant drug. Now the word mantra is resuscitate, resuscitate, resuscitate. That may be for any GA bleed. You are here now, you're watching the bleeding in front of you happening, intravenous replacement, blood products, and hemodynamic resuscitation. There are 4 options are there: endoscopy, pharmacotherapy, angiography, and surgery. And endoscopy is the key and the mainstay of treatment. Now it is there. I'm going to tell you very important advancement happened in the diagnosis of the post-ERCP bleeding is, when a pool of blood is there, you won't be able to diagnose, but you see this, the red dichromatic imaging Olympus has introduced, where in the pool of blood, you can see the bleeding happening here, and on the control it, then it is. This is the diagnostic advancement happened now. There are 4 case scenarios. I just want to tell you that. What is commonly happening here is you cut the ampulla. As you are progressing to the apex of the ampulla, sometimes a small arteriole can bleed. Don't bother about, you make it from endocut to coagulation current, or you continue with the endocut. What happens, the bleeding stops, and most of the time it subsides on its own. This is what the case scenario 1 will be there. Case scenario 2 is you need to have the guidelines follow up, like you need to have the epinephrine injection, which is very easier to do that. And you need to have the thermal therapy or the chemo clip if you are able to do that. Now, case scenario 2, what happened is we have done the sphincterotomy, stenting was done. There is a bleeding mother, blood clot was removed. We see the underlying area of the bleeding. We use the sclerotherapy needle with using the sclerotherapy needle, epinephrine injections given, and followed by we do this the APC. The case 3 scenario, which is very sometimes you come across, you do the sphincterotomy, you see the bleeding is there, stone is removed, you place a plastic stent, and you try to control the bleeding stops, and you are very happy, don't discharge the patient. 24 hours later, there is a drop in hemoglobin. Again, you try this, nothing happens. Then what you do this is a very important thing. This is not happening. You remove the plastic stent and place, you should have the self-expanding metallic stent in the armamentarium, without which you should not do this. This is the thing. Now, case scenario 4 is the first slide I showed you. This patient undergoes ERCP, a stone is removed, torrential, there's a volcano of eruption of the bleeding happening volcano, and you see the massive bleeding happening now. And there's no time for you. While you are organizing, you can have the balloon tamponade if you are very lucky. So we use the balloon tamponade. Sometimes the sphincterotomy knife itself, you can do the coagulation. So, and quickly recall, there can be a lot of bleeding happening. It can be biliary, that is, you will have portal biliopathy, that may be the reason. So quickly read this. And we were aware of this patient has got biliary, the portal biliopathy. So we did a balloon tamponade, it stopped it, but for a while you kept it for 10 minutes. And on deflating the balloon, what happens is again started bleeding now. Now what to do that? We are done with all the armamentarium, with exhausted, but for only one thing happened. And this is what the clear-cut indication for the fully covered. If the fully covered also fails, now we have a spray, and then you have to send it for the angioembolization or surgery. So what happened in this case, let's see now. Now we are deploying the metallic stent now, and after deploying the metallic stent, the bleeding has stopped. And we had a great sigh of relief just now. This is a technical topic, and so I need to give some technical tips. Proper orientation of the guide wire, avoidance of the zipper cutting is a very important thing. And never use the fully open sphincterotome when you are expecting bleed. Closed or partially closed sphincterotome is useful. And successful electrocoagulation, the sphincterotome wire can be the first step, can be tried because you are already there. And sometimes if you are anticipating blood, you want bleeding, combining small 1/3 sphincterotomy with endoscopy balloon dilatation will be of great use. And application of electrocautery current is more difficult than injection therapy. So the next step should be the balloon or injection therapy. This is what it is now. And somewhat technical, stone removal balloon can be used to buy time. While you are 5 minutes, you are controlling the bleeding. What you can do is you get other armamental, get the help from your entire unit, get the blood ready and everything ready. And for the time you are deflating the balloon, further bleeding, then you can go for the avoid trauma in the pancreatic orifice. Whatever you do the endotherapy, you be away from the other. You end up in pancreatitis. Then you see that you are stop the bleeding, but pancreatitis, that's the worst. I have not tried the second one, prophylactic submucosal injection of the hypertonic saline, but there have been reports that epinephrine effective. So I address to the audience, you start trying if you anticipate bleeding. These are the technical tips. Hemoclip, even if you're an expert, placement of hemoclip is because the elevator comes into the way and the sheath often becomes kinked. So hemoclip is not that easy. And the two, you have to see the pinpoint, the location of the bleeding is very important. And the clips, once you are successful, 90 to 100% of the time. But we need to design normal duodenoscopy friendly hemoclips. Right now, not available. So hemoclip maybe not be the thing. So first is sphincterotomy wire, then will be the stone removal balloon, then injection therapy, then APC, another thing. And this is what the fully covered metallic stent should be in the department. We are actively practicing high-end endotherapy work that gives a tamponade, not only controls the bleeding at the level of ampulla, it can control the bleeding to the lower CBD and distal and the mid CBD also. And remind that this is the most effective last opportunity second line method. If you are failing with the fully covered stent, then we have to go with the hemostatic powder. I have not tried because it becomes very messy and you will not be having a time to try another endotherapy, but you are done with all endotherapy. You are waiting for angioembolization, interventional radiology, or the surgery, then easy to apply. And there are several powders are available that factor replacement for hemophilia, platelet transition for thrombocytopenia. All things need to be covered. Recheck your coagulopathy profile, coagulation profile, and make sure that you are not missing anything. And now this is a very important thing. You want to recall the anatomy. It's a gastroduodenal artery divides into anterior and posterior. An inferior pancreatoduodenal artery divides into anterior and posterior. And they form a arcade of vessels. From the arcade of communicating vessels only, it supplies the ampulla. It is not like cystic artery. You can angioembolize and you can control the bleeding from the cystic artery. Ampullary bleeding is totally different ballgame. You need to have a super selective angioembolization, which will be very difficult. The communicating artery from there. And there's a nice study done by this gentleman and from the Japanese. I want to read it along with you. Papillary artery originates from the communicating artery, which connects the posterior superior pancreatoduodenal artery and the anterior superior pancreatoduodenal artery in 74% of the time, and directly from the pancreatoduodenal artery posterior as a vasa recti in 26% of the time. What a wonderful work. He took almost 5 years to study on the morbid anatomy and the cadaver has it. And the conclusion here is No papillary artery arises from the anterior pancreaticoduodenal artery. So mistakenly you angioembolize that artery, then is not going to stop. So that means angioembolization of the periampullary bleeding can be very, very difficult, technically difficult, may cause infarction of the abdominal organs. Angiography embolization is successful 80 to 80, almost 100%, but should be considered before surgery and technically difficult and should be super selective. What about surgery? In my practice of over 35 years, I never submitted a patient. We had a 5 major bleed, one for the, before the advent of fully covered, I sent it for the angioembolization. After that, I never sent it. And 2 cases I have managed with the fully covered, 1 case with the, 2 more further cases with the regular, the guidelines therapy, with this sclerotherapy and the APC, thermal therapy. Why surgery is so difficult? Post-operative mortality rate is as 50%. I don't know about now, the older studies. And sphincteron, what do they do in surgery? Sphincterotomy into a sutured sphincteroplasty and overseeing the bleeding artery. Now the problem comes is the bleeding comes from the mid CBD or lower CBD. I really wonder how the surgeon would be able to manage it. Now I've been asked by the organizers, for the sake of the postgraduate, you should have some question. Now the rapid fire going to be 4 before I sum up. The rapid fire is, does pre-cut increase the post-ERCP bleed? Answer is yes or no, or well, may not happen. What's the answer? Postgraduates? You are silent means you are not very clear. That is also literature also not very clear. Very good. The answer is very good. But now more and more in favor of the technical details. Did not increase the rate of post-ERCP bleeding compared to the persistent cannulation attempt. The last one more slide. Why sphincterotomy should be done in biliary 10 or 11 o'clock position? Don't tell me my teacher taught me like that only. It is given in the book. What is the rationale? And Mahesh, you are not a postgraduate. Okay. I think Mahesh answered rightly, because this includes only 10% of all papillary arteries. That's the reason, one other thing. And the axis told the, now, which one you will choose? Pure cut, blended current, or endo cut? Answer is whatever available I use. No, that's not the answer. Sir, I don't have a high-end diathermy machine. That is not the answer. What is the answer is, endo cut is better than blended current is better than pure cut. So this is the answer for this. You may ask me that there are some reports about fibrin sealant, but why it is not being preferred? The answer should not be it's not available. It is costly. What is the reason? I think again you are silent means you are not aware of it. The potential risk of transmission of infection and occlusion of the pancreatic orifice. I told you anytime, and in the hurry, what will you do is you do some endotherapy. If you occlude the pancreatic orifice, then you'll end up in pancreatic. I think having done that, ladies and gentlemen, this is my time to summarize here is the first line option is injection and thermal methods. Second option is hemostatic clips. If technically feasible, you should be really an expert into that and should be able to locate the bleeding vessel, which may not be sometimes possible. And what will you do while you are waiting for the thing? This balloon tamponade ensure temporary control of the bleeding. Can use a sphincterotomy wire also. You improve the visualization of the bleeding site. If you have the facility for RDI, red dichromatic, this one imaging, then you can use that. May allow plan and successful implementation of other treatment methods. And fully covered SEMS has really revolutionized the salvage therapy while traditional endoscopy methods fail. Hemostatic powder cannot be routinely recommended. Pharmacological agents can be used in disorders of hemostasis and coagulopathies. Angiography and surgery required at some rare cases for refractive bleeding. Thank you very much. And I've taken this from the major review article. I think I appeal to the postgraduate, take a photograph of this. This is a fantastically written review article ERCP related bleeding. Thank you very much for this wonderful opportunity.
Thank you, Professor T.S. Chandrasekhar, for a very lucid and informative talk. So you can, sir, join us on the stage. We can have question and answers at the very end when all the 4 talks are done with. So all the residents can be ready with their questions. And now we move to the second talk.
Good morning. Our next topic is if there is perforation during ERCP. And the speaker is Dr. D.N. Reddy. He will speak from Hyderabad online. Dr. D.N. Reddy is very well known to all of us. Most important is his PGI gastro alumni. By saying that, I myself feel very proud. And he is the chairman, AIG Hyderabad. Over to you, sir, Dr. D.N. Reddy.
I'd like to thank Dr. Usha Datta for giving me this opportunity to be a part of the symposium. Unfortunately, because of another commitment, I can't be physically there. I've been asked to talk on perforations during ERCP. If there's a perforation, what would you do? Perforations during ERCP are not very common, but when they occur, it can be a problem both for the patient and for the treating doctor. Now, to treat these perforations in a rational way, it's important to understand the anatomical localization of the perforation and etiological cause. The Staffer's classification very clearly defines this. Type 1 perforations occur when there is injury to the lateral wall of the duodenum, usually because of the scope itself. Type 2 are because of periveterian injury during sphincterotomy. Type 3 is when you try and pass a guide wire through the bile duct or pancreatic duct and produce injury. And finally, the type 4 ones are only free air in the retroperitoneal space and nothing else. If we actually look at incidence of each of these types, you'll see that it's highest with type 2. And fortunately, with better sphincterotomes, intelligent cautery machines, this is coming down further. The overall incidence of perforations itself is pretty low, and it's very important that when this occurs, to manage them in a proper way. Let's start first with type 1 perforations. These can occur with the scope itself because of the knuckle effect of the scope. This was during one of our ERCP workshops. A very famous endoscope is doing this. Sees and comes back, and you can see very clearly. He didn't do anything, just a diagnostic look at the papilla, and you can see the large perforation that came in. And if this is not recognized immediately, or if it's very large, often surgery is required. But if recognized early, and if it is small in less than 2 centimeters in size, we can, to some extent, using the newer clipping techniques, for example, over the scope clips, you can actually seal it off immediately. And increasingly now we are using the King's loop technique, where you put in a loop, and even fairly large perforations can be closed using this technique successfully. Now, coming to the type 2 perforations, and these usually occur during sphincterotomy. And you can see very clearly here, after sphincterotomy, when the contrast is flowing out like this, you know that there's a perforation. Now, this can be treated very easily by putting in a completely covered, self-expanding metal stent like this, which doesn't migrate. Sometimes you notice these type 2 perforations only after the procedure. Like in this case, the stones were removed, and then we notice this perforation with air under the liver surface. And then in this case, of course, you can put a nasocystic or nasocystic tube into the bile duct, and so that continuous drainage is achieved. You can also get perforations like this using a needle knife. In this case, using a needle knife over a pancreatic stent, sometimes you can become aggressive, and you can see the small hole that we created there. But very often, just stenting this patient is sufficient, or even just clinical observation is sufficient with perforations closed. Now, coming to the type 3 perforation, you can see there's an obstruction here, trying to pass a guide wire. You can slowly see air under the liver here, subhepatic air in the retroperitoneal space is suggestive of perforation. This is gradually increasing. One should not stop your procedure at this point of time. Get into the right plane, and then once you're in the right plane, you can actually negotiate a guide wire into the intrahepatic systems, and then put in a completely covered stent. And very often this is sufficient in most of these cases to seal the perforation. These stents can then be removed after 4 weeks with complete seal. Again, after you finish the procedure, you sometimes notice air like this. Usually, again, because of type 3 perforations. One need not very often. But the most common thing that one often sees, if you actually look at the patients carefully after large sphincterotomy, is some amount of perinephric air. After my ERCP, I always look at the kidney here. If you see air around the kidney like this, then you know that a small perforation has been created. These type 4 perforations, they don't have to worry about. Most of these patients within 48 hours will completely resolve, and they can start feeding after 48 hours, and you'll find that they do well. So how do you suspect perforation during or after the procedure? First of all, during the procedure, you can often see the opening that you have made, especially if it's a type 1 perforation. There's also inability to keep the bowel distant with carbon dioxide. There's air on fluoroscopy that you see, and of course, patient starts having a respiratory distress. But sometimes small perforations are not noticed, but during the early postoperative period, there's unusual type of abdominal pain, chest pain with emphysema or shortness of breath, then one should suspect that potential perforation. Much later, these patients can become very sick, hypotensive, with mental confusion, and SIRS sets in. The best way to detect perforation, especially if the small one, is to do a CT scan. This detects small amount of gas and also fluid correction. This is not to suggest that all patients should get a CT scan even for a small perforation, because they may be insignificant. But if it's going to be significant, if it requires amount of decision making about how to treat this, then it's best to get a CT scan very early done, and sometimes a contrast CT scan to see if there's a type 1 type of perforation. Like other potential complications of ERCP, there are certain risk factors that are patient-related, procedure-related, and these have now been very clearly identified for perforation. For example, this can be related to anatomy and disease. For example, in a suspicious sphincterotomy dysfunction, of course, we no longer do sphincterotomy in these cases. But the most common reason for perforation is B2s. When you're doing B2, there's a fixed limb, and this can result in perforation of type 1 nature. Duodenal diverticulum, especially periveterine diverticulum, you do a large sphincterotomy, or when there's papillary stenosis. If fixed loops, because of gastrointestinal cancer, even pancreatic cancer, when the loop becomes very fixed, then you can have a perforation, and very elderly patients a problem. There are also operation-related risk factors. Difficult intubation can result in perforation elsewhere also. And of course, when you dilate biliary strictures, especially when you use a large balloon dilatation, even for your sphincteroplasty, you can produce a perforation. So these are some of the factors which result in perforations, and knowing these factors can often result in actually avoiding this complication. I think it's very important to realize that early diagnosis and proper treatment would result in better outcome. And I think very clear evidence that if you diagnose these patients before 12 hours, then majority of them can be salvaged, especially if you're going to do an endoscopic treatment. But after 12 hours, you can see how the mortality rate increases. So I think early diagnosis and treating this endoscopically very often results in very good outcomes in these patients. But those who go for surgery, usually after 24 hours, have some problems, and especially sepsis sets in very early in these patients. So the basic principles of treating patients for endoscopic ERCP-related perforation is similar to what you would do for all endoscopic perforations. Try and close this endoscopically. In fact, very often, an important principle would be that you call a colleague of yours, because if you have created a perforation, you sometimes don't have the mental balance to try and close it. Call an experienced colleague of yours in the same department, and of course, he's in a different plane at that point of time, and it's easier for him to close. Achieve adequate biliary drainage either by a completely covered metal stents or at least a nasobiliary drainage continuous aspiration. And of course, if there's a collection that has resulted in the retroperitoneal space, very often because of type 2 perforations, then this should be drained percutaneously. So using these basic principles of what we would do in endoscopy, to a large extent, you can treat these patients very adequately. So just to summarize what we went through, type 1 perforations are in the lateral duodenal wall, are endoscopy related. They can be intra or retroperitoneal. They are very severe, and these patients, if they're not managed endoscopically, surgery should be done very quickly within 24 hours. Type 2 perforations are periveterian because of sphincterotomy. It's retroperitoneal location, and majority of these patients can be treated with a combination of a fully covered SEMS or a nasobiliary drainage. We follow up these patients with post-procedure CT. This is the best method. Type 3 are ductal injuries, either occurring because of wires or baskets. Again, it's retroperitoneal. A majority of these patients, stenting is sufficient, and again, post-procedure CTs can follow. Type 4 perforations are because of only retroperitoneal layer, very small microscopic perforations. They do not require much treatment. Usually occur if you do a prolonged procedure, especially with a lot of air flowing in, your airflow is very high. Again, retroperitoneal, and majority of them are treated conservatively. In fact, in this type of situation, the CT can look frightening and could be avoided. Just following these patients with nil oral for 48 hours, followed by starting liquid feeds and antibiotics is sufficient in most of these cases. So in summary, ERCP-related perforations are rare but could be fatal. Early diagnosis is a key factor in prognosis. Endoscopic therapy to close this perforation is the mainstay of treatment. Surgery can be considered if endoscopy fails, or if the perforation is very large, or the diagnosis is delayed and the peritoneal inflammatory signs. Thank you once again for giving me this opportunity to participate in this very important symposium. Thank you. I'd like to thank
Dr. Mahesh Goenka, a doyen of endoscopy, who actually needs very little introduction, our current president of ISG and head of gastroenterology at Apollo Clinicals in Kolkata. He'll be speaking to us on how to prevent post-ERCP pancreatitis.
Thank you, Dr. Shukla, and good morning, everybody. It's always a great feeling to come back to your alma mater. And for me, it's special because I have spent a good 12 years of my life here. We have been in this auditorium more for Friday movies than for the academics. Academics used to be in lecture theater. But today I'm here for the academic program. My greetings from Indian Society of Gastroenterology as well. So post-ERCP pancreatitis is no doubt the most dreaded ERCP complication. Overall, 2 to 10%, but can go up to 40% sometimes. The worst part is it's unpredictable, both for occurrence as well as for the natural history, and is of course associated with significant morbidity, sometimes mortality, and of course the cost. So what I will be doing to you in the next 14 or 15 minutes is to talk to you as to how we can prevent post-ERCP pancreatitis if we can. So how do we predict the risk before, during, and after ERCP? Now, this is a table from ESG guideline published about 2 years back, and they have divided the risk factors into those with major criteria, the first list, suspected SOD dysfunction, history of post-ERCP pancreatitis previously, pancreatic sphincterotomy, difficult cannulation, pneumatic dilatation, precut sphincterotomy. This is a questionable point I'll discuss later on, and empulectomy. And these are the minor factors: female younger than 50, history of more than 2 recurrent episodes of pancreatitis, contrasting to PD, and cytology obtained from PD. So if there are one major risk factor or 2 minor risk factors, this patient should be considered as a high risk of post-ERCP pancreatitis. And the risk is cumulative. So if there's one risk, let's say female gender, the relative ratio is 2.5. But you have a combination of female with normal bilirubin, difficult cannulation, sphincter for diet dysfunction. The risk can be as high as 42.1%. We also looked at data. This is a multivariate analysis done in an international trial where Dr. Kocher from PGI has also participated. And we almost evaluated 1,000 patients who underwent ERCP. And in our study, young female, pancreatic biliary malignancy, guide wire passage to the pancreatic duct, cannulation techniques were some of the deciding factors, and these are the p-values. What was important is that we realized in this study that passage of guide wire into the pancreatic duct is also important. We till now believe that it's contrast injection, acetylization during the opacification, which is important. But this study and some of the subsequent studies which has been published has shown that a guide wire entering the pancreatic duct more than one time increases the risk significantly. And this is another study which has shown that when you compare with guide wire insertion as compared to opacification, in fact, in this study, the odds ratio of having post-ERCP pancreatitis was higher for guide wire insertion than for opacification. So at least the risk is as much, if not higher, with guide wire insertion. And we, again, the same group, developed and validated a post-ERCP pancreatitis risk calculator with machine learning. And what we did is that we used a gradient boosted machine model was developed. 12 multicenter randomized controlled trials were evaluated. Number of ERCPs which we evaluated were more than 7,000 with a PEP incidence of 8.6%. 22 PEP risk factors were included and 4 possible interventions were evaluated. This is the ROC curve, and this shows the relative importance of risk factors: BMI, age, guide wire, pancreatic duct injection, cholecystectomy, minor papilla, and so on. So this is how, like any medical calculator, you can enter the data, whether it's male or female, age, BMI, and the other risk factor present, and the calculator will give you a potential risk of getting a post-ERCP pancreatitis in this particular patient, and also tell you that if you use these interventions, which we commonly do, how the risk can be reduced. I think this requires further external validation. We presented this in last ACG, and it seems to be a very promising calculator. So the question is, how do we prevent PEP before, during, and after ERCP? I think most important point for the postgraduates is that perform ERCP only with indicated. And this I learned at PGI Chandigarh, that ERCP has no diagnostic role. You should not do it if there's low probability of CBT stone, and we know ASG has given some guideline. Resectable biliary tumors with no cholangitis, there's no role for ERCP. SOD type 3, we should not do it. Painless chronic pancreatitis type 4 islet tumors, one will resist doing an ERCP. About the techniques of ERCP, you should note if the difficult cannulation is there, and we follow the rule of 552, but we should decide whether you're doing wire guided or contrast guided, and I'll dwell on this a little bit. Decide when to do a pre-cut, late, very early, and primary. And if you have an unintended pancreatic guide wire, you should change the technique to double wire technique. Now, this is a meta-analysis, 12 randomized controlled trial, which looked at guide wire assisted cannulation compared to contrast assisted, and clearly showed that a ratio of 0.5 risk ratio, guide wire assisted cannulation is always better than contrast injected. Now, if you're using a double wire technique, which we do quite a bit, and in our setup, about 10% of our ERCPs are with double wire technique, then we must always place a stent. Let me see if the video is done. Let's forget about that. So if you put a stent, the risk of post-ERCP pancreatitis is reduced to 3.3% compared to not placing a stent and only doing the ERCP over a guide wire, then it's 10.3%. Now, pre-cut, there are lots of issues. There's no time for us to discuss that. It can be done during the algorithm in a late when you've failed everything, very early, or recently some people have started doing as the initial way of doing a sphincterotomy. In fact, there are some studies which have shown that if you go for early or as primary pre-cut, then the risk of PEP may be reduced rather than increased with pre-cut. In fact, this study is from Jaipur, Maharshi, which is used, they have used a primary pre-cut. That's the first modality of doing a sphincterotomy, and they found a low PEP rate in this. But this is not a uniform policy which is followed. Now, let me now talk about pancreatic stenting, which is there for almost 25 years now. Various studies are available. And this is a meta-analysis published some time back, about 12 studies, which clearly showed that pancreatic stenting does reduce the risk of ERCP-induced pancreatitis. There are some issues in pancreatic stenting, which stent is optimum, whether we should stent even if there is difficult pancreatic cannulation, what are the risks of trying and failing, should PG stent be a standard procedure, and are NSAIDs adequate to replace PG stent? This is what is based on most of it on evidence, and this is what we practice, that we use 3 to 5 French stent, short stent, unflanged, so that may fall off immediately within a few days. We don't go on trying for stenting in a difficult situation because the risk is high if you go on trying when the PD stenting is itself difficult. We don't put PD stenting in all patients, only in difficult ERCPs. And PD stent, as I'll show you in the next few slides, cannot, and I emphasize, cannot be replaced by NSAID alone. What about use of pharmacotherapy? I think
endomethacin and subsequently diclofenac, the NSAIDs has become a part of our practice in ERCP to reduce pancreatitis. Now, this was an initial study published in 2012 in NEJM, which showed that both the risk of post-ERCP pancreatitis, all types, as well as moderate to severe type, was reduced by using rectal endomethacin without an increase in the side effects of GI bleed or renal failure. And then there are a number of meta-analyses which are published. I just picked up one, which has 16 randomized controlled trial and showed 50% reduction in PEP. So the issues are whether it is effective for all ERCPs or should be done only for high risk. There is a dichotomy. The ESGE guideline says that it should be used for all ERCPs, where ASG still believes that it should be used only for high risk patients. Whether it's a standard dose or high dose, we prefer a standard dose of 100 milligram. What should be the timing? There are studies both in before ERCP and after, but in general, it is to be used before ERCP. There's no difference between indomethacin and diclofenac in most of the studies. Now, should rectal indomethacin replace PD stent? And this is an important message which I want to convey. This is a national survey in USA. And this is the trend of post-ERCP pancreatitis. So there was an increase, then there was a fall around 2014-15, and then again there is an increase. And it parallels with the mortality with associated PEP. And what is the reason? This has been studied in this article. So you look at 2009, the indomethacin was used in 6.4% of ERCPs, and PD stent was used in 37.7%. As compared to now, 2018, 4 years back, indomethacin used in 46%, more liberal use, and stent only in 3.8%. So there was a transition around 2013 to 14, you see, that the use of indomethacin increased dramatically and use of PD stent decreased dramatically. And if you parallel this with the data which I showed, possibly this is the reason for this change in the graph. So I think PD stent has its own place, and it has been shown that it cannot be replaced by an SID altogether. What about other pharmacotherapy? Sublingual nitrates may be used, useful when indomethacin cannot be used. Some protease inhibitors have been found to be useful, but there's hardly any data to support the use of these three drugs. Now, this is an intro trial, which again, the same group, we ourselves from Apollo Hospital, along with PGI Chandigarh, Dr. Kocher, Dr. Sinha, John Hopkins, and AIG Hospital are starting very soon. The concept is that it has been found that the PEP is much less in patients of renal transplant who undergo ERCP because they are on tacrolimus. And the concept is that calcineurin inhibitor decreases the calcium release, which may be a pathway in the formation of PEP. So this is a study, and this is a protocol which we published a couple of months, 2 months back in pancreatology. And we plan to do 4,000 patients. So there'll be two groups, placebo compared to tacrolimus, and then high risk and moderate risk. Can you do something from there? Okay. And then normal risk or moderate risk, and then in this group we'll give rectal endomethacin, and in this group we'll combination of tacrolimus with endomethacin. A single dose of tacrolimus is planned. I think stuck. Okay. Now, finally, what about hydration to prevent pancreatitis? I think this is again a new concept relatively. Last 8 years, this was the first paper which used hydration to prevent PEP, just like hydration to treat acute pancreatitis. And then it has changed to aggressive hydration, where we use 35 to 45 ml per kg over a period of 8 hours. And the standard therapy is 12 to 15 ml. These are some of the studies. I'm not going to details of this, but ESG guideline says that if you are using hydration, then this should be the dose. 3 ml per kg per hour during ERCP, whether it's 10 minutes or half an hour of ERCP. Then you give 20 ml per kg bolus just after the ERCP, and then 3 ml per kg per hour for 8 hours after the ERCP. We in our department did a DNB thesis where we reduced 8 hours to 4 hours with promising results, even with 4 hours. And this may be logistically useful because some of the ERCPs are done on the OPD basis. So which modality to be used, and what about combination? We also looked at the same group, me, Dr. Kocher, Dr. Nageshwar Reddy, and John Hopkins, looked at epinephrine, the concept this being a vasoconstrictor. And we had a controlled, placebo-controlled study, but we did not find epinephrine to be additive to use of rectal endomethacin. Now, this is a network analysis which has been done by us. And we evaluated 1,503 studies, 55 randomized controlled trials, 20 interventions. And the meta-analysis and network analysis showed that a combination of IV fluids with rectal indomethacin may be reducing the risk maximum as compared to any other single modality. This has been shown reflected in another study published last year, where a combination of rengalictate with indomethacin was found to be most successful. So the modalities which can be used before ERCP is rectal indomethacin or diclofenac or sublingual nitrates. Whether used to be used in all patients or high risk is up to your institute choice. During ERCP, you may change to pancreatic stenting in difficult pancreatic cases. And after ERCP, you can continue with aggressive ringal lactate hydration as much as 35 to 45 ml per kg over 8 hours, which comes out to about 2.5 liters of fluid. Now, I was trying to make an algorithm myself, but I could not make any better algorithm than this algorithm given by ESGE in 2019. And I'll run through it in the next 1 minute, which is available to me. That when a patient comes to you, you find out whether there is an NSAID contraindication. Majority of time, there's no contraindication. So you give rectal indomethacin or diclofenac 100 milligram before ERC. If it's a standard cannulation, no further intervention is required. If it's a difficult cannulation, do a pancreatic stenting. Now, if there is contraindication to use of NSAID, find out whether there is a contraindication to high volume hydration. If there's no contraindication to high volume hydration, then you start ringal lactate 3 ml per kg per hour during the procedure. If it's a standard technique, continue with hydration, which can be 20 ml per kg bolus after ERCP and 3 ml per kg per hour for 8 hours. If there is difficult cannulation, then you do a pancreatic stenting and stop hydration. So no, don't combine stenting with hydration. Now, if there is a contraindication for using hydration, then you are left with giving sublingual glyceryl nitrate, which can be a good alternative to indomethacin, but is not as effective. So you consider putting a pancreatic stent in these patients, whether it is a normal risk or a high risk. If it's high risk, you go all out to put a pancreatic stent. If it is not, then also you try to put a pancreatic stent. I think this is still the best algorithm to prevent post-ERCP pancreatitis. Thank you very much.
Thank you, sir. Thank you for lucid presentation, and you can join us here. And we have one more topic. Now I invite Dr. Sandeep Nijavan, who is eminent speaker and HOD of SMS Medical College, Jaipur, to speak on how to deal with difficult foreign bodies.
Good morning, chairpersons. I'm very thankful to Dr. Usha for the kind invite. I had to leave and give many walkovers in my tennis tournament yesterday to be here today, but I am happy that academic has won over the sports at PGI Chandigarh. So, as far as the foreign body is concerned, the most commonly it occurs in children because of the curious intake, but it does happen in adults because of the intentional intake in psychiatric illness, mentally retarded, during alcohol intoxication, even incarcerated individuals seeking secondary gains. So mind you, it is 92% of the time that is intentional in adults. Impaction does occur more commonly in esophagus because of the anatomy with physiological narrowings. Age of the patient, very young patient, we have impactions and motility disorders like diffuse esophageal spasm, achalasia cardia, then various size, shape, and composition of foreign bodies also matter. So upper sphincter, there is impaction at aortic arch, then at left main bronchus and G junction. So these are the 4 areas where you will find impacted complicated foreign bodies. And these patients actually do have history of foreign body injection, but it can be absent in few of the cases. But if they're present with discomfort, choking, the refusal to eat, vomiting, drooling, blood-stained saliva, wheezing, and respiratory distress, we should actually expect foreign body injection in a child. Detailed history should be taken, and maybe we get hold of the foreign body outside by the attendants if possible. And signs and symptoms are very important. Vitals are to be taken care for, and any perforation in the chest or abdomen are to be examined carefully. Then imaging does support your diagnosis of foreign body injection. A plain X-ray, radiopaque foreign bodies, ultrasound of the abdomen if it is gone into the abdomen. A CT is a very useful modality. MR we usually avoid, but at times because there are ferromagnetic foreign bodies. So if there's a history and you find that there is a respiratory distress, straight away we go ahead and do endoscopy. If we find the foreign body, we remove it. If these symptoms are there and there's no history of foreign body ingestion, we do X-ray and find it. And if it is, we find the foreign body in the esophagus infected, we remove it. If there's no foreign body in the esophagus, symptoms are present, then also we go ahead and do endoscopy and remove it. But if it is absent, then actually we reassure the patient attendant. And as far as the management of difficult foreign bodies, initial resuscitation is very important. Medical management usually fails in a difficult foreign body. Endoscopic management is the key to success, and rarely we fail, and surgical management is the final answer. Before endoscopy, we do X-ray. Most of the radiopaque foreign bodies are seen, and the perforations and obstruction also are seen on the X-rays of the plain X of the chest and abdomen. A little X-ray does help to localize whether it is in the food, whether it is in the esophagus or it is in the trachea. And negative imaging doesn't exclude the presence, because there are radiolucent foreign bodies which are not picked up on X-rays. Oral contrast is contraindicated in these patients because of the chance of aspiration and difficulty it gives during the endoscopic removal. Halo sign does tell you whether it is a disc or not. Coin is very homogeneous, and a little step of picture shows that it is disc battery. Emergency endoscopy is required less than 6 hours if the foreign body is sharp and this battery is taken and it has caused a complete obstruction. Semi-urgent, that means 6 to 24 hours. Sharp foreign bodies in the stomach or duodenum, or they are long foreign bodies, long enough to do not grow across the curve of the duodenum. And a non-urgent means a blunt object, foreign body lying in the stomach, and there are no features to suggest any complication. So you may actually wait for up to 48 hours in these patients. Endoscopic management, actually assessment for the need of endoscopy right at the go. We should see whether endoscopic removal is required or not, that timing, whether it should be urgent or not, and then pre-procedure preparation is the key to success. Adequate sedation, few may require intubation. Choose to use the correct endoscopic equipment is also important, and post-procedure, all complicated should be actually managed for 24 to 48 hours. Conscious sedation should be done in almost all patients. GA is required and elective endotracheal intubation when a prolonged procedure is anticipated and complete esophageal obstruction is there, and there are multiple comorbidities and the child is very small. A head low position is always better, because if you actually leave the foreign body in pharynx, then it may not go to trachea. As far as the equipment is concerned, we have endoscope, rigid or flexible retrieval devices, and the protective equipments required in few cases. Rigid endoscope normally we don't use, but if there is a large foreign body in the upper esophagus or the sharp foreign body hypopharynx, then we require, but it can lead to higher chances of perforation. Flexible endoscopes are recommended in children more than 10 kg, standard gastroscope, adult gastroscope. But if it is a child of less than 1 year of age or less than 5 kg, we use actually pediatric scopes. These are the various devices which are to be there whenever there is a foreign body encountered. Standard biopsy forceps for small objects like pins and needles. Red tooth forceps required for finer tissue handling because it leads to minimal trauma. So stent removal, any other soft foreign bodies. Alligator forceps of various surface irregular foreign bodies like coin, then it is a accessory of choice. Then we have actually tripod, pentapod. These are required for removal of food bolus. Then we have snares. These are very ideal instruments for removal of blunt objects, especially dentures, and then we have retrieval net rod basket to remove multiple small objects or a slippery object. Overtube is indicated whenever there is a sharp or pointed object, and this batteries and long objects more than 6 centimeter size, a large bolus which or bezoars to be actually, multiple attempts are to be done, or any foreign body which is to be fragmented and to be removed, then we use overtubes. Short of overtube, we have protector hood, which can be used in the absence of overtube, especially in children, because in children the chance of perforation are more. This we can make ourselves. And then sharps in esophagus, it's a medical emergency. Direct laryngoscopy is required if it is the upper esophagus, and cricopharynx, again, if it is below the cricopharynx, we have to take with the use of endoscope. In stomach, the risk of perforation sharp is as high as 1/3 of the patients, so should be removed endoscopically. And anything which is beyond the reach of the endoscope, it has to be closely monitored. If it is not progressing, if it is sharp, it has to be removed surgically. Then we have to actually, all sharp foreign bodies we have to align, and then the sharp end comes should later while removing it, and we have to have a protector hood or a cap over the endoscope while removing them. This batteries, again, there are problems because if it gets impacted, it can lead to necrosis and perforation. So it has to be removed. It is impacted in the esophagus. In stomach, you can wait depending on the size. If it is small disc, you can wait for 24 to 48 hours. But if the child is small and the disc is relatively large, you have to remove it early. Blunt objects, these are very commonly seen, commonly encountered coin. You can remove them easily unless until they are impacted, because it can also lead to necrosis and perforation. So any foreign body which is impacted has to be removed urgently. And if something has gone beyond stomach, most of them actually pass off. You have to actually, repeat the X-ray to see whether it has passed off or not. And all ferromagnetic foreign bodies can be removed by using magnet, which we make it indigenously. As far as narcotic packs are concerned, endoscopic removal is a contraindication, because if you puncture it, you lose the patient because of the toxicity of the narcotic in that patient. And so surgical intervention is done only when the packets fail to progress or there are signs of obstruction. As far as the rectal foreign bodies are concerned, they are accidental or voluntary. They can be sexual, non-sexual. Assault can be there, or again, there can be actually drug packs, smuggling. If they are lying high, that is above the sacral curve or a rectosigmoid junction, or a low lying, because the high lying foreign bodies in the rectum, there are less chances that it can be removed endoscopically, and 2.5 times more chance that surgery may be required. And one has to rule out actually peritonitis in such patients. A direct rectal examination is important, which indicates the proximity of the foreign body to the pelvic floor. So evaluate and document the functional status of the sphincter as well, because we have to relax the sphincter when we actually remove it. Avoid doing a rectal examination if there is a history of sharp foreign body, because you can injure yourself. And if there is an sphincter damage while actually foreign body is getting inserted, we have to repair that post removal of the foreign body. The methods are transanal extraction for distal accessible foreign bodies by giving sedation to these patients, or by various endoscopic methods, or ultimately surgery. Endoscopic removal, if it fails, if the transanal extraction fails, then endoscopic removal should be done. Foreign bodies which are lying higher up in the rectum and colon, endoscopic removal is of choice. Enemas and stimulants should not be recommended, because if there is an impaction of the rectal foreign body, it can lead to obstruction. Then various equipments, polypectomy snares, foreign body forceps, guide wire with balloon dilator to inflate proximal to the foreign body, and then you retrieve across the anal sphincter. So if there is a rectal foreign body and peritonitis is present, straight away we take them for surgery. If the object is palpable, a transanal extraction is suggested. If it is successful, it is yes. Then otherwise, we have to do a conscious sedation, then various extracting instruments are to be used. If it fails, again, endoscopic removal is the treatment of choice. Various endoscopic accessories can be used, and if it fails, then again there can be a combination of endoscopic removal and a mini laparotomy, so as to push the foreign body distally with the surgical instruments. And patient has to be observed for 24 hours post endoscopy. And if there are features of peritonitis, then a divergent coloscopy is also indicated. So in summary, proper history and examination is required before subjecting these patients for removal. You have to stabilize the patient, resuscitate the patient, and assess for the complications which can be encountered in a complicated foreign body. A relevant and a timely investigation should be done. A timely intervention according to urgency should be decided whether it should be done urgently, semi-urgently, or the next day. A correct selection of accessory over tube should be done in few cases only. A dry run, if possible, is the key to success, and conscious sedation should be done in all. GA should be done in small kids and complicated cases, and patient to be observed for 24 to 48 hours post removal in impacted and penetrating foreign bodies. And removal not always indicated. This 6-month-old child came 3 days ago with an injection of a foreign body, a earring, and we asked them to wait, and 2 days later it was lying in the rectum. And yesterday I got a telephonic call that it was passed in the stool. So all foreign bodies may not require removal even in small kids. All foreign bodies can be removed by not only conventional instruments, but you can make your own indigenous instruments which make the procedure cheaper and effective at the same time. Thank you for your patient hearing, and you all are invited for ISGCon in Jaipur from 5th to 8th January 2023. It will be a not only academic piece but a hospitality also. Thank you very much.
Thank you, Dr. Nijaman, for a wonderful description of such an important topic. You can join us here.
If you have time, I can ask 2 questions.
Yeah, sure.
Can we have the slides, please? No, last, yeah, 35th. Now, a 12-year-old boy with history of accidental ingestion of a foreign body presents 4 hours later with drooling of saliva, absolute dysphagia, and a retrosternal pain. What single investigation would you do? CT thorax, chest X-ray, barium swallow, or X-ray abdomen erect? CT thorax, yeah. Somebody gave the answer. It is the right answer because all foreign bodies cannot be picked up on a simple X-ray. A barium swallow is contraindicated, and X-ray abdomen is not required because the symptoms are esophageal. The next question: for a large denture in the esophagus, what would be the best endoscopic accessory to be used? Rat tooth forceps, retrieval balloon, large roth net, snare. Snare is the correct answer because rat tooth forceps may not actually catch hold of a denture. Retrieval balloon, you may fail, but if it comes to the throat in a old man, it can go into the trachea. A large roth net may not catch it, so snare is the accessory of choice.
Thank you, Dr. Nijaman. So we had 4 very interesting talks on actual GI emergencies during endoscopy. Foreign bodies, we all have learned that when to intervene, when to wait, and it is important that caution should be exercised in taking out the foreign bodies, particularly the sharper ones. Dr. T.S. Chandrasekhar told us about GI bleed during ERCP and how to control use of simple things like noradrenaline or saline injection, and particularly keeping in mind that you should have a fully covered stent for the ultimate possibility of using that in bleeds, particularly the coagulopathy, biliopathy, and exsanguinating bleeds. Dr. Goenka very elaborately told us how to prevent post-ERCP pancreatitis. This topic has interested each one of us, and something simple using indomethacin or diclofenac suppository can help prevent a large majority of patients. And to add to that, either use a pancreatic stent or hydrate well, or a combination of these. I think it should not be taken lightly, and you must categorize the patients on table whether that patient has turned into a high risk and take due precautions. We all know what a nightmare post-ERCP pancreatitis is. Dr. Nageshwar Reddy showed us perforation, though it's an uncommon complication, yet for anyone, it can be a real trouble. So most important is identification of the perforation. Do a check X-ray at the end of the procedure, or even during the procedure, look at the fluoroscopy, look at the air, and always use carbon dioxide for the procedure. So early detection can help early intervention, and quite often you'll be able to close the perforation or use a conservative mode of treatment. We can have just one or two questions as we are running short of time. Yes, Kenzo?
Yeah, I really asked my mentor over last 3 decades. Still, he's my mentor, Dr. Goenka. Yesterday, we had a huge discussion on with Deepak Gunjan was the speaker about acute pancreatitis and fluid. See, there were days I said that in 1980s, 90s,
Dr.
low
Kinsok,
fluid. Just one, very short. I'll make very short because Dr. Goenka was not there. So then we increased the fluid to 250 ml per hour and did aggressive hydration. Now we have decreased fluid to 90 ml per hour. So if in acute pancreatitis we are now decreasing fluid, then how can we use the same pathophysiology to prevent the acute post-ERCP pancreatitis and give overhydrations? So that's why maybe data is coming throughout the world. Even overhydration will not be helping us to prevent post-ERCP pancreatitis, and we give more of indomethacin or give a pancreatic stent.
I think your answer is very valid. Question is very valid. I don't have an answer, but whatever data is available till now, this is aggressive therapy. And the aggressive therapy is not like giving 8 liters or 7 liters in the 24 hours. It's just giving about 2.5 liters over a period of 8 hours. So as of today, we go with evidence, and the evidence suggests that this is a good way of preventing post-ERCP pancreatitis. But this is not the first modality. The first modality continue, as Dr. Kocher said, is rectal indomethacin, and then deciding, depending on how difficult the ERCP is, you decide whether you want to add pancreatic stenting to that or not. Yeah.
Kinsok, I'll add you. I'll take you back to the actual literature. Do not go by the reviews. Do not go by the meta-analysis. Go back to the actual literature. The original study of favoring excessive hydration was from Mayo Clinic. You look at the data, they had used only 3.5 to 4 liters in 24 hours.
Yeah.
Just that much.
Yeah.
And the term they used was a misnomer. It was not aggressive. Then they came down to 2,500 to 3,000 milliliters. So don't go by the term aggressive or non-aggressive. The other concept, which is more logical, is goal-directed therapy.
Yeah.
So maintain the parameters, look at the urine output. CVP is not a good marker of looking at the necessity of fluid. So if you go by that, no study will recommend more than 2.5 to 3 liters.
Yes.
And for post-ERCP pancreatitis, it is just for 4 to 8 hours.
Yeah.
So it is not aggressive. There is no contradiction in terms of was it aggressive, was it more conservative. There's nothing aggressive. No one is recommending 6 to 8 liters. Some of the guidelines using that aggressive word had suggested in terms of 250 ml per hour. So that was amounting to 6 liters. But very soon those recommendations were altered.
Yeah.
So just stick to the basic principles and stick to 2.5 to 3 liters.
Thank you.
So one, I think, very important carry home point, which is again for all the interventional GI people, the role of fully covered SEMS, which Dr. TSC alluded to. I think two major complications of ERCP. On one side, difficult to control bleeding, and the second is type 2 and type 3 perforation. So every GI unit should have fully covered SEMS in their armamentarium, because this is just placing is as simple. And this is the best rescue modality, I would say, for both these situations when one falls in difficulty of a scenario 3 and 4 of difficult to control bleeding, and at least the periveterian or a bile duct perforation.
If a patient develops post-HRC pancreatitis, so regarding what is the role of antibiotics in post-HRC pancreatitis?
I think the role of antibiotic in post-HRC pancreatitis is just like that in any acute pancreatitis. So we don't use antibiotics unless it's moderate to severe pancreatitis, but it also depends whether you've been able to achieve what you wanted to achieve during the ERCP. If your system remains obstructed, of course you have to give antibiotic. About the fluid, I'm coming back. Kinshuk, this is not, as Dr. Kocher said, it's the amount of fluid which you are talking about that's not going to aggressive versus too much or major or minor. But only thing is that when you're talking about post-ERCP pancreatitis and fluid management, it is not actually goal oriented, because here there's no urinary outcome which you are measuring. It's basically you pre-decide how much of fluid you have.
With this, I think we have to close this session. I thank all the speakers for a wonderful talks and a great academic discussion.
Thank you, Chairperson and speakers. We won't be having tea break since we are running late, and we will directly proceed to the next session. That is the second PGI gastroenterology oration. I'll request Professor Usha Datta ma'am to start this session.
Sorry, we will just directly move into the next very important session. This session is the second PGI gastroenterology oration. The Department of Gastroenterology instituted this PGI gastroenterology oration last year. This was to commemorate the role of stalwarts and academicians who have untiringly worked in the field of gastroenterology in India and put India on the world map with their contribution to science, teaching, and clinical care. PGI is the first institute in the country which started its DM program in 1971. Professor C.M. Habibullah was the first esteemed alumni of this department. Since then, we have had several luminaries of the like of Professor S.L. Broor, Dr. Kartar Singh, Dr. D.N. Reddy, Dr. Mahesh Goenka, Dr. T.S. Chandrasekhar, Dr. Khuru, Dr. Basin, Dr. Kocher, Dr. Naresh Bhatt, Dr. Patrick Kamath, and Dr. Shanti Swarup, and many others. There have been several eras in PGI, from its contribution to the field of luminal work, to pancreaticobiliary work, to endoscopy work. It has moved from strength to strength, thanks to the exceptional faculty, talented students who come here, and a system which has a dedicated emphasis on faculty-student interaction. The recent introduction of interventional endoscopy was pioneered by Dr. Narendra Dhaka, who was a dynamic and extremely skilled endoscopist. He was a wonderful teacher. We unfortunately lost him at a very young age. All our young faculty have been trained by him and are now doing spearheading work in this area. Professor D.N. Reddy delivered the first oration last year. We now have Professor S.K. Acharya, ex-head of the Department of Gastroenterology at All India Institute of Medical Sciences, New Delhi, to deliver the second PGI gastroenterology oration. He was my MD thesis guide, my guru, and is my mentor. There has been a long tradition of collaboration between the two departments of AIIMS and PGI in various academic pursuits. He has been a well-wisher of our department. Luminaries like him add respect and a huge weight to our oration itself. I now request Professor Y.K. Chawla to invite our chief guest, Dr. Acharya, to deliver the oration and also introduce him to the audience. Professor Chawla, please.
Thank you, Usha, for giving me the chance to introduce such an eminent person in the field of hepatology, not only in the country, but even internationally, Subrat Acharya. We've known each other since 1980 when we were both DM students at All India Institute. We used to work very hard. We had very tough teachers, but at the end of any issues that we had in our gastroenterology ward, we enjoyed working together. We had Dr. Sareen also with us and Dr. Kar. So we were the four people who worked for that department, and I would say that we learned a lot, and Subrat made a very big contribution in making us work hard. The second thing is our friendship grew from then, and he joined as a faculty in AIMS gastroenterology. I came to PGI Chandigarh. And then we started a program known as Current Perspectives in Liver Diseases. This we started in the year 2000, which successfully has carried on till this year as well. Both of us have retired, but it was one program that everyone was looking forward to. So this is about our own personal relationships. After retirement, I have joined him in AIMS in Kalinga Institute of Medical Sciences at Bhubaneswar, where again, he is the pro-chancellor and is controlling that institute. He is also the president of All India Institute, Bhubaneswar. And in the years to come, you would see that with his intervention and support of other people there, that institute has already come up very well, but it is going to go up further. Subrat has done exceptional work in the field of hepatology and gastroenterology. He used to work so hard that whenever I used to ring him up for any opinion or otherwise, at 11 o'clock in the night, because I knew he would be busy in the OPD or looking at different research projects. At 11 o'clock, he would always tell me, ki, main abhi khane ja raha hu. So which means he used to work every day, including Sundays, till 10 o'clock in the evening. That was the hard work that he put in. And I would only say that he's a role model for a lot of people. He's one of the most dependable and incorruptible individual. He was offered the position of director AIMS Bhubaneswar when it was being made initially, but he refused because he would not let his patients be away from him. And he wanted to operate from AIMS Delhi while the construction was on. That somehow got refused by the government of India. So friends, all the youngsters, you all know him as an academician, but I would have no hesitation in saying that he is a role model for all of us, not only the students, but even we seniors, for his intelligence, dedication, hard work. You talk of anything and it is there in him. And one of the most successful hepatologists that our country has produced. Thank you, Subrat, for coming all the way, and Usha for giving me a chance to introduce my very, very dear friend.
I would also like to invite Dr. Atul Sachdev and Dr. Chaubal to come and chair this session. Thank you. Thank you, sir.
Well, it's such a nostalgic when you're one of your old friends with whom you spend your younger days struggling, eating bread and chai in the dead of the night in the dirty canteen in the back of the ward after treating GI bleeds into the blood all over. Indeed, a nostalgia, pleasure of highest quality. Thank you, Yogesh. Thank you always. And thank you for your kind words for me throughout. You'll be surprised that throughout our careers, spanning over 40 years, he and me has remained like brothers not only friends. And it indeed, you will agree, great pleasure to be introduced by one of your closest friends in life. It is also a pleasure that a young girl, when he was running around in AIMS, in medicine world, breathless, always, and working hard. When I saw her interest and her intelligence, particularly sharp brain. I thought this girl should do gastroenterology. And I talked to her, will you do dissertation in gastroenterology? And those were the initial days of acute liver failure. And these and Usa Venkatacharya took up this study to identify the liver volume in acute liver failure by doing a CT scan using a grid which you estimate today for liver transplant. And from that day, Usa Venkatacharya, right, subsequently Professor Usa Datta, has become the chief of the most coveted institute in the country, that is PGI-GI, and has slipped into great shoes of luminaries of this department. Thank you, sir. You are very kind. And this auditorium, and Bahesh told you that he has come for drama, but many of us has come here to attend multiple educational meetings, multiple talks, and multiple learning experiences, which is unforgettable. The citadel of knowledge, this hall. Having said that, way back in 1980s, when in this country, acute liver failure was completely blindly followed. Whatever described by UK groups or French groups has changed. A lot of water has flown under the river. And we have found acute liver failure in India have distinct difference than rest of the part of the world. And we all know, we see them day in and day out. You'll see our patients are young, basically. There's a major difference. You'll see half of them are females, in contrast to most of the diseases which are dominated by males. You'll see in our country, 1/3 of them pregnant, threatening to lives, right? And most of them are caused by hepatitis viruses. And recently from Tamil Nadu, Sangeet and his bosses has accumulated rat poison. This is another important cause of acute liver failure in this country. Since they are young, like in the West, they have 9 liver. And when they are injured, an injury to the liver is a regeneration of stimulus for liver regeneration. And you know, liver is a very avid regenerative organ. So injury is sad. So they should all survive, but they have a high mortality because of the complications, because of liver failure that ensues, like encephalopathy, sepsis, and these are 2 major complications, and cerebral edema, which kills them. Renal failure, unlike West, is infrequent in this country because in the West, the causes are drugs, which are hepatotoxic and nephrotoxic. And therefore, if we buy time and allow them to have regeneration and prevent complications, the survival has improved. Indeed, it has improved from 10% to 80% today by all of you in extensive ICU care management, understanding the complications, correcting various biochemical and metabolic parameters has resulted in a survival rate of more than 50–55%. This has been all reviewed recently, right? There is a recent review, and Indian Association of Study of Liver had 2 extensive discussions and published 2 consensus, which has provided all the data related to acute liver failure from this country. And these were the experts and the people who provided the wisdom, expertise, they reviewed the literature, provided these guidelines. I've just summarized that. So the issues, as far as Indian context is considered, is each of this area which I've outlined are important and have probably a distinct form of approach for each. We all know that acute liver failure is an infrequent fatal complication of acute liver injury. which has many causes. We also know acute liver injury as a natural course. And most of the patients, right, have reserve, hepatic reserve, and they recover 90% of patients that are acute hepatitis. It started with prodrome, has classical acute hepatitis. If you have a prolonged INR, we call it severely acute liver injury. But if you have encephalopathy, the liver reserve further has fallen, and we call it acute liver failure. Within a short time period, in India, we call it 4 weeks. This gap actually varies from country to country. In England, original definition is 8 weeks. In USA, it is 26 weeks. Yeah, ASLD described it 26 weeks. I don't think any of you has seen a ALF after 24 weeks or 4 weeks of onset of acute hepatitis. So they have different causes. They have drugs and acid and other metabolic causes, which is a smoldering slow course. Hence, the natural course is different. Hence, their recovery rate is different. Hence, their liver regeneration process is different. And that's the basic reason. So INSL defines it is a clinical syndrome characterized by encephalopathy, jaundice, and prolonged prothrombin, INR more than 1.5, developing in a patient without pre-existing liver disease within 4 weeks of onset of symptoms. A few patients presenting with severe acute liver injury, which I told the prolonged INR, mostly due to drug injury, may develop after 4 weeks, but within 8 weeks. Now, if you see the etiologies in our country, these are collation of multiple studies. It's predominantly virus, in contrast to the Western country, which are paracetamols or drugs. So in our country, if you see, the viruses are major cause, but the viruses, to identify the viruses is important. I put in the red mark here, etiologically based outcomes in acute liver failure. They have all liver failures. They have all acute liver failures. But if you see hepatitis A and E, which is one of the major causes of acute liver failure, has a low mortality, multiple studies, in contrast to the other causes. I also told you that this is very sensitive. The rat poisoning recently in the whole Tamil Nadu is caused of 40% of their acute liver failure. And in them, they have seen plasma exchange actually salvage one therapy that works like wonders. The drugs, which is important in our country, are antituberculous. We have Delhi Indian Network by Harshad Devabharvi, which has been published already, where 1,400, more than 1,400 patients of acute liver injury were documented, and most of them are antitubercular. Hardly you will find paracetamol or other drugs. But complementary alternative medicine, indigenous drug constitute about 13 to 20% of such patients, which is our major cause. This is the distinct difference which you have. The third difference we have are pregnant. I told you both in epidemic and sporadic. Females outnumber males in this disease, and 1/3 of them are pregnant. And predominant 60% of them has marker for hepatitis C infections. So it was considered in the world that HIV associated ALF in pregnancy causes more death. That is, HIV is causing more death. But subsequently we saw it is not true. If you are pregnant, you have more chance to contract hepatitis C. If you develop hepatitis C, you have more chance to develop severe liver injury. But once you develop a severe liver injury, your natural course is same as other causes of severe liver injury in the pregnant. So therefore, the previous concept that they should be terminated is indeed wrong. It is harmful. A large number of 500 patients of pregnant female with acute liver failure. We analyzed this from way back in 2010. It was published and collected. We have this ALF mimics in our. We all know now dengue, malaria, leptospira, and scrub typhus, which can have severe liver injury and have encephalopathy and mimic your acute. And that's why the clinical suspicion and during particularly epidemic of one of those infections will be suspected. And these tests are very specific. You can always rule out because the etiology needs separate management and separate out. This is a subsequent problem. Now, if you see, this is I summarized at the beginning. This is a summary of our whole clinical presentation. But I want to focus your attention here is the natural course is very short. That is about 5 days. Whatever happens within this 4 to 5 days. The most 75% of that will occur in the first 3 days. If they improve, they will improve between 3 to 5 days. Right. So this is a very short course, very stormy course, very closely to be managed, and the results in our patients are excellent. The major complications in our patients are advanced encephalopathy, cerebral edema, and infections. We don't have renal failure or GI like West in paracetamol or NSAID. As I explained, they have caused toxicity both liver as well as kidney. Therefore, when we evaluate, there are certain things I have very important pointed out. These parameters should be in the checklist of management of acute liver failure to tick them in every 4 to 12 hours to assess their status and to find whether they are improving or not. Now, medical management doesn't work in everybody. So, transplant is a definitive option in such patients. But I told you natural course is very short. There is no time. So from the very beginning, you should be able to know the chances of outcome in such patients with medical therapy, or you start counseling them for a new liver and start contacting a transplant surgeon for that in your team. And there are various prognostic markers to identify this. One of them is commonest is King's, which I have listed, and multiple markers. Now, if you see the King's, we don't see paracetamol. So I'm ignoring paracetamol criteria for transplant. If you non-paracetamol induced acute liver failure, which is our patients, that indications prognostic marker for outcome or mortality are single prothrombin time more than 8 seconds, or any 3 of them. Age less than 11 or greater than 40. Etiology, that is non-A, non-B, non-E hepatitis. This is actually, they don't see E. This is King's College. Halogen or idiosyncratic drug use. And duration of jaundice more than 7 days before onset of episode. Based on this, they classify liver failure into hyperacute, acute, subacute, because they find the difference of mortality. Those who presented within 7 days, they have a higher survival, because transplant is a definitive option. We don't see such differences. So we don't classify our patients into acute, hyperacute, or subacute. So this is one of the important criteria. And prothrombin time more than 50 seconds or bilirubin level more than 70. If you see our patients, predominantly 80 to 90% of them do not fulfill these 3 criteria: age, etiology, or hyperacute duration. So 5 of the 3 criteria are not valid in our cases. It's very difficult to use this criteria. This is the criteria described by Dr. Thiemann, who is sitting here. This is one of the clinical criteria from this institute, where I define that clinical parameter like advanced age, jaundice to encephalopathy interval, presence of overt cerebral edema at presentation, advanced encephalopathy, prolonged prothrombin time, and kidney disease failure. Of course, kidney failure occurs much less. If 3 of these 5 criteria are present, the prognosis is very bad. From the very start, he will start counseling. And he found this is superior than the other scopes as well as which are used in other places. And in the meantime, there were studies from this country where they showed that ammonia level is a major determinant of whole pathogenetic process in acute liver failure. And gradually that story is being spilling over to chronic liver disease. Recent publication, you must have seen that even chronic liver disease, elevated ammonia, is determinant of long-term liver-related mortality, hospitalization, as well as complications. And way back, we saw admission of ammonia in the survivor is much less than non-survivors. It was an independent prognostic matter variable for mortality. But later on, we saw the ammonia kinetics is important. When the ammonia level persists over 5 days period, more than about 120 to 123 micromoles per liter, most of them will die. Whereas if it comes down, indicating liver cell is regenerating, therefore there will be ammonia metabolism. I call it a surrogate marker for hepatic regeneration. Remember, this is arterial ammonia, not venous ammonia, to be done in 15 minutes. Remember, ammonia is a volatile substance which vaporizes in room temperature. As a result of this, ammonia estimation is fallacious unless collected on ice, done within 15 minutes. And if you do ammonia in that fashion, this will give you exact better outcome than any other parameter. But it has to be done in that ICU where it can be estimated using a kit within 10 minutes intraarterial. And when we use this, we found, first thing, this is a large cohort study which was validated subsequently, where we found that high ammonia, advanced encephalopathy more than grade 2, prolonged INR more than 5, or bilirubin level more than 15 milligram, if it is progressively occurring over 3 days or persisting over 3 days from baseline, then the mortality is much more better predicted than the baseline predictor. These are baseline predictor, but the odds ratio for predicting outcome on day 3, if they are persisting, is significantly higher, which I have drawn in a bar here. If you see, the first one is the baseline, first bar. Second bar, if the day 3 it has come down. And third bar is if it has increased on day 3. And you see the mortality which I have drawn, right, in dark blue and survival in light blue. If you see it comes down on day 3, if it increases, see for each. So we scored them. We took their odds ratio, identified their beta integer, rounded up the number. And we found this is true also in the validation model, which is another model. They overlap completely. And when we scored them, we found there are total simple 6 scores. If you have on day 3, advanced encephalopathy, INR more than 5, arterial ammonia more than 123, or bilirubin more than 50. These are depending upon their beta integer. And if there are 4, mortality is more than 80%. If it is less than 4, mortality is about 20 to 30% is 1, less than 5%. This is the validation model. We called it early acute liver failure early dynamic model. This is 6 scores, and with 6 scores, this is the test group, blue, and the green is validation group. And with the increasing score, see the mortality rate. But most interestingly, you see this is a dynamic mode. Somebody who has very high score at baseline, it can improve. And you transplant him. They are unnecessarily transplant. Transplant is a swap. On day 3, they predict the outcome much better. If you see, he has alpha 3, which is in between. It can go both ways. And if you see the lowest score, which you will not list, it will change over day 3. And on day 3, you can take a call to have a maximum benefit. Therefore, this model has been compared, Dr. Salimar from AIMS compared this model with all other existing models. And on day 3, he found the area under curve is about 0.9, 90% accuracy. So for us, this is the best prognostic model. And we told you the second complication besides encephalopathy, which fields are infections. And we had a large database, and sepsis occurred within day 3 to most. And Dr. Salimar further analyzed this and published this. And we saw that if you have infection, the mortality is very high. See the first front red line, and other complications as well, very high. And if you see, ammonia was an important predictor. If you have infection, ammonia doesn't come down. If ammonia comes down, they improve. If there is no infection, ammonia comes down. And if your ammonia persists, the infection persists. Now we know ammonia causes neutrophilic dysfunction, prevention of liver regeneration, and that's what it should be removed. So principle of management, I need not go into the details because ICU care will be taken next week. These are basic principles I have written down. All of them need intensive care, right? And prevention of all these complications. And identification of the causative factor is very important that influence the mortality. And removal of toxic agent, one of them is ammonia. And acute liver failure is acute injury to the liver, forming dam, and transmigration of bacteria forming fat, causing a cytokine storm, which actually causes multi-organ failure. If ammonia and cytokines can be removed from circulation, you will salvage them in by time. They have a nice liver, which will regenerate. So these are basic principles. I will not go into the details because this will be discussed, but I have put in certain things in red, very important, besides fluid electrolytes, encephalopathy seizures, or cerebral edema treatment with mannitol, or hypoglycemia management. Important thing is high arterial ammonia and lactates. If they have high, you cannot remove them by any method except probably CRR. And it has been found to be very helpful in improving survival. There is no way to remove this fluids. Besides prophylactic antibiotics and other routine things. But ninth, I have added N-acetylcysteine as a routine parameters to be used, because if you see, there are now 7 studies and meta-analysis studies which document increased overall survival, transplant-free survival, as well as post-transplant survival, as well as in that. Acute liver failure is a condition where transplant itself is not easy. It's very difficult. Post-transplant events are very stormy, and we may lose patients of cerebral edema and sepsis. Therefore, in comparison to chronic liver diseases, acute liver failure results do not match. So this is why important, and daily prognosis is important. Etiology is important. I have listed certain causes where etiology specific therapy has been shown to improve survival. There are many etiologies, and therefore establishing the etiology is extremely important to improve survival. The time is up. But the specific therapy are certain drugs, CRRT, plasma exchange, and transplant. 4 things. I'll run through them quickly. Right. The first, L-ornithine, L-aspartate, which are actually substrate for urea cycle, thought to improve the urea cycle, decrease the ammonia. It didn't work because there is no hepatocytes. They're all necrosed, and it simply cannot convert them to ammonia. So in a randomized controlled trial, it failed. It failed because when you give L-ornithine aspartate in the muscle with the help of enzyme, right, ornithine becomes glutamate, combines with ammonia, goes to the muscle, and there is glutamine synthase, which again becomes glutamine, and glutamine go to the intestine. It is the energy for intestinal epithelial turnover. Intestinal has glutaminase. It breaks glutamine into glutamated ammonia, and ammonia circulate. So you have to remove glutamine to remove ammonia. That study actually indicated. Following that, Dr. Jalan from UCL, he used L-ornithine phenyl acetate because it's directly bind to the glutamine and excrete in the water, and ammonia level comes down. LOPA has been shown in pig model to decrease brain water content, increase urinary acetyl glutamine, phenyl acetyl glutamine, as well as improve their outcome in mortality. But in human model, this has been found to be safe, and this is the degree of ammonia according to dose-related LOPA, whose survival data is awaited because this has been patented by the US group. We cannot try it because they will not give it to us. They're trying, we will know that. I told about CRRT in a retrospective study. In a large group of patients, it has been shown to be beneficial, remove ammonia as well as remove lactate. But however, plasma exchange has come in a big way. We know about plasma exchange very well. And removed the circulatory, I will not go into the details of this cartoon, but it removes the circulatory cytokines and prevent multi-organ dysfunction. And in a large randomized controlled trial from multicenter study of Europe, indeed it showed survival benefit amongst patients with high plasma or high plasma exchange, particularly high plasma volume exchange. And that is quite large. That is about 15% of body weight. That is 8 to 12 liters per session. Average about 2.5 session. Done over 12 years period of time, collecting 180 patients. A lot of loopholes are there. But well, it showed it is a randomized trial. But what it showed importantly, that patients who are listed for transplant, indicating they have poor prognostic marker and they are unlikely to survive, when subjected to high volume plasma pheresis, they will significantly improve survival. That is important. This is the Indian study by Rakhi Mahiwal from ILBS, who took 20 patients in each arm to test the hypothesis that high volume plasma pheresis works. And she showed, and she actually, sorry, it is not high, it's standard one. She used 1 to 2 liters per session instead of large volume, right? And use about 4 to 5 liters over 2 to 3 days. In contrast to 10 to 12 liters, up to 15, 20 liters per day in the European trial. And she showed that indeed survival is significantly, markedly better in such patients. And these are uncontrolled study of plasma pheresis, but the meta-analysis also showed benefit. Therefore, both INSL and ESL recommend plasma pheresis as a grade 1 evidence and should be routinely used in patients with acute cough. So in summary, I will say acute liver failure in India is predominantly due to hepatitis viruses. Anti-tubercular drug and complementary alternative medicines are important drug-induced causes of acute failure. Our patients are young and has a female preponderance. Quarter of them are pregnant, and hepatitis E virus is the major cause, and we don't recommend termination in that. Survival frequency in HIV and HIV-ALF is less than 50% in contrast to other. And you see the prognostic model to choose transplant in our setup, which is a dynamic model, is much more accurate for our patients who have viral hepatitis. It is also a survival model because a very bad patient, you can assess and tell that he will survive on day 3 with the expected management. And predominantly liver transplant till date is live related enough, right? And 1 year survival, which is I collected from all centers, is reaching almost 75 to 80%. But then you are able to provide that to an extremely small group of patients. What I want to emphasize at the end of my say that our patients are very young. 1/3 of them pregnant. 2 lives for a viral disease in a naive liver. Don't write them, right? Doing a regular monitoring and correcting their electrolytes, the glucose, preventing the sepsis, and looking for cerebral edema will be buy you time. They deliver themselves regenerate. They will walk out. In contrast, think about a transplant. You are operating 2 people, right? The drugs, post-transplant complication, first 3 complications, primary non-function, hepatic artery thrombosis, second week, third week, hepatic vein thrombosis, portal vein, rejections, sepsis is a war. You salvage them, you monitor the drug regularly, right? Then comes biliary restriction. Then you start in putting stents after stents, causing the dilatation. So I call it a swap. In a group of patients, in a country where the disease is occurring on a naive liver, where the stimulus is injury and the stimulus causes liver disease. Thank you very much.
I'll now request all of you to stand and give a rise and give a standing ovation to Professor Acharya for his lifetime work in this field.
Thank you,
I
sir.
haven't known a more dedicated clinician scientist in our country like. Thank you, sir.
Thank you.
Thank you, sir, for beautifully summarizing the ALF aspect and
Arusa, I didn't think you need any things to say like that or Jogesh, because all of the fellows whom I am seeing, they will pull my legs later on, right? They are all friends with whom I grew up. Mahesh, Rakesh, everybody, Ashwini, Anup, Radha, and the great fellows are standing there, and General Anand, Pankaj, who is my boss now, PC Sharma, Kingsu, with all I grew up, right? Thank you very much.
Thank you, sir. So now I would request Professor Yogesh Chawla, sir, to honor the Professor Acharya, sir, by giving the shawl. Now I would request Atul Sachdeva, sir, to present the plaque to sir. Now I'll request Chaubal, sir, to present the memento to Acharya, sir. And I'll request Professor Usha Datta, ma'am, to present the flowers to sir. Thank you, everyone.
So now we'll have our next session. The topic is ALF in the ICU. To chair the session, I'd request Dr. Virender Singh, sir, Professor, former head of the Department of Hepatology, PGI-GI Chandigarh, and Dr. Navneet Sharma, sir, Consultant Department of Internal Medicine, PGI-GI Chandigarh. And may I introduce the panelists, Dr. BC Sharma, sir, Consultant, GB Pant Hospital, New Delhi, Dr. Ujjal Poddar, sir, Professor, SGPGI Lucknow, and Dr. Purna Chandra, sir, Senior Consultant Gastroenterologist, Bangalore. This will be an online session, and I'd request Dr. Ujjal Poddar, sir, to please introduce the speaker and carry on the proceedings. Thank you.
Dr. Ujjwal, you are supposed to introduce the speaker. There is some confusion. Let us start with the case-based
There is
discussion.
no confusion. What is Purna? One more panelist. Akash is unwell, so that's why physically he couldn't come, but he will do it online. As he prepared the slide, he sent the slide to all the panelists. So there is no confusion. It will be a smooth sail. Dr. Akash Shukla is Professor and Head, Department of Gastroenterology at GS Medical College and Kane Hospital, Mumbai. Akash, are you online?
Any connection problem, Musa?
I think there is a little bit change in the program. Sunil, please you join us as a panelist.
We can have the next session.
Dr. Deeman is here. Can I request Deeman sir? Can you take your talk? Can you take your talk now? Professor Deeman has agreed. Just 1 second. Professor, I understand. Professor Deeman has agreed to take a talk on approach to hepatic encephalopathy to just fill in this gap. In the meanwhile, we'll establish contact with Dr. Akash. Please continue to chair the session. Dr. Deeman will come on stage. Thank you, sir. लैपटॉप से कनेक्ट कर लेंगे हाँ हाँ बिल्कुल
शरीर भी क्या ऑनलाइन
Dr. Deeman is well known to this audience. He was head of the department of hepatology at PGI. Now he is director at SGPGI Lucknow. Dr. Deeman.
Thank you, Dr. Virendra. Thank you, Professor Usha, for inviting me this wonderful conference. And I can see the house is full, especially with the students who are appearing in the various examinations of the DM in gastro. So I have to discuss with you approach to a patient with hepatic encephalopathy. So framework of my talk would be classification, then minimal hepatic encephalopathy, and management of overt HE in a hospitalized cirrhotic patient, and the prevention of HE. As far as the classification is concerned, there are various domains. First is the type A, B, C. A is associated with acute liver failure, B for bypass, that means the portosystemic shunts, and the C is with the cirrhosis that includes both the liver disease as well as the portosystemic shunt. As far as the grading is concerned, we all know about the West Haven criteria. It includes grade 1 to grade 4. And recently, the patients who do not have any symptoms or signs of neurological involvement, once they are subjected to the neurophysiological and neuropsychological test, you find abnormality, and this entity is known as the minimal hepatic encephalopathy. And the recent guidelines, they have merged the grade 1 hepatic encephalopathy as well as the MHE as a covert, and the other is the grade from grade 2, grade 4 is the overt. Because you can diagnose grade 2 hepatic encephalopathy with confidence, that is the temporal disorientation with or without asterexis, which is not present in grade 1 encephalopathy. Then the time course, episodic, recurrent, and persistent. And last is the spontaneous or precipitated. So coming to the episodic or the recurrent, you can see a bar that is the clinical detection level. If there are the distinct episodes are there, and between the episodes, there is no neurological deficit or disarrangement, then we can call it the episodic or recurrent. Recurrent means if there are more than one episode within 6 months, then it is recurrent. And if the bar, all the episodes is above the clinical detection level, then it is called as the persistent. If it is below, then it is minimal, which is, I have already told you, detected with neuropsychological or neurophysiological testing. So I'll tell you that recently the EASL guidelines have come only a month or two before, and they have suggested the use of the West Haven criteria when at least grade 2 hepatic encephalopathy is present. And in patients with no or mild neuropsychiatric abnormalities but without grade 2 HE, a neuropsychological, neurophysiological, or therapeutic test should be done to diagnose covert HE. Means if 2 plus, then West Haven criteria, otherwise testing with the neuropsychological or neurophysiological test. In patients with the grade 3 and 4 West Haven criteria, the Glasgow's common scale should also be used. Coming to the minimal hepatic encephalopathy, I have just told you it is detected when there is nothing is present on neurological examination. When what you do is the neuropsychological, neurophysiological tests which are abnormal. And this minimal hepatic encephalopathy or the covert hepatic encephalopathy is associated with the cognitive decline as well as the decrease in the work productivity. And there is a high risk of the development of the overt HE in these patients, and there is even high mortality. There is a driving impairment, and there is an impaired quality of the life, sleep disturbances, falls, leading to the injury and others. And not only that, there is a burden on the caregivers and the burden overall healthcare system also. So it is important that we must look at it and treat it also. As far as diagnosis is concerned, there are so many tests, but I have chosen only a few tests here. Standard psychometric test, basically they tested psychomotor speed, visuomotor coordination, attention. It took around 20 minutes, but it has a poor specificity. The golden test is basically in this patient is the FES, psychometric hepatic encephalopathy score, which included 5 tests: number connection test, figure connection test, serial dotting test, digital symbol test, and line tracing test. And it is very important that it tested various domains that including psychomotor speed, set shifting, attention, visual perception, visual spatial orientation, and visuomotor ability. This is a gold standard, and it took around 15 to 20 minutes. And there is another animal naming test that you can name as many as names of the animals within the 60 seconds. This is a bedside test. This is basically a screening test, having the higher sensitivity, highest sensitivity. Once it is present, then you have to go to the specific test. Similarly, the Stroop test.
Should covert HE be screened or in the clinic or in the ward, and how? So what does clinical guidelines from the EASL recommend? In patient with the cirrhosis and no history of overt HE, screening for covert HE should be performed with this test for which experience tools and the local norms are applicable. So what is more important, once the validity of the test in a particular country or a particular population has been demonstrated, only those tests should be used, otherwise no. And at the only bedside test available to date is the animal naming test is worthy for further study and the validation. I think this test has also been validated in the PGI itself by Dr. Taneja. So you can use animal naming test and followed by the fact that we also have the norms in India. So for the screening and then confirming in India, we have both the tests. Comparative efficacy of the treatment option for the MHE. If you want to treat, then what to do, which drug you have to use basically. We have done a systematic review and the network meta-analysis. And based upon this, the clinical practice guidelines from the ECL, they recommended the treatment for the lactulose because the lactulose was more effective in reversal of the MHE as well as the prevention of the overt HE. So this meta-analysis was very, very important. And what does the CPG say or recommend? Clinical practice guidelines say the patient with the covert HE should be treated with non-absorbable disaccharide, what we have demonstrated in our meta-analysis. And this is the first time any society has come for the treatment for the minimal or the covert hepatic encephalopathy. And in patient with the covert HE, anti-HE treatment should be considered for purpose of the differential diagnosis and to prevent overt HE. So I have told you, prevention of the overt episodes of the HE is very, very important, and more important is the differential diagnosis. In a patient who is about 60 years of the age, if you treat and all the psychomotor abnormality reverses, then you can say minimal HE. If it doesn't, then you have to look for the other causes, for example, dementia and other things. So this is the algorithm. And the algorithm say that in patient with the cirrhosis, they might be having the portosystemic shunt. Any past history of the OHE is there, then you treat with the lactulose plus minus rifaximin. If you suspect shunt or demonstrated, occlude it. If it is not there, you do the clinical assessment with the mini-mental score. If it is less than 25, treat it as a OHE with the treatment. If it is more than 25, look for the history of the falls, accident, reduced work productivity, then again you treat it. If nothing is there, then comes the role of the neuropsychometric testing. And if it is abnormal, then you label is MHE and treat with the lactulose as per the recent clinical practice guidelines. If it is normal, then you have to see that the patient is at high risk of development of the HE, then you can treat. That is called as the primary prophylaxis. Management of the overt HE now coming from the MHE. So attend airway, breathing, and the circulation, what Dr. Acharya has also said for the acute liver failure management also. And the patient with the grade 3 and 4 and the Glasgow of the less than 7, they are at risk of the aspiration. They should be intubated and they should be managed in the ICU care. And in patient with the delirium or the encephalopathy, there is role of the imaging. You can either go for the CT scan just to rule out any intracerebral pathology. And you have to look for the hypercapnia, hypoxia, because you have to maintain the cerebral blood flow in these patients. And inotropes should be used to maintain the arterial pressure to ensure adequate cerebral perfusion. I think these are the very, very important things when you are treating a patient with the hepatic encephalopathy. Always look for the alternative cause, because this it doesn't mean that a cirrhotic patient who is having the alteration in the sensorium, that he would be having only the hepatic encephalopathy. Look for the metabolic, like the diabetic, hypoglycemia, ketoacidosis, alcohol, drugs, particularly the benzodiazepines, neuroinfection, intracranial bleeding and stroke, where you require the imaging also, epilepsy and others also. And what does this EASL's clinical practice guidelines recommend? They say with 100% consensus that in patient with the suspected HE, alternative and additional cause of the neuropsychiatric impairment should be identified to improve the prognostic accuracy and the result of the treatment. Okay, this is very, very important. And in patient with the delirium and encephalopathy and the liver disease, plasma ammonia measurement should be performed because a normal plasma ammonia level rules out practically the hepatic encephalopathy. And there is no imaging that you can say that if you do that, this patient is going to the HE. Identification of the precipitating factor and their correction. I think this is the most important part when you are treating, and this is the standard teaching that when we were the student, we were also taught like this, that look for the infection, GI bleeding, diuretic overdose, treat them, and the HE would be reversed. And what does EASL CPG say? In patient with the HE, precipitating factors should be sought and the management. This is the very, very important. I think when you go first to the patient, you look for these precipitating events also for minutes. So commencement of the empirical treatment, you all know lactulose, non-adsorbable disaccharides. And in the meta-analysis, it has been proven that lactulose is beneficial on improvement for the improvement of the hepatic encephalopathy, and this meta-analysis also reported that the mortality also goes down. And not only that, treatment with the NADs is associated with a beneficial effect of the serious adverse events, including liver failure, varicose bleeding, and severe infection, including the SVP also. And would you like to add the rifampicin to the lactulose? If yes, then what are the results? These meta-analyses have demonstrated. If you further add rifaximin to the lactulose for the treatment of the acute episode of the hepatic encephalopathy, it also improves the incidence of the effectiveness rate as well as on the mortality. So whenever you have the patient diagnosed, then you can start with the lactulose as well as the rifaximin also. L-ornithine L-aspartate. There are several studies, small study, but most meaningful study that I'm presenting in front of you, it was done by Dr. Sidhu, published in Hepatology, and it has demonstrated, we look at the day 1 to the day 5, the percent of the patient with the resolution of the HE is much more in combination therapy, LOLA plus lactulose when compared to the lactulose alone on day 4 and day 5. This beneficial effect goes off. Therefore, if you have to use for some reasons L-ornithine aspartate, it has to be used intravenously for 3 days only. Polyethylene glycol is the same pack that you use for the colonoscopy preparation also, and it has demonstrated that if you use the polyethylene glycol, that is the 4 liter, the 2 packets, and what they have demonstrated that HESA grade, HESE is the grading system for quantifying the hepatic encephalopathy. It goes down, it improves much more. That is from 2.3 score to the 0.9 in polyethylene glycol group than in the standard group. And the time to resolution is much faster in the PEG group also. We found the similar results in patients with the hepatic encephalopathy and acute on chronic liver failure also. Albumin administration, I think it is a complete talk by the Professor Sareen. You have to concentrate on that also. But I would like to tell you, there are the 2 trials with the contrast result. One comes from the Delhi, Professor B.C. Sharma, who is sitting over here also. And they have demonstrated albumin plus lactulose is far better than the lactulose alone therapy. And reversal of the HE is much higher, mortality is also improved, and the hospital stay was also shorter. And what's about the liver support system? What the EASL guidelines recommend? On the basis of the 3 randomized controlled trial and 1 meta-analysis that in patients with the liver failure and overt HE, albumin dialysis, that is the MARS, ameliorates HE and can be considered, but it does not improve on the mortality also. Criteria for the liver transplantation. I tell you that the in patient with cirrhosis, development of the overt HE has been associated with the poor transplant-free survival. I think this is the poorest when you compare with the other complications like the ascites and UGI bleed. And the first episode of the overt HE should prompt referral to a transplant center with initial evaluation. And if it is more than one episode, then you have to consider for the liver transplantation. Nutrition is very, very important. And BCAA you can use in these patients also. If there are the portosystemic shunts, there are the two kinds of shunt. One is the porto cable, another is the periumbilical. You can occlude them with the embolization also, and the recurrent of episodes of the hepatic encephalopathy, they improves. And the only thing that you have to take care of, that there should be underlying good liver function. MELD score should be 11 or less than 11. That is the important thing. And finally, coming to the conclusion of the overt encephalopathy, again, ABC, airway, breathing, and the circulation, and exclude other causes. I already told you, metabolic causes also, alcohol and other things also. And once the diagnosis of the hepatic encephalopathy is confirmed, and the patient is in grade 3 or 4 with the Glasgow Coma scale of the 7 or less, admit in ICU and intubate. And then general measures, I have told you, direct treatment of the precipitating factor. That is the foremost, most important thing. You have to look for it. And second is that after treating those things, then you come to the specific, I just discussed you do, the role of the lactulose, rifaximin, PEG, L-ornithine aspartate, BCA, embolization, and the MARS. And with this, thank you so much. One question is there. Can I ask them? Is
Yeah, go
time
ahead.
permit?
Go ahead, go ahead.
Go ahead. Okay. In patient with the liver cirrhosis and a history of or with covert HE, which one of the following is not correct? I'm saying the not correct. During driving I have not discussed it, but I am asking you. During driving simulation studies and on driving tests, patients with the cirrhosis and HE have been shown to exhibit, means the covert HE have been shown to exhibit problems with vehicle handling, adaptation, cautiousness, and lane keeping, etc. And patients with the cirrhosis and cognitive impairment, that is MHE or covert HE, have more documented traffic accident and violations compared to the unimpaired patients with the cirrhosis. Third is treatment with rifaximin in randomized trial has been shown to improve driving simulator performance in patients with the covert HE. No single psychometric test has the ability to reliably divide patients into the safe and unsafe driving. And lastly, it is not mandatory to give verbal and written advice to avoid driving following an episode of the overt HE. Anyone can answer which is not correct. 5, that is correct actually. So whenever anybody is having the overt episode of the HE, so you have to give advice not to drive, both verbal as well as in writing on the prescription paper. Thank you so much.
Thank you, Dr. Veeman. If there is any burning question or comment, we can have it. Otherwise, we go to the next talk. By this time, Dr. Akash is online.
Yes,
Yeah.
sir.
Dr. Kensho.
Yeah, Dr. Dhiman sir, again, you are my teacher 30 years back. So we get always a call from neurology department, internal medicine department, as well as oncology department. The ammonia is 215, patient's altered sensorium, ultrasound liver shows normal or may not have been done. And they have already started on rifaximin, lactulose, and they have learned from us that they started on lactulose enema. Now we know that this 70-80% of raised ammonia is caused by non-liver causes. Should we go non-hepatic causes? So should we go there and stop those, or we treat as ammonia toxic ammonia reducing drugs as that?
You mean to say that just to revise, a patient from different departments without liver disease or with liver disease?
Yeah, without a liver disease, because of either seizures, because of sensorium, because of IC bleed, because of disturbance in electrolytes, sepsis, solid organ tumors.
And you say ammonia is raised.
And we are called that treat this.
Now, if ammonia is raised, then it is logical to give anti-ammonia drugs also, which include lactulose, alvelose, rifaximin. But at the same time, I would suggest two things: that you should go for the imaging to look for the cirrhosis of liver. Simple bedside test is the FPRI and the FIB4 also. And another is the fibroscan and the imaging. And imaging will also tell you if there is the portocystic shunts or not. But if ammonia is raised in these patients, if somebody has started anti-ammonia treatment, you cannot stop.
Yeah, these patients are mostly on ventilators or something like that. So you can't shift them down for an hour. RFE is not always possible to do
Then
that
wait
at
and watch
bedside.
till they improve.
Yeah, still they
Yeah.
improve. Yeah, my personal experience is also that. The second is, do you ask for a venous ammonia better than arterial, or capillary ammonia better than
Whatever
arterial?
is available is okay.
Whatever
That
is
okay.
available. Thank you, sir. Thanks.
Thank
With that, we come to an end of this talk. Can we have the second talk by Dr. Akash, ICU management of the ALF? Is he ready?
Yes, sir, I'm here.
Yeah. Dr. Ujjal.
Yeah, Akash, you can start.
Are my slides visible?
Your slides. Yes, you are visible. Your slides are also visible, Akash. Akash, let me introduce. We have Dr. Virender Singh, Dr. Navneet Sharma as chairperson. And in the panelists, we have Dr. Brijesh Sharma, and instead of Purna Chandra, Sunil Taneja, and myself, Dr. Ujjal Poddar. So you start your presentation. If there is any coordination required, I am here.
Great. Thank you, sir. Good morning, everybody. At the outset, I must apologize for not being able to make it physically there because of health issues. This is a 24-year-old female, otherwise healthy, who presented with malaise and generalized weakness for 7 days. Low-grade fever 2 days, for 2 days, 7 days ago. She was having some low-grade fever before that, intermittently for 4 to 5 days. Nausea, vomiting, and jaundice and encephalopathy for 5 days and 2 days. So if jaundice to encephalopathy period was 3 days. So this patient was admitted elsewhere for jaundice and nausea, and then referred because of the worsening of hepatic encephalopathy, that is confusion, agitation, and then progressive worsening sensorium. There is no past history of any liver disease. When she comes to the emergency room, her blood pressure was 126/50, pulse rate was 118, she was ecteric. There were presence of bilateral basal coarse crepitations. She is drowsy, reacting to painful stimuli, and not following commands. Pupils are equal and reacting to light. The cardiac system was normal. She is febrile with a temperature of 101.5 degrees and abdomen is soft. The emergency investigations done in the ER show sugars of 70 and arterial blood gases showing pH of 7.32 with CO2 of 30. And on 2 liters of oxygen, her PO2 was 100. Bicarbs were 15 and lactates are 8. X-ray showed a right lower lobe collapse. She was resuscitated in the ER. The fluids were given. Investigations were sent. A discussion was there about whether we should intubate her or not, and what imaging should be done, and whether she requires anti-brain edema measures. So this was the decisions which we had to take in the first hour. So the investigations that we sent showed a hemoglobin of 10.3, WBC count of 7,800 with 72% neutrophils, platelets were 80,000, creatinine was 2, uric acid was 7, electrolytes were showing sodium of 140, potassium of 3.7, chloride of 108, amylase lipase were normal. Bilirubin was 10.5 with direct of 7. SGOT was 1070. SGPT was 1650. Alphos was 81. GGT was 73. Albumin was 2.3. And ammonia levels were 320. Dr. Dhiman just spoke about the importance of ammonia, and the importance of ammonia levels in patients with acute liver failure cannot be overemphasized. And the INR was 3.4. So the first question to the audience, do you think this patient needs a liver transplant? Yes or no? Buddha, can you take a...
From the audience, what do you think that this patient should be sent for liver transplant? Yes or no? You got the history. It looks like a hyperacute liver failure. INR was 3.4, bilirubin 10, ammonia 320. Anybody? Liver transplantation at this stage? No? Any volunteer? Experts?
Sir, I
Yes.
think the patient should not be sent for a liver transplant right away. The patient has several atypical features that suggest away from a viral cause of acute liver failure in this condition, and probably can be monitored for now. Sir.
Akash, we got a response from one of the residents say that he'll wait because looks like it is a viral hepatitis.
So non-viral hepatitis.
We don't have a investigation yet, but you said that you want to wait.
Sir, the patient may have a tropical infection like leptospirosis in this presentation. So
Okay.
we would like to treat for that in
Okay. Because of this persistence of fever, you want to investigate for tropical infection. That's your answer, right? Akash, you got the point?
Yeah, I got the point. So I think at this stage, I would agree that this is not a patient who should be immediately taken up for transplant. Multiple reasons. One is we still don't know the complete diagnosis of this patient. Second is it is a hyperacute liver failure. Third is we are dealing with a lower lobe consolidation with pneumonia, which is not yet treated. So there are multiple reasons by which at this stage we would not offer the transplant. So I agree completely with the audience there. So the first question would be to Professor B.C. Sharma. Would you intubate this patient in view of the encephalopathy? And when would you usually intubate the patients?
Since from clinical presentation, this patient is in grade C encephalopathy and may be having, encephalopathy is more than grade 2 and may be having some amount of cerebral edema. Therefore, endotracheal intubation is indicated in this patient. And endotracheal intubation in this patient will be done to prevent aspiration pneumonitis. Or secondly, patient may require control of ventilation for which mechanical ventilation might have been done. And for endotracheal intubation, precautions to be taken are a rapid sequence induction, adequate sedation with propofol, and patient may need muscle relaxants. Other than these advantages of endotracheal intubation, like prevention of aspiration pneumonia, we can offer mechanical ventilation, which is a neuroprotective, and also we have to take care of lung protective mechanisms. By what I mean is, while ventilation, we have to keep low tidal volume, that is 6 to 8 ml per kg of body weight. And we have to keep low positive end expiratory pressure, which prevents obstruction to cerebral venous flow, thereby minimizing secondary cerebral insult. And thirdly, to maintain normocapnia, that is PaCO2 between 30 to 40 milligrams of mercury, that prevents vasodilatation and then therefore prevents secondary insult to cerebral abscess. That's all about endotracheal intubation I want to say.
Thank you, Dr. Sharma. I think all very pertinent points, beautifully brought out. The next question would be to Dr. Taneja. Here is a patient who has come to the ER who is tachycardic, who has got a sodium of 140 and has got a lactate which is 8. So would you want to resuscitate this patient with IV fluids? And what would be your choice of resuscitation fluid?
So I think this is a patient of acute liver failure, and she also has acute renal failure. So first thing I would like to do is look at the volume status of the patient. So that can be done either by placing a CVP line or by looking at the IVC diameter. And choice of fluid which I would like to use at this stage would be any crystalloid. So once we look at the CVP and the IVC diameter, then crystalloid can be used to bring up the fluid volume and look at the. In fact, we can also do a echocardiogram and an echo to see for the filling pressures also. That can also help us to decide about the fluid which has to be given.
Yeah, I think, thank you, Sunil. I think that's important that we assess the volume status. Today, I think echo, looking at the IVC and looking at the right atrium is what governs how much fluid we are going to give. And as he very appropriately said, any crystalloid which should not be hypotonic is the choice of resuscitation fluid. At the same time, you don't want to over hydrate the patient because that can contribute to the raised ICP. So you want this patient to be euvolumic. So Dr. Podar, we have a patient who has got a hyperacute liver failure here with a jaundice to encephalopathy period less than 7 days, just 3 days, and also has creatinine, which is 2, has progressive encephalopathy. So overall, how will you prognosticate this patient? What are the scores that we use and how do they change over time?
Yeah, Akash, the first and foremost thing we think about this hyperacute versus acute, and we conventionally believe that hyperacute has a better prognosis. But if you apply the other prognostic models, so where you take the grade of encephalopathy, this patient had grade 3, which is not a good prognostic marker at all. You have a lower grade, better prognosis. Then you use the ammonia, anything arterial ammonia more than 125 in Alfred score is bad. INR relatively good. It is not so bad. 3.2, more than 3.5, more than 5, we take a bad prognostic factor. We don't know the etiology. If you know the etiology, if it is a viral, especially E, we have a better prognosis. So if you put everything together, she has a guarded prognosis. Though it is a hyperacute with a better prognosis, but her lab parameters are not always all supporting. She is grade 3 encephalopathy. She has a very high ammonia. So at this stage, I will give a guarded prognosis.
Yeah. So thank you, Dr. Podar. So I agree that patients with hyperacute liver failure have a good prognosis. However, in this patient, what we are worried about is the infection, consolidation, and renal dysfunction. And that is why Dr. Podar would give a guarded prognosis. Any infection in a patient with acute liver failure is always worrisome. So those need to be treated before we can say that this patient is likely to improve or would require a transplant. So coming back to Dr. Sharma, what is the etiological workup that you would typically send in this patient?
Before going to investigations for etiological workup, I would like to review the history of antitubercle treatment, complementary alternate medicines, alternate systemic medicines, and yellow phosphorus in form of rat poison.
Yeah, none of them is there.
Second problem, she's a young female. I would like to know whether she is pregnant or not, because that takes me to another direction. If these things are not there, I would like to investigate for the most common etiology, that is viral hepatitis. I will get IgM anti-HCV for hepatitis E virus, IgM anti-HAV for hepatitis A virus, HBsAg and IgM anti-HBC for hepatitis B virus, and anti-HCV for hepatitis C virus. If these investigations are positive, the work is done. If these are negative, then I will consider ALF-like presentation due to tropical infections in India. For that, number 1 is malaria, for which I will get peripheral smear for MP and malarial antigen. Number 2 is dengue, for which I will get NS1 antigen and IgM dengue serology. And number 3 is leptospirosis, for which I will get CPK and IgM for leptospira. If these are also negative, then I will come to third category, that is acute liver failure with like presentation with underlying subclinical chronic liver disease, like autoimmune hepatitis, for which I will get ANA, ASMA, NTLKM, and IgG. Second is Wilson disease, for which I will like to get examination for KF rings, serum ceruloplasmin, serum copper, 24-hour urinary copper, and deep and challenge test. And third will be acute hepatic inflow tract obstruction, for which I will like to get ultrasound, Doppler, and maybe contrast enhanced CT scan. And the fourth most important will be HBAG reactivation, for which I would like to get HBsAg, IgM anti-HBC, total anti-HBC, HBeAg, anti-HBe, and HBV-DNA. That if patient is old age, and I think clinically this cardiac failure, ischemic hepatitis, then I will get ECG and echocardiography. If all these are negative, then I will come to the rare causes. Number one category will be systemic non-hepatotopic viruses like herpes simplex, varicella zoster, and Epstein-Barr virus. And lastly, I will not forget Reye syndrome presenting as acute liver failure. That is all the etiological workup I will do in this patient. If I do complete workup, I will do all this.
Thank you, Dr. Sharma. I think that was a very exhaustive list. And again, depending on the clinical picture and presentation, you choose which of these to send. And sometimes we may have to send instead of sequentially simultaneously if time is of extreme importance and important decisions have to be taken. So next question is to again Dr. Taneja. What is the importance of ammonia in prognostication as well as management decisions in patients presenting with acute liver failure? I know Dr. Dhiman has beautifully illustrated in the previous talk and in all his previous papers the importance of ammonia. If you can summarize for acute liver failure, what is the importance? I will be grateful.
So we've just had a masterly oration by Professor Acharya, and he's talked about the pathogenesis of ALF. So ammonia plays a very important role in pathogenesis of ALF, and it is ammonia which leads to cerebral edema primarily. So there are two criteria which are being followed for ammonia. One is the absolute criteria, and second is the dynamic change in the level of the ammonia value. So absolute criteria is if you have any value more than 200, then the patients have a poor prognosis. The dynamic criteria which is being used is the Alfred criteria, and you look at the ammonia levels at day 1 and day 3, and if it is more than 123, it is suggestive of poor prognosis. So there are studies which have shown that if you bring down the ammonia, or if there's a level of ammonia which is coming down over a period of time, that shows that the patient will improve and has a better prognosis. So measures which have been taken to bring down the ammonia is obviously one is plasma exchange, which is very helpful, and the second is CRRT.
Yeah, so I would completely agree with you, Dr. Sunil. And I think the Alfred model works the best for our population, proposed by Dr. Acharya and Dr. Shalimar. They have done a fantastic job and have made our lives easy in taking decisions on patients with acute liver failure. So here the etiology specific workup was done. Dengue, lepto, rickettsia fever panel was negative. Malarial antigen was negative. IgM, HEV was positive. HAV, Hep B core, Hep C, HIV, and HSV PCR were all negative. So when a patient comes like this, the first thing that you look for is airway. Dr. Sharma talked about how you ensure that you have intubated. That's the first thing to do. Never forget. Remember that this is what will impact the outcomes the maximum, the ABCD. So breathing and airway. Circulation is again invasive advanced monitoring is what we would do. Central line is the minimum, but in most patients who have hypotension and who are requiring inotropes, we would want to have an arterial line and very often even other monitoring like PICO and other catheters. The key thing in managing this is to differentiate between SIRS and sepsis, and that's very difficult, and very often we have to depend on cultures and clinical sense rather than any single objective parameter. And the D is sedation and analgesia. Usually the sedation of choice is propofol with or without fentanyl, and fentanyl more for analgesia. And this is what we would use in our ICU because of the short half-lives and non-dependency on liver for their metabolisms. So the patient goes to the ICU, and the repeat ABG was done a few hours later, which shows lactates coming down to 4. The ammonia 6 hours later is 200. A transcranial Doppler and optic nerve sheath diameter was done, which are both normal, and the patient is having a urine output of 0.5 to 1 ml per kg per hour. So ammonia levels still very high, 200, lactates around 4. So question to Dr. Podar, uh, how would you monitor intracranial pressure in such a patient bedside, and how often do you really resort to invasive monitoring?
Akash, this is very important issue of monitoring intracranial hypertension. See, the gold standard is invasive intracranial pressure monitoring. However, there is no study has proven that by doing the invasive monitoring, you can improve the survival. Survival benefit is not there. Moreover, a patient of acute liver failure with coagulopathy, there is a high risk of causing bleeding while putting the bolt. So, invasive intracranial pressure monitoring is only indicated when the patient is having high grade of encephalopathy, patient is waiting for liver transplant, hyperacute liver failure, very high ammonia, and persistent cardiovascular compromise in a setting where there is expertise available. It is not done in most of the places, and it's not possible. On the contrary, we have the non-invasive method of monitoring intracranial pressure. And between these two, optic nerve sheath diameter and transcranial Doppler, it has been shown that optic nerve sheath diameter monitoring is easier and it is more reproducible. So normal cutoff for an adult is 5 millimeter. Optic nerve sheath diameter is going beyond 5. You can think about this patient is having cerebral edema, and the dynamic model that you monitor daily, and you can see the change with the therapy. More than 5, now it is coming down less than 5. That will tell you that probably there is an improvement with your anti-cerebral edema therapy. There is a recent study of meta-analysis of all the parameters of non-invasive versus invasive. They have compared and published in BMJ 2019. These are not particularly for liver failure, for any cerebral edema. They have shown that area under the curve is best with the optic nerve sheath diameter, Akash. It is almost 94. But for transcranial Doppler, it is not so good. So I think in day-to-day practice, we should use ultrasound to monitor optic nerve sheath diameter, to diagnose and to monitor intracranial hypertension.
Yeah, thank you, Dr. Podar. I think all important points. Although there is very good emerging evidence for transcranial Doppler, it's easier to do and probably is more sensitive. The ONSD may take some time to increase following raised intracranial hypertension. But as you said, there is more data available and more validity for ONSD, and therefore that is very often preferred. But I think we should all start learning TCD, and we should, because I think that is going to become the standard of care in the future. And BOLT is something that invasive intracranial pressure monitoring is something which we do extremely rarely. Dr. Sharma, what are the other monitoring that you would do in this patient? You can just briefly tell us.
Yeah, other monitoring in this patient, first is clinical, temperature, urinary output early, CVP, grade of coma, and pupils. After that, I will get hemogram, LFT, and KFT. And then prothrombin time every 12 hourly, blood sugar 6 hourly, ABG 12 hourly with lactate levels, and serum ammonia monitoring every 12 hours. After that, I will go to hemodynamic monitoring. I will like to monitor mean arterial pressure, which should be kept around 70 millimeter of mercury. It indicates cerebral perfusion pressure. Second, I would like to measure IVC size to know volume status, and that can be measured by ultrasound. Third, I can do is, if not clinically done, end tidal CO2 and flow track monitoring with facility of extracellular lung water measurement. However, these are not done. After this comes neurological monitoring, but Dr. Ujjal has discussed transcranial Doppler and ONSD. Other than this, usually not done is reverse jugular oxygen pressure. But most of these three facilities, transcranial Doppler, transcranial Doppler, ONSD, and reverse jugular oxygen pressure is not available at many centers. There we may do CT head, which is not very sensitive, however, can depict evolution of cellular edema. And we may see features in form of prominent gyri, flattened sulci, and loss of differentiation of gray and white matter. And then lastly, the most important monitoring is to look for infections, blood culture, urine culture, sputum culture, endotracheal tube secretion culture. I will do, it's recommended is every 48 hours. Then for infection, I did not come across any study or did not come across any data or effect on serum procalcitonin for determining infection in acute liver failure. That is what all we will do in, I will do in monitoring.
Thank you, Dr. Sharma. I think you have covered everything. The key emphasis which Dr. Sharma said was about invasive hemodynamic monitoring. I think that is what has changed the outcomes in our patients with acute liver failure. Today, we no longer depend only on central line. We know that that is undependable, and we would want to see the IVC. We would want to do the invasive monitoring with either PICO or flow track or any similar systems where we know how much is the extracellular lung volume, water volume, how much is the perfusion in the peripheries, what is the peripheral vascular resistance, and then depending on that, we decide how much fluid to give. Next question to Dr. Taneja. Can you tell us with regards to N-acetylcysteine, one, should we give it to all? And two, is it safe to give it in presence of infections? And three, are there any side effects which we should be careful about?
So I think the data which has emerged on the use of N-acetylcysteine is primarily from the paracetamol group, where it showed a survival benefit. And subsequent studies have been done in the non-paracetamol group also, where they have shown that it helps. And I would recommend using N-acetylcysteine in all patients in the non-paracetamol group also. And so two things which are very important is when you have to give N-acetylcysteine is please look for volume overload, because if you give too much of fluids along with that, then there's a risk of volume overload. And you have to be cautious when the patients are having renal failure also. So I think infection is not a contraindication to the use of N-acetylcysteine.
I think, thank you, Dr. Sunil. I think that is a very important point, that although conventionally N-acetylcysteine is associated with mild immunosuppression, it is not contraindicated in the presence of infections. The benefits have outweigh the risk of infections. Thank you. Thank you very much.
Akash, can I make one point at this
Yeah,
stage
sure.
about N-acetylcysteine? We have to be careful about the duration of therapy. We should not cross the past 1 week. It has been shown in animal studies, N-acetylcysteine prevents the regeneration. So after 1 week, when the liver will start trying to regenerate, N-acetylcysteine will hamper it. And secondly, N-acetylcysteine, one of the effect is anti-inflammatory. So first week you have a surge, then it is very good. But second week, when there is a immune paralysis, that you continue N-acetylcysteine beyond 7 days, probably the risk of infection will increase. So I think we start, but don't go beyond 7 days.
Perfect. Yeah, absolutely valid points, Dr. Podar. So we would monitor ammonia frequently, at least twice a day, if not more. Sometimes we do it 6 hourly if the patient is started on CRRT. If the ammonia levels are persistently beyond 200, we in our center would start the patients on CRRT. Transcranial Doppler is what we used. It's the most preferred. We have found it to be the most useful. ONSD is probably the most established, and reverse jug is again something which is extremely useful wherever the expertise is available to place it at the right place and obtain the samples. Pupils is something which is very late, and therefore it should not depend upon the pupils to diagnose raised intracranial pressure. I think you've already missed the boat if the pupils have become dilated and fixed.
Akash, there is a question from the audience. Dr. Kingshuk wants to ask.
Akash, Kingshuk here.
Yes,
So is it practically possible always to do ammonia every 6 hourly except tertiary care centers? And I feel really very difficult to do every 6 hours ammonia. So is there any other way, or we manage in the same way? What we are going to change? If ammonia is 200 and now after 6 hours is 222, or next 6 hours is 198. What are the changes we are going to make by serially ammonia every 6 hours?
Absolutely, sir. I think very valid question. So I think a few years ago, my answer would have been that although it was recommended by the West, we would not do. But now we do ammonia levels very frequently because our CRRT settings change, our fluid management changes according to the ammonia levels. And that is why I think liver intensive care has now emerged as a separate field altogether. And I agree with you completely that this is possible only in tertiary centers which have all the facilities. But I strongly feel that patients with acute liver failure with grade 3 and 4 encephalopathy who are intubated, who have renal dysfunction, who have ICP, should be managed at centers which have expertise in managing these, and there only that there will be a difference in the outcomes. Otherwise, it is very difficult now to justify managing a patient without these measures.
Thank you.
Akash, Dr. Brijesh wants to make one.
Dr. Kinsuk,
yeah,
very simple.
Yeah.
Serum ammonia level and performance time should be estimated every 12 hours. Number one. Number two,
time we are doing.
just listen to me.
Yeah.
Number two, it's not difficult at all to get blood ammonia levels. Bedside you can do with portable machine blood ammonia levels. And third thing is both prothrombin time and ammonia levels now are becoming more important because most centers are using dynamic criteria for prognosis, for severity, for mortality, and also as an indicator for liver transplant. Therefore, ammonia and prothrombin time every 12 hourly is very important and very simple to do, and indications of why it is important I have told you.
Yeah, thank you. Thank you.
Akash, carry on.
Yeah. So then we come to the E and the F, that is exposure and fluids. So temperature is usually maintained 35 to 36 degrees. Avoid hypothermia, except for in those patients with refractory intracranial hypertension. We do monitor the electrolytes, as Dr. Sharma mentioned. Avoid high degree of positive balance because it will worsen the encephalopathy. And we usually would start CRRT early because of getting a metabolic control, preventing lactic acidosis. So for us, very high arterial ammonia levels persistently more than 200 and persistently rising lactic acid levels are the indications for CRRT, even in the absence of complete renal failure. Then we come to nutrition, and we must feed this patient if we can protect the airway. In grade 1 and 2 encephalopathy, we have to be cautious because of the risk of aspiration. We would usually target the ideal calories and protein intake, but that is not usually possible initially. So even if we are able to achieve 1/4 of what is our target for the first 48 to 72 hours, it's fine. Lactulose is something which, again, there is good evidence that it may not be of major benefit, and in fact may make the transplant difficult to do, and therefore is not routinely indicated in these patients. H is for hematology. So there is no need for prophylactic transfusions. So even if your INR is 7, 8, or 10, please do not give empirical FFPs prior to placing of lines. The bleeding risk is low. And the only time you would try to correct the coagulation parameters if the patient is in sepsis and you see active bleeding from around the sites and the platelet counts are low. Those are the patients where the bleeding risk may be high, and there, in presence of bleeding, you may decide to correct coagulation based on dynamic parameters like sonoclot or ROTEM or TEG. You need to prevent infections and be aggressive in treating the infections. If they are difficult to diagnose, you have to have a high index of suspicion, and very often you can't wait for the cultures to diagnose, and therefore you would change the antibiotics empirically based on the clinical presentation. You'll have a low threshold for broad spectrum antibiotics, and in patients who are having prolonged stay in the hospital and are having antibiotics for prolonged periods, you will have a very low threshold for starting antifungals. Uh, N-acetylcysteine, beautifully discussed by Dr. Podar, that there is no benefit beyond 5 days. The dose should be the same as that for paracetamol poisoning, and that is what has been shown to be useful, and it improves overall survival as well as transplant-free survival. So our patient, day 2 to 4, in the ICU, sedated, ventilated, on low doses of inotropes, on CRRT, arterial ammonia maintained between 85 to 100, lactates in the range of 2 to 4, on meropenem, teicoplanin, and micafungin, on NSL's infusion, 3% saline given to keep sodium between 140 to 145, core temperature maintained, PaCO2, as mentioned by Dr. Sharma, between 35 to 40, feeds started, and monitored as discussed. Now, in this patient, patient is there on day 4. Would you offer this patient transplant, or you would want to wait for the liver transplant, assuming that the patient has the finances and has a living donor ready? So, Dr. Podar, you can again take opinion from the audience. If you can take a
From
poll.
postgraduate, at this stage where you have seen the parameters have started improving in this patient. The
On
ammonia,
CRRT.
which was
Yeah.
320, now it has come down to around 200, then 100. She is in ICU, day 3, day 4. So, what is your opinion that we should proceed for transplant or will continue the conservative management? Anybody? You raised the issue of infection. Now probably it is no longer valid, that tropical infection. We have done investigation, so that point is not. But otherwise now this patient is viral hepatitis E, and this is her status over the 3 days of ICU stay. So what is your opinion? Should we go for transplant or will carry on conservative management?
Sir, is there any information on the sensorium of the patient? It's mentioned the sedated have the.
Yeah, she
If the
is
sensorium is
ICU sedated, ventilated, so we couldn't assess the sensorium, but other parameters is showing improvement. Ammonia has started coming down. Lactate is improved.
Sir, I think I would go with C, sir. Keep ready, but observe for 2 to 3 more days. And if she doesn't improve, sensorium does not recover, then.
Akash, he says that we'll continue conservative management.
Fair enough. I think that's appropriate, and especially because this is hyperacute liver failure and we have gotten on top of infection, the other parameters have remained stable. Although there is no dramatic improvement as yet, but I think this is a patient who will turn around more than not turning around. So I would keep everything ready, but I'll continue to observe and go ahead only if there's no improvement or worsening. So that is what we would do. How many of you feel that renal dysfunction in a patient with ALF is a problem for liver transplant? Can we just have a poll of the audience? How many would say yes and how many would say no?
Yes. Oh, yeah. No. Oh, yeah. Majority said yes. It is a problem.
So I think this is an important message. In ALFs, usually acute renal failure is not a problem. Almost invariably, those patients who are really sick and who really need a transplant, they would almost always have renal dysfunction and acute kidney injury. And in all probability, they would require renal replacement therapy of some sort. But this is not usually a problem for liver transplant. You can transplant them on CRRT or otherwise, and you may require the CRRT for some time after the transplant, but almost always the kidneys would recover when you have done the transplant. So in this setting, unlike ACLF and 6 cirrhotics, where renal dysfunction could be a major issue, in patients with acute liver failure, especially the hyperacute ones, renal dysfunction is not usually a problem. So on day 5, in this patient, the INR started downtrending. No products were transfused. Dose of CRT was reduced. Sedation was continued. And then on the day 6, CRT was discontinued because the urine output was adequate. The ammonia level was persistently less than 100 even after stopping the CRT. And therefore, the patient was weaned off the ventilator and was awake. So here is a patient who was hyperacute acute liver failure, IgM HEV related. The jaundice to encephalopathy period of less than 7 days. Peak INR was 3.4, mild cerebral edema, AKI akin 2, which recovered spontaneously. So last set of questions before we wind up. So I'll start with Dr. Taneja. What is your practice for CRRT? When would you start your patients?
So I think this is a very important question, when to start CRRT. So there are 2 studies on this. One is from the pediatric ALF group, and second was a retrospective analysis, which was published in hepatology. So once you have very high ammonia, if it is more than 200, and if there is any synthetic, any dysfunction of the kidneys, then I think you should start early CRRT in these patients, because it has been shown to be helpful in improval of survival in such patients.
Thank you, Sunil. I think that is what the evidence tells us. Although there are individual variations in the practices. Dr. Sharma, what is the role of plasma exchange now?
Just before that, Akash, can I just add on what Sunil said? That message should be clear that CRRT, irrespective of the renal dysfunction, has play a role.
Yes, sir.
So we should not wait for the renal dysfunction to start CRRT.
Agreed, sir. So it is especially helpful when you have renal dysfunction along with high ammonia. So it can be used in both conditions. Early CRRT is always helpful when you have a high ammonia.
Yeah, so I think the importance of CRRT cannot be overemphasized ever. You today, in the absence of renal dysfunction, persistently high lactate or a persistently high ammonia level, even in the absence of renal dysfunction, would still be an indication for starting CRRT. So, Dr. Sharma, role of plasma exchange?
Plasma exchange is indicated in acute liver failure if there are poor prognostic factors satisfying the indications of liver transplant. However, due to limited resources and non-availability of organ, the liver transplantation cannot be done. In our patient, plasma exchange is not indicated. Just to say, there are 3 randomized controlled trials, all Western studies on plasma exchange, and 2 retrospective studies are available. These are mainly on paracetamol-related acute liver failure and mainly high volume plasma exchange. 2 studies from India, Ipan et al., CMC Vellore. Unique feature was this was on yellow phosphorus, that is rat poison related acute liver failure. Another study, Rakhi et al., ILBS, New Delhi. Unique features of this study were mainly cases were causes were liver failure, causes of liver failure were causes other than paracetamol, and this was a standard volume plasma exchange. High volume plasma exchange, where exchange is 8 to 12 liters over 9 hours. Standard volume, but Rakhi used 4 to 6 liters over 4 hours. Low volume, 1.5 to 2 liters per 2 hours. Standard volume and low volume plasma exchange, the advantage is because resources are limited, so it is more easily can used. And second is less incidence of transfusion related lung injury. Advantages of plasma exchange are increased transplant-free survival, increased biochemical and hemodynamic improvements, higher reduction in lactate levels, higher reduction in ammonia levels, and also significant reduction in levels of pro-inflammatory cytokines and significant increase in levels of, significant reduction in level of pro-inflammatory cytokines and significant increase in level of anti-inflammatory cytokines, and also significant reduction in endotoxins. This is the advantage. These are the actions of plasmapheresis. However, Dr. Taneja and Dr. Ujjal Podar, and you also mentioned CRRT without renal failure to decrease ammonia levels. And this. In such a situation, Whether to do plasmapheresis or to do CRRT, I am not clear. There is no randomized control trial in such a situation to compare plasmapheresis and CRRT when renal failure is not there. Our indication is to decrease ammonia levels and to add to the, to decrease endotoxins, pro-inflammatory cytokines, and to add to synthetic functions of liver. I need a randomized control trial to compare that. Thank you.
Yeah, thank you, Dr. Sharma. Valid points. So to just summarize what Dr. Sharma just told us, that in patients as a bridge to transplant, we can use plasma exchange. In those patients where liver transplant is not an option and the patient is not infected, we can use plasma exchanges. And remember that the biggest worry with plasma exchange is the risk of infection and the risk of TRALI. And therefore, in the presence of infections or in presence of respiratory compromise, we are extremely worried while doing plasma exchanges, and probably we would avoid. And in patients where isolated ammonia levels are elevated persistently, whether PLEX is better or CRRT is better, we need a randomized control trial. The advantage of CRRT is that you are able to maintain a level of ammonia in a sustained manner, whereas with plasma exchange, you get it down and then it tends to build up. So you get more fluctuations. And as Dr. Acharya sir has beautifully elucidated, that it is the fluctuations which can be detrimental. And therefore, theoretically, at least, CRRT appears to score over PLEX for this indication. But I agree with Dr. Sharma that we require a randomized control trial. Dr. Sharma, today with the improvement in the ICU care, where exactly do we see the role of transplant? When should a patient be shifted to a transplant center?
I will tell the role of transplant, but before that I say plasma exchange. Some hepatologists have advocated plasma exchange as a bridge therapy for liver transplant. However, it has been proved that plasma exchange as a bridge therapy for liver transplant is not beneficial at all. Not used. Then coming to liver transplant, our patient, according to King's College criteria at baseline, or acute liver failure, early dynamics, that is Indian criteria on day 3, does not satisfy criteria for liver transplant. Criteria for liver transplant, Western, King's College, Clinches, and MELD score, these criteria has been used quite frequently. However, problem with that, these criteria utilize only biochemical and other parameters at the baseline. They are not dynamic criteria. Nowadays, there is a lot of literature on dynamic criteria. 3 dynamic criteria: acute liver failure, early dynamic criteria from India, which has been validated by recommended by INSL. Then another dynamic criteria is from US acute liver failure study group, and third is from King's College. The last 2 dynamic criteria are dynamic web-based algorithms. Another parameter for liver transplant people have used is CT volumetry, in which liver volume less than 1,000 per cubic centimeter is an indication of liver transplant. I would like to mention more about acute liver failure, early dynamic Indian criteria recommended by NSL. The basis was that most of the cases are due to viral hepatitis. 12 acute liver failure on naive liver, which has a normal regeneration capacity. Therefore, we should wait, and subsequent days, liver will regenerate and biochemical and other parameters will improve. Therefore, liver transplantation will be unnecessary. These acute liver failure early dynamics group uses biochemical and other parameters for deciding whether liver transplant is done or not done on day 1 and day 3. In this criteria, Dr. Acharya has told all the components of criteria. Criteria less than 4, survival is 80%. If criteria 4 or more than 4, mortality is 80%. This has been recommended by NSL. However, when I went through this, in my mind, there are many problems, many limitations. Dr. Acharya is not there, but Dr. Chawla and Dr. Shalimar, they are sitting. They have made in this contribution in making this idea. If you want, I can tell the.
I think we should be brief because I think we are exceeding our time.
Okay.
Yeah.
We can discuss this separately.
Yes, sir.
If there are any other questions or comments from the audience.
If I can summarize what.
Akash, we'll finish our question.
Can I just give a brief comment before we sum up? So I think we need to use Alfred more and more. I think of all the criteria that is available to us, it appears to be working the best for our population. We have already officially adopted the Alfred criteria in Mumbai and in Maharashtra for organ distribution and for ensuring for listing the patients for liver transplant. I think this is the first major step because we have found that that is the one which is most useful. So I would request everybody to validate these criteria at their centers and use it more and more. And the last comment from Dr. Ujjwal, any special issues in pediatric, then we can wind up the session.
One small thing, Dr. Akash, Alfred criteria you are using. Problems is Alfred criteria, I think.
Sir, we know there are problems, sir, with every criteria. No criteria is perfect.
Enumerate.
But sir, we are running short of time. Let us wind up.
Agreed, sir. Agreed.
We can discuss later.
Okay,
Akash, can I go ahead with pediatric liver failure?
Yes.
Okay, see, there are actually three basic differences between adult and pediatric liver failure. We start with the definition. What is acute liver failure in adult? You need to have hepatic encephalopathy and INR more than 1.5. Duration can vary depending upon which criteria. But this integral part. But in pediatric acute liver failure definition, encephalopathy is not essential because it is very difficult to assess the encephalopathy in smaller kids. They may be crying otherwise also, and you can put them as a grade 1 encephalopathy. So our pediatric acute liver failure definition is when the INR is more than 1.5 with hepatic encephalopathy. But if it is INR is more than 2, irrespective whether there is an encephalopathy or not, you call it acute liver failure. Obviously, the other thing, no pre-existing liver disease and evidence of hepatitis is there. Another point about definition, we have a subset called neonatal liver failure. Neonate means this first 1 month of life, and there it is shown that physiologically their INR is prolonged. A normal term baby has INR up to 2, and a preterm baby can have INR up to 3. So for neonatal liver failure, they said we increase this criteria to INR more than 3 instead of taking it 2 or 1.5. So neonatal liver failure, we take it INR more than 3 to say it is a neonatal liver failure. Second aspect about the etiology, what you have discussed so far, that viral hepatitis is the commonest cause of liver failure in adults in India. But in children, etiology varies with the age. If you take the first 3 years, means either infant or toddlers versus the older children. Older children, we get predominantly viral hepatitis followed by Wilson or autoimmune. But the younger kids, first 3 years of life, metabolic liver disease predominant. There it could be galactosemia, tyrosinemia, or mitochondrial hepatopathy, HLS, hemophagocytic lymphohistiocytosis. They are more common. The viral infection, if at all, they're not usual hepatotropic virus. You get the herpes simplex virus causing neonatal liver failure. Regarding clinical presentation, it is almost same. Only thing is that you start thinking when this child is having multi-system disease, there is a cardiomyopathy, neurological problem, hypotonia, then it is likely to be a metabolic liver disease which is responsible for liver failure. And unique features of Wilson, fulminant Wilson, is that if you get a Coombs negative hemolytic anemia, chances of Wilson disease is very high. Regarding management part is almost same, except that for listing for liver transplant, very simplified in children. Only the two things, if you have a INR more than 4 and bilirubin more than 300 micromole, means 17.6, then they are listed for liver transplant. Akash.
Yeah, thank you so much. So I think if I can just give 5 learning points from today's discussion. Invasive hemodynamic monitoring for patients with renal dysfunction and requiring inotropes. Second,
Akash, I think there is one more question to Sunil.
sir, I think I'll just briefly enumerate and then probably I'll give a comment sir, on that. Because I think we have exceeded the time, big time, almost 50 minutes.
No, we have been allowed 10 minutes extra.
Okay, great. So
Already
then
7
I
minutes
then
are
I
over.
ask
We have 2
Sunil to
minutes.
comment. Sunil, can you comment on the subacute liver failure?
Yeah.
Because we have not
So,
discussed that.
so I think the hyperacute is up to 7 days, and 7 days to 4 weeks is acute, and beyond that we take it as subacute hepatic failure. The best prognosis is with hyperacute, as we've seen in this patient, and with the improvement in intensive care, more and more survival benefit has been seen in patients with ALF now. So subacute hepatic failure is when they tend to have this ongoing necroinflammation, and it goes on, and then the patients tend to develop ascites or chronic liver failure over a period of time. So they have the worst prognosis.
Thank you. I think, and our experience is most of these patients are drug-induced or viral who have not able to recover. So it's more of a failed regeneration, uh, uh, and I think that itself is a big topic in itself. So if you can just talk about it maybe for 2 minutes and enlighten the residents about it.
So the most common cause of subacute hepatic failure in our setting has been viral hepatitis only. So earlier studies which came from India were all hepatitis E related, but subsequently we have studies from Vellore and other institutes where other causes of viral hepatitis and also been incriminated. And other causes, obviously, as Dr. Akash said, that subacute hepatic failure can be caused by drugs and CAM intake. So Ayurvedic preparations, herbal preparations, all these drugs can lead to ongoing necroinflammation in the liver and cause they tend to go on to develop ascites after a period of 4 weeks of duration. And I think they have a poor prognosis over a period of time.
Yeah, thank you. I think so. These are the group of patients who have got the worst prognosis. Uh, so I'll not go into the details, but few basic therapies for preventing cerebral edema. Maintain sodium between 140 to 145. We no longer aim 150, which was the norm. It has been associated with increased risk of microbleeds. Hemodynamic filtration to be done to keep arterial ammonia below 150. Normothermia, do not try hypothermia early. Normocapnia, as Dr. Sharma spoke about. He did talk about the plasma exchanges, the randomized control trial, which was for high volume, and but
Anything
now we
new,
have
Dr.
good.
Akash? This has already been talked of.
Yeah. So
Anything
that's
new?
what. So this is what was discussed, whether we want to use standard volume or low volume. I think Dr. Raki and Dr. Sareen have beautifully demonstrated the usefulness of standard volume, and Dr. Epan from down south has demonstrated the value of low volume plasma exchange, and that is what we usually practice in our routine issues. Uh, I think I'll skip this. Uh, and I'll just if when not to transplant is important, we should know if we have a confirmed invasive fungal infection, if there is an evidence of brainstem herniation, if patient is requiring more than two or more inotrope supports in if two inotropes in very high doses or more than two inotropes, uh, patient with uncontrolled sepsis, untreated infection, and patients with inadequate social support. So these are the patients where we would not be transplanting. Outcomes after transplant have been good. ILBS has demonstrated that in their study, good outcomes. This is our personal experience: 183 patients, 56 transplanted, 85 spontaneous survival, and 42 either died or left against medical advice. 8 deaths out of 42, and I think this is a worry, that is almost 34 patients could not afford the treatment. And I think that is something which we need to address. How can we offer all these therapies which we talked about uh, at a very economical and financially compatible uh, rates? And I think PGI has taken a wonderful initiative in this aspect with providing affordable transplant program and affordable ICU care. Other government institutes need to replicate that. Doctors, Dr. Acharya and had started a wonderful liver ICU, which changed our outlook towards transplant. ILBS is doing an excellent job in Delhi of managing patients with acute liver failure and doing transplants. So I think we need more institutes at across the country from the government sector, public sector, to basically replicate what these institutes are doing. If I can just summarize in 3 sentences today's learning experiences, I think invasive monitoring for patients with hemodynamic instability, use of plasma exchange in the right patient, and early use of CRRT and metabolic control for patients with lactic acidosis and persistent hyperammonemia. I think these are the 3 things with excellent infection control that will change the outcomes. I'll hand over to the chairpersons for further discussion. Thank you.
Thank you, Dr. Akash. Thank you, Dr. Ujjwal. Thank you, B.C. Sharma and Dr. Navneet. We come to the end of this session. Thank you very much.
So now we'll take a lunch break. So because of shortage of time, we'll have a 30-minute lunch break. So we'll start with the next session at 2:30 sharp. So please join here.
Enhance the visibility of suspicious areas, which is especially important during detection and characterization. TXI stands for Texture and Color Enhancement Imaging. The incoming image is split. Texture and brightness are enhanced. During the stacking process, both images are merged. Color tone enhancements are made to more clearly define subtle tissue differences. TXI is supporting better visibility of potential lesions, resulting in image details at a level that typically only very experienced endoscopists have learned to see. TXI aims to contribute to lower miss rates for information and early mucosal changes, especially flat or depressed lesions that can easily be missed. The color appearance of TXI is close to white light. This allows users to relate to imaging of lesions they are familiar with. In this regard, we aim to introduce TXI as the new white light. EDOF stands for Extended Depth of Field. The incoming beam of light is divided by the beam splitter and reflected via 2 mirrors to the sensor. This technology projects 2 images with identical content that, however, exhibit different focal lengths and combines those images into 1 image in total focus. EDOF supports the detection of lesions through improved visibility, thanks to a broad focus range and less blurring. EDOF allows for a much closer distance to the object in normal mode compared to previous dual focus endoscopes. Therefore, EDOF was developed to ease handling significantly by reducing the need to frequently switch from normal to near mode. EDOF is designed to also ease handling in near mode. With its large depth of field and maximum magnification equal to that of zoom endoscopes, it allows the entire lesion to be kept in perfect focus and images to be achieved that typically used to be reserved for very experienced endoscopists. As a result, the learning curve for advanced imaging is expected to be shortened for non-experts. RDI stands for red dichromatic imaging. RDI uses an additional amber LED. Red light penetrates deeper into the tissue compared to green light. If a deep blood vessel is present, amber light is strongly absorbed. The vessel appears darker and is therefore more visible. If the amber light hits a bleeding point at which the blood concentration is very high, the amber light is strongly absorbed. The bleeding point appears darker and is therefore more visible. RDI thus helps to efficiently identify the bleeding source during endoscopic resections. This supports clinicians to coagulate bleeding vessels quicker and easier. Therefore, RDI helps to reduce stress and procedure time for treatment of emergency bleedings and endoscopic resections. RDI aims to help to avoid delayed bleeding after EMR or ESD. RDI may improve speed, efficiency, and safety of endoscopic treatment. Treatment.
Greetings from ILBS.
Enhance the visibility of suspicious areas, which is especially important during detection and characterization. TXI stands for Texture and Color Enhancement Imaging. The incoming image is split. Texture and brightness are enhanced. During the stacking process, both images are merged. Color tone enhancements are made to more clearly define subtle tissue differences. TXI is supporting better visibility of potential lesions, resulting in image details at a level that typically only very experienced endoscopists have learned to see. TXI aims to contribute to lower miss rates for inflammation and early mucosal changes, especially flat or depressed lesions that can easily be missed. The color appearance of TXI is close to white light. This allows users to relate to imaging of lesions they are familiar with. In this regard, we aim to introduce TXI as the new white light. EDOF stands for Extended Depth of Field. The incoming beam of light is divided by the beam splitter and reflected via two mirrors to the sensor. This technology projects two images with identical content that, however, exhibit different focal lengths and combines those images into one image in total focus. EDOF supports the detection of lesions through improved visibility, thanks to a broad focus range and less blurring. EDOF allows for a much closer distance to the object in normal mode compared to previous dual-focus endoscopes. Therefore, EDOF was developed to ease handling significantly by reducing the need to frequently switch from normal to near mode. EDOF is designed to also ease handling in near mode. With its large depth of field and maximum magnification equal to that of zoom endoscopes, It allows the entire lesion to be kept in perfect focus and images to be achieved that typically used to be reserved for very experienced endoscopists. As a result, the learning curve for advanced imaging is expected to be shortened for non-experts. RDI stands for red dichromatic imaging. RDI uses an additional amber LED. Red light penetrates deeper into the tissue compared to green light. If a deep blood vessel is present, amber light is strongly absorbed. The vessel appears darker and is therefore more visible. If the amber light hits a bleeding point at which the blood concentration is very high, the amber light is strongly absorbed. The bleeding point appears darker and is therefore more visible. RDI thus helps to efficiently identify the bleeding source during endoscopic resections. This supports clinicians to coagulate bleeding vessels quicker and easier. Therefore, RDI helps to reduce stress and procedure time for treatment of emergency bleedings and endoscopic resections. RDI aims to help to avoid delayed bleeding after EMR or ESD. RDI may improve speed, efficiency, and safety of endoscopic treatment. Enhance the visibility of suspicious areas, which is especially important during detection and characterization. TXI stands for Texture and Color Enhancement Imaging. The incoming image is split. Texture and brightness are enhanced. During the stacking process, both images are merged. Color tone enhancements are made to more clearly define subtle tissue differences. TXI is supporting better visibility of potential lesions, resulting in image details at a level that typically only very experienced endoscopists have learned to see. TXI aims to contribute to lower miss rates for inflammation and early mucosal changes, especially flat or depressed lesions that can easily be missed. The color appearance of TXI is close to white light. This allows users to relate to imaging of lesions they are familiar with. In this regard, we aim to introduce TXI as the new white light. EDOF stands for Extended Depth of Field. The incoming beam of light is divided by the beam splitter and reflected via two mirrors to the sensor. This technology projects two images with identical content that, however, exhibit different focal lengths and combines those images into one image in total focus. EDOF supports the detection of lesions through improved visibility, thanks to a broad focus range and less blurring. EDOF allows for a much closer distance to the object in normal mode compared to previous dual focus endoscopes. Therefore, EDOF was developed to ease handling significantly by reducing the need to frequently switch from normal to near mode. EDOF is designed to also ease handling in near mode. With its large depth of field and maximum magnification equal to that of zoom endoscopes, it allows the entire lesion to be kept in perfect focus and images to be achieved that typically used to be reserved for very experienced endoscopists. As a result, the learning curve for advanced imaging is expected to be shortened for non-experts. RDI stands for red dichromatic imaging. RDI uses an additional amber LED. Red light penetrates deeper into the tissue compared to green light. If a deep blood vessel is present, amber light is strongly absorbed. The vessel appears darker and is therefore more visible. If the amber light hits a bleeding point at which the blood concentration is very high, the amber light is strongly absorbed. The bleeding point appears darker and is therefore more visible. RDI thus helps to efficiently identify the bleeding source during endoscopic resections. This supports clinicians to coagulate bleeding vessels quicker and easier. Therefore, RDI helps to reduce stress and procedure time for treatment of emergency bleedings and endoscopic resections. RDI aims to help to avoid delayed bleeding after EMR or ESD. RDI may improve speed, efficiency, and safety of endoscopic treatment. Enhance the visibility of suspicious areas, which is especially important during detection and characterization. TXI stands for Texture and Color Enhancement Imaging. The incoming image is split. Texture and brightness are enhanced. During the stacking process, both images are merged. Color tone enhancements are made to more clearly define subtle tissue differences. TXI is supporting better visibility of potential lesions, resulting in image details at a level that typically only very experienced endoscopists have learned to see. TXI aims to contribute to lower miss rates for inflammation and early mucosal changes, especially flat or depressed lesions that can easily be missed. The color appearance of TXI is close to white light. This allows users to relate to imaging of lesions they are familiar with. In this regard, we aim to introduce TXI as the new white light. EDOF stands for Extended Depth of Field. The incoming beam of light is divided by the beam splitter and reflected via two mirrors to the sensor. This technology projects two images with identical content that, however, exhibit different focal lengths and combines those images into one image in total focus. EDOF supports the detection of lesions through improved visibility, thanks to a broad focus range and less blurring. EDOF allows for a much closer distance to the object in normal mode compared to previous dual-focus endoscopes. Therefore, EDOF was developed to ease handling significantly by reducing the need to frequently switch from normal to near mode. EDOF is designed to also ease handling in near mode. With its large depth of field and maximum magnification equal to that of zoom endoscopes, it allows the entire lesion to be kept in perfect focus and images to be achieved that typically used to be reserved for very experienced endoscopists. As a result, the learning curve for advanced imaging is expected to be shortened for non-experts. RDI stands for red dichromatic imaging. RDI uses an additional amber LED. Red light penetrates deeper into the tissue compared to green light. If a deep blood vessel is present, amber light is strongly absorbed. The vessel appears darker and is therefore more visible. If the amber light hits a bleeding point at which the blood concentration is very high, the amber light is strongly absorbed. The bleeding point appears darker and is therefore more visible. RDI thus helps to efficiently identify the bleeding source during endoscopic resections. This supports clinicians to coagulate bleeding vessels quicker and easier. Therefore, RDI helps to reduce stress and procedure time for treatment of emergency bleedings and endoscopic resections. RDI aims to help to avoid delayed bleeding after EMR or ESD. RDI may improve speed, efficiency, and safety of endoscopic treatment. Enhance the visibility of suspicious areas, which is especially important during detection and characterization. TXI stands for Texture and Color Enhancement Imaging. The incoming image is split. Texture and brightness are enhanced. During the stacking process, both images are merged. Color tone enhancements are made to more clearly define subtle tissue differences. TXI is supporting better visibility of potential lesions, resulting in image details at a level that typically only very experienced endoscopists have learned to see. TXI aims to contribute to lower miss rates for inflammation and early mucosal changes, especially flat or depressed lesions that can easily be missed. The color appearance of TXI is close to white light. This allows users to relate to imaging of lesions they are familiar with. In this regard, we aim to introduce TXI as the new white light. EDOF stands for Extended Depth of Field. The incoming beam of light is divided by the beam splitter and reflected via two mirrors to the sensor. This technology projects two images with identical content that, however, exhibit different focal lengths and combines those images into one image in total focus. EDOF supports the detection of lesions through improved visibility, thanks to a broad focus range and less blurring. EDOF allows for a much closer distance to the object in normal mode compared to previous dual-focus endoscopes. Therefore, EDOF was developed to ease handling significantly by reducing the need to frequently switch from normal to near mode. EDOF is designed to also ease handling in near mode. With its large depth of field and maximum magnification equal to that of zoom endoscopes, it allows the entire lesion to be kept in perfect focus and images to be achieved that typically used to be reserved for very experienced endoscopists. As a result, the learning curve for advanced imaging is expected to be shortened for non-experts. RDI stands for red dichromatic imaging. RDI uses an additional amber LED. Red light penetrates deeper into the tissue compared to green light. If a deep blood vessel is present, amber light is strongly absorbed. The vessel appears darker and is therefore more visible. If the amber light hits a bleeding point at which the blood concentration is very high, the amber light is strongly absorbed. The bleeding point appears darker and is therefore more visible. RDI thus helps to efficiently identify the bleeding source during endoscopic resections. This supports clinicians to coagulate bleeding vessels quicker and easier. Therefore, RDI helps to reduce stress and procedure time for treatment of emergency bleedings and endoscopic resections. RDI aims to help to avoid delayed bleeding after EMR or ESD. RDI may improve speed, efficiency, and safety of endoscopic treatment. Enhance the visibility of suspicious areas, which is especially important during detection and characterization. TXI stands for Texture and Color Enhancement Imaging. The incoming image is split. Texture and brightness are enhanced. During the stacking process, both images are merged. Color tone enhancements are made to more clearly define subtle tissue differences. TXI enhance the visibility of suspicious areas, which is especially important during detection and characterization. TXI stands for Texture and Color Enhancement Imaging. The incoming image is split. Texture and brightness are enhanced. During the stacking process, both images are merged. Color tone enhancements are made to more clearly define subtle tissue differences. TXI is supporting better visibility of potential lesions, resulting in image details at a level that typically only very experienced endoscopists have learned to see. TXI aims to contribute to lower miss rates for inflammation and early mucosal changes, especially flat or depressed lesions that can easily be missed. The color appearance of TXI is close to white light. This allows users to relate to imaging of lesions they are familiar with. In this regard, we aim to introduce TXI as the new white light. EDOF stands for Extended Depth of Field. The incoming beam of light is divided by the beam splitter and reflected via two mirrors to the sensor. This technology projects two images with identical content that, however, exhibit different focal lengths and combines those images into one image in total focus. EDOF supports the detection of lesions through improved visibility, thanks to a broad focus range and less blurring. EDOF allows for a much closer distance to the object in normal mode compared to previous dual-focus endoscopes. Therefore, EDOF was developed to ease handling significantly by reducing the need to frequently switch from normal to near mode. EDOF is designed to also ease handling in near mode. With its large depth of field and maximum magnification equal to that of zoom endoscopes, it allows the entire lesion to be kept in perfect focus and images to be achieved that typically used to be reserved for very experienced endoscopists. As a result, the learning curve for advanced imaging is expected to be shortened for non-experts. RDI stands for red dichromatic imaging. RDI uses an additional amber LED. Red light penetrates deeper into the tissue compared to green light. If a deep blood vessel is present, amber light is strongly absorbed. The vessel appears darker and is therefore more visible. If the amber light hits a bleeding point at which the blood concentration is very high, the amber light is strongly absorbed. The bleeding point appears darker and is therefore more visible. RDI thus helps to efficiently identify the bleeding source during endoscopic resections. This supports clinicians to coagulate bleeding vessels quicker and easier. Therefore, RDI helps to reduce stress and procedure time for treatment of emergency bleedings and endoscopic resections. RDI aims to help to avoid delayed bleeding after EMR or ESD. RDI may improve speed, efficiency, and safety of endoscopic treatment.
Greetings from ILBS. I'm very grateful to Dr. Usha Gupta for having invited me for this program. I wish I was there among
Good afternoon, everyone. I welcome you back to this postprandial session. This session is going to be on ACLF, and we have three panelists for this session. It would be Dr. Pankaj Puri. He is a senior consultant and a gastroenterologist working in Fortis Hospital, Delhi. Then we have Dr. Shalimar. He is a professor in the Department of Gastroenterology at All India Institute. And then we have Dr. Kaushal Madan. He is a director and head of clinical hepatology at Max Hospital, Gurgaon. May I request all the chairperson to come on the stage? I request Dr. S.S. Sidhu sir to please join as a chairman on the stage.
Okay, so I think, can we start? Permission of the chair, Dr. Sidhu?
Yeah, I think we can start this case-based discussion. Dr. Duseja will be presenting this case. This is a case on acute and chronic liver failure. And I believe this is cause of associated with alcohol. Yeah, so over to Dr. Duseja.
Thank you, sir, and good afternoon, everyone. At the outset, my sincere thanks to Professor Usha Datta and her team for giving me this opportunity. So what I'll do, we've been given, 40 minutes to, discuss this case. But before I discuss, I think this is just a tribute to Dr. Vinay Sundam, who has really worked a lot on ACLF. And if you look at the literature on ACLF and liver transplantation, you will find, his name may be on the tops. So we lost him this year, just at the age of 48. So with this, I think let me start the case. This is a 40 years old, gentleman who presented to an outside hospital with a history of alcohol abuse for more than 10 years. And he was taking around Indian-made foreign liquor of around 80 to 100 grams a day. And this time he also had, in between also he had history of binge drinking. This time also he had binge drinking, and he came with the history of jaundice and ascites for 2 weeks. And then worsening of his sensorium for 3 days, decrease in urine output for around 3 days. And when he presented to that particular hospital, he was found to be deeply icteric. He was afebrile at that time, but he was in grade 2 hepatic encephalopathy, and his vitals were stable. So when he was investigated there, he was found to be anemic. TLC was slightly on the higher side, 11,000. Platelets were low, 98,000. But look at his liver function. The bilirubin was, 24 was the total, and with the conjugated fraction of 18, AST, ALT elevated, AST more than ALT, albumin was low, 2.5, and he had prolonged prothrombin time of 27 seconds, which is prolonged by almost 14 seconds with an INR of 2.6. He also had renal dysfunction, AKI, creatinine of 1.5, sodium 136, lactate was 2, and his ultrasound had shown evidence of cirrhosis with portal hypertension with ascites, and acidic fluid analysis had shown that he had high gradient, low protein fluid with 50 cells, no evidence of SPP. So with this case in mind, I think let's start, what are the format I have thought is that I'll be putting in some questions, but before these questions go to the panelists and we discuss these out, the questions will go to the audience and to the residents. And anybody who answers questions right, I have been told by the organizers that you'll be getting 1 chocolate each. So first question, and same question then goes to, to the panelists to expand it and to add on to this. So I think probably there's no doubt that this patient looks like acute and chronic liver failure. And we're discussing this in this session, but then the question is, by which definition will you call it as acute and chronic liver failure? And then 2 subsequent questions, because this is an alcohol-associated ACLF. So how common is that alcohol-associated ACLF of all the ACLFs? And then how common is, severe alcoholic hepatitis, which looks like is the case here, present as ACLF. So these will be the three first questions I thought. Let me start. So please, residents, chocolates for you. Yes, Akash.
Sir, this ACLF would be by the definition of a partial ACLF, which defines it as acute hepatic insult manifesting as jaundice more than bilirubin of 5 and along with INR of more than 1.5 with clinical ascites and encephalopathy. And for the second part, how common is ALD ACLF?
So could it also fit into the canonic ACLF?
So with grade 2 encephalopathy and the creatinine of 1.5, it would fit into grade 1 canonic ACLF as well.
So grade 1 also, because you know there is a renal dysfunction maybe, right?
Yes.
And there is a brain dysfunction.
Grade 2 encephalopathy.
Right, and the bill is there. So the one organ failure, liver is definitely there.
Yes, sir.
Liver is there, and if you look at it, the INR is just 2.6.
So
okay, yeah.
this
So,
would
but the
mean
liver would qualify with other
grade
dysfunction.
2, grade 2 canonic
So
ACLF.
this will be grade 2 canonic ACLF also, right? Okay, so the second question, maybe chocolate for him, Akash, and then how common is alcohol as a cause of ACLF? Anybody? Of all the ACLFs, whatever you see in your clinical practice, how common would be alcohol? Anybody quickly? No. Akash?
More than 80% would see, 75 to 80% would be
Okay,
alcohol.
the third question is how commonly SAH comes as ACLF?
More than 90%.
Right. Okay, I think like, you can go to the panelists. Maybe I've written this for Kaushal. He's our DM resident. He doesn't get a chocolate. Okay. So DM hepatology will not get the chocolate, or because he's our resident, he will not get the chocolate. Okay. So please, Kaushal.
So I think he should get a bigger chocolate because even experts are not able to understand or define ACLF the way you have defined. So you should get a bigger chocolate. Not even two small chocolates, a bigger chocolate. So he's right when he says that according to a partial definition, it fits into the criteria of acute and chronic liver failure of bilirubin of more than 5, INR more than 1.5, development of ascites within 4 weeks, and or encephalopathy, and he's got all those features. And the recent point which has been added in that definition is a high 28-day mortality, which I have a problem with. How can you have a definition saying that this much should be the mortality? That is a separate issue. So, and I also agree that in grade 1 ACLF, according to canonic, also the canonic classification, also it would fit into the definition. And how common is ALD ACLF? So I think about 40% in our practice, 40 to 45% of ACLF which we see in our practice are due to alcohol induced. And how commonly does severe acute hepatitis present as ACLF? Now, this is an issue. If you go to the community, I think the percentage would be very less. I think it would be about 20% of severe acute hepatitis.
Alcoholic hepatitis.
Sorry, alcoholic hepatitis, which will present as ACLF. But when it comes to a tertiary care hospital where you and I are working, I think the patients who are referred to us, almost 80% will have ACLF. That's what I feel.
I think largely I agree with all the answers, and quickly this is the definition which Akash was trying to read. I think as resident level, I think you should know what is an partial definition, which has been revised after 2009 when it was given, then 14 and then 19. So jaundice more than 5, coagulopathy INR more than 1.5, complicated within 4 weeks by ascites and or NCAF, and as Kaushal said, new thing which they have added is the 28-day mortality. This is the canonic definition, again, which was given maybe around 8-9 years back from the EASL-CLIF consortium, which was again acute decompensation of cirrhosis in the form with, say, HE, ascites, GI bleed infection. But the important thing is that the canonic talks about that a patient should have one or more organ failure. Only then you can call it as ACLF. And for the sake of organ failures, canonic, they use this, CLIF SOFA score, and they gave all these, this thing. And this is what we were discussing. For creatinine more than 2 and HE of say grade 3 and 4, bilirubin of 12, INR of more than 2.5, they are all considered as organ failure. But then creatinine of 1.5 to 1.9 may be just a renal dysfunction. This patient had an INR of 2.6. So which means that one is the coagulation failure, other is the bilirubin more than 12. So that's another, so at least this would fit into maybe the ACLF grade 2 definition. So 2 organ failures, ACLF2, 3 organ failure or more, you call it as ACLF3. And if there's only one, which is kidney or non-kidney, with either a brain dysfunction or kidney dysfunction, becomes ACLF1. Okay, so this is, again, a lot of data available that how common is, alcohol as the etiology. And again, if you look at the Western figures, the 60 to 70% of their patients may be alcohol related. And even from the ARC data or the Asia Pacific data, if you look at this, chronic disease because of alcohol constituting around 50% or even 60%, and alcoholic hepatitis on top of that happening again in around 50% as the acute precipitating event. And if you look at the Indian data, this was the nasal data, which was compiled by Dr. Shalimar, whose here alcohol is around 60% as a cause of, ACLF. And even our own institute data, we showed that alcohol is around 60% as a cause of, ACLF. So I think at your level, you should remember that the 60% of almost all our ACLFs are related to alcohol. To say that what percentage of severe alcoholic hepatitis would come as ACLF. So again, that's the most common presentation of SAH. So this is again one study I'm quoting, which actually looked at, the biopsy-proven patients with severe alcoholic hepatitis and with the MADRS discriminant function of 32. And they divided these patients into 2 kinds of ACLF. Prevalent ACLF. Prevalent means there is a patient with severe alcoholic hepatitis and who comes with ACLF. So they call it as prevalent ACLF. And then there was another group who comes as SAH and over a period of time then develops ACLF. That was known as incidental ACLF, IACLF. So combined together, this constitutes around 65%. So 65% of severe alcoholic hepatitis, they will present like, ACLF. And 35% I think would be, and these figures, again, this is again from a big center, French center. So this would vary, where the patient is coming into. But then again, at your level, I think we need to understand severe alcoholic hepatitis, which is defined by a MADRS discriminant function of 32 or more. Most common presentation is like ACLF, which is around 65%. Okay, I think let's move forward and look at the severity of this patient when he presented. So I think this question was for, I think Dr. Shalimar, maybe you can take this up. How do you grade the severity of ACLF in this patient and what scores normally you would use in your clinical practice? Or maybe before you, maybe I can again go to the residents, please. Chocolates for you, please. Which severity scores will you use?
Sir, we can, sir.
Yeah, please go ahead. Yeah.
Sir, we can use the ARC score.
Which score?
We can use ARC score or CLIP-SOPA score for grading the severity. Since our patient fits into the definition of ACLF both by APASL as well as canonic, we can use either of these, preferably ARC score, which basically includes 5 things. And it categorizes ACLF into grade 1, grade 2, grade 3 based on the
Good, I think. Thank you. So chocolate for you, you can collect it now or later. Dr. Shalimar, if you can just elaborate on that.
So if we talk about, we've got a lot of prognostic scores available. So if we go to simple scores like CTP, MELD sodium, and then you got Apache. So initial studies had shown that each of these scores have some value in predicting the outcomes. I think study from PGI Chandigarh per se also shows Apache 2 had a very high sensitivity and specificity of predicting the outcome. So as things have evolved, now you got different definitions. So each definition gives you a particular group of patients, and you need to understand that there is a significant dissimilarity between the 2 groups. So if you classify a patient based on a APASL definition, he may not satisfy the Easel-Cliff definition. Vice versa also. So if you are using the APASL criteria for making a diagnosis,
use the ARC score. If you're using the EASL definition, use the EASL Cliff organ failure or the EASL Cliff ACL, Cliff C ACLF score, that performs better. So please keep in mind, what I see is most frequently, what most residents do is they'll use an APASL definition and start calculating the Cliff C ACLF score in that. See, these patient groups are different. Your prognosis would be very different. So keep that in mind. What he's rightly said is the prognostic scores, ARC, APASL Cliff, that's the, or say the Cliff C ACLF score. These two scores are most commonly used. You've got online calculators available. They'll give you the score. They'll give you the mortality at 1 month, 3 months, and then that's how you can do it. You don't need to remember what score predicts what outcome. That would be my take on that. Clinically, I would use this. We calculate every score. That's because we are collecting data. As a being a tertiary care center, I like to calculate even the MADRS, MEL sodium, and then use them individually in a particular patient. Like each score may not do really well. You need to take a call on that. That would be my take.
Yeah, I think agreed, and the points are very well taken. So I think, as we said, in all cirrhotics in general, we tend to start with, child POG score, look at the MELD sodium, right? And then in a severe alcoholic hepatitis or alcoholic hepatitis in general, we would always use MADRS discriminant function. But then these scores are, liver specific scores. And as we started with, ACLF is a syndrome which happens in patients with chronic liver disease and is associated with one or more organ failure. And these organ failures, as per the CLEF, have to be, extrahepatic organ failures. So to look at the severity, these liver specific scores may not be alone good enough. So you need to look at these scores, which also takes into account extrahepatic organ failures. That's why I think the SOFA score, the Apache 2 score, and these ARC score, Cliff C ACLF scores, these takes into account not only liver failure, but also, the extrahepatic organ failure. So this is where we were in this patient, ARC of 11, Cliff C ACLF 47, MDF of 88, MELD sodium 34, and he was child C. And this is how I think these are, again, very, as I said, very easy to calculate on your mobiles, on your laptops. Just go to the ARC site, fill in these values, and you'll get a score here. And this again divides ARC based on the ARC. You divide these patients into 3. Grade 1, and the score is 5 to 7, 8 to 10 is 2, and grade 3 is this. And this is the kind of, 28-day mortality which is associated with each score. And 1 unit increase in score, by 10, the increases the, over 10 score, that is grade 3 ACLF, will increase the mortality maybe by 20%. And these are, the beauty of these scores are, these are especially ARC, Cliff C ACLF, these are all dynamic scores. You can, use it every day. And then there's a lot of data now which people have said that day 3 to day 7 are the best predictors where you can, kind of patient would tend to stabilize and you can prognosticate them better. So I think you must use them, say at 0 level, day 3, maybe day 7. I think that's very, very important. And as was pointed out, I think bilirubin, HE, INR, lactate, creatinine, these are the components. Similarly, Cliff C ACLF, again, as I said, divides into grade 1, 2, 3, and again, the mortality 28-day and 90-day. And this is again an online, score which is available. You can just fill in and you get the, the score and the organ failure, and even the risk of dying at 1 month and at 90 days.
Dr. Ajay, I just have two things to point out. First of all, there has been a study published this year only from a large American group from Dr. Patidar, and they have surprisingly showed that these alcohol-based ACLF is just about 20%, and 80% is non-alcohol based.
Normal?
Non-alcohol based.
Non-alcohol based ACLF.
Number one. Number two is, you see, it depends upon what is your focus. Now, if you look at a patient who has come to you with alcoholic hepatitis, you would be looking at that picture entirely with a focus on getting him treated for alcoholic hepatitis And you would be looking for first confounding factors that might take him away from the definition of severe alcoholic hepatitis. Then you would be looking at what other problems are associated with him, so that you can which take him away from the mainline treatment of corticosteroids. So it is these kind of artificial divisions that we have made, they create a lot of confusion. Because when a patient comes to you with severe alcoholic hepatitis, he's got ascites, he's got pedal edema, he's got grade 2 encephalopathy, he's got probably AKI, acute kidney injury. On one hand, you would simply say that yes, this patient has predominantly severe alcoholic hepatitis with underlying cirrhosis and has got complications these are the complications. That focus probably, and then if you see all these studies are basically based, these studies on MADRS score or on the MED scores or on the Lilly scores. If you look at from a different focus, then you would say this is all ACLF. And I believe personally that ACLF really messes up the situation, because it takes away from the focus the primary diseases occur. The primary pathogenesis, that the driver is alcohol.
I think, yeah, I agree maybe partially with you on the semantics, but yes, this patient definitely has severe alcoholic hepatitis. There's no denying the fact. He has a history of alcohol fitting into that definition, bilirubin, AST, ALT, everything, MADRS, even though the histology was not available, but I think probable severe alcoholic hepatitis you can always make in this patient. Why we are calling it as ACLF is, based on, the current definitions. So let me just move from here. I think the one more score which we use very oftenly in our clinical practice bedside is what we call the simple organ failure count. This is called as SOFC. Very simple. Don't need to do it. Just count the number of organ failures a patient has, and we had actually shown that this is the kind of mortality which is available with the number of organ failures. So I think very, very simple. Just count the number of organ failure, which is given even with canonic and with the ARC also. But I think this is also you can use that. So outside, when this patient was diagnosed as severe alcoholic hepatitis. So with that diagnosis, he was put on Vicodin, prednisolone, 40 milligram a day. And the intent was to look at the response to Vicodin, and then they assess the LFTs again at day 7. And you calculate a score at day 7, which is known as Lille score, to look at the response to steroids to decide whether somebody needs to be continued on steroids beyond 7 days or not. And based on the Lille score, if it is less than 0.45, then you can continue. But if it is still beyond that, I think that becomes an indication of stoppage of steroids. So this gentleman, Lille score, even though there was a reduction in bilirubin from 24 to 18, was still 0.87. So he was taken as a non-responder to prednisolone. He even started having fever, and his prednisolone was stopped, and then he was referred to PGI here. So when he came here, so I think before I go on further, I think the next question for the residents, what do you think, were these steroids indicated in this patient? And was he the ideal kind of candidate for giving steroids? Because if you look at the first line treatment for severe alcoholic hepatitis, all the algorithms, leave aside, we will share maybe our experience later, I think, but if you look at all the algorithms, severe alcoholic hepatitis, if the patient is eligible, and if it is no contraindication, corticosteroids are the first line of treatment for SAH, or severe alcoholic hepatitis, right? So now the question again, residents, please. Was it indicated in this patient, and was he the ideal candidate? Anybody? My chocolates are going waste. Hanji Akash, you have been asked not to be qualified. You're not qualifying for the chocolate, but still you can answer.
So he had renal failure to set in. So I think renal failure, pancreatitis, upper GI bleed, these are contraindications for corticosteroids. So he had a AKI of 1.5, probably not the right candidate to start steroids up front.
So yes, so I think maybe Pankaj, you can elaborate on this. Yeah.
Well, if the MADRS is more than 32, steroids need to be considered. The standard contraindication for steroids is the mnemonic GPRS, GI bleed, pancreatitis, renal failure, sepsis. I don't think 1.5 is really, fitting into renal failures. There's no strong contraindication to steroids as far as that is concerned. Is he a right candidate for steroids? Well, we don't have these contraindications, but his MADRS score is 88. And there's been some data to show that if your scores are very high, more 54, they tend to do poorly and they tend to get septic with steroids. Saying that, these are probably the guys who are going to benefit from it. So unless there is a grossly decompensated cirrhotic, steroids need to be considered, and I don't think I will say that they should have been.
May I interrupt?
Yeah, sure, sir.
There was a study published in gastroenterology about 2 years back from the French group from the Lille Hospital. And that study had basically taken around 2,000 patients from multiple studies, and this is the meta-analysis. And they had actually made this point clear that the MDF of 54 or the MELD of 20 is not should not be treated as a cutoff point for giving corticosteroids. In fact, they clearly said that there is no correlation between these scores and the corticosteroid usage. So therefore, their final recommendation was that corticosteroid should be given. But I have an issue over here. Unfortunately, in our country, most centers are not using corticosteroids. And why is that? The reason for that is that all our patients, they have severe sarcopenia. They have no muscle mass. Muscle mass means, lack of muscle mass means lack of immunity against infections. T cell, B cell functioning goes for a hit. And the moment you start them on steroids, you light up a fire. They catch up infection and they die very soon. As a result, most of us in most centers have not given steroids for this reason, because we have seen this thing happening over again and again. And I would add to this that Professor Philip Mathur, when he came over here, he went to ILBS and I met him after that. He said, I fully agree that your patients should not be given corticosteroids because they have no muscle mass. But our patients are well-rounded. They have enough muscle mass. They don't have sarcopenia. They will respond well to steroids. So this situation is completely different from the West and our situation.
So yeah, your points are well taken. Kaushal, you wanted to add, and maybe Kaushal, you can also elaborate. SAH, yes, indicated steroid. You can debate on the cutoff for MADRS and MELD, where to give, where not to give. But then, does the presence of ACLF, does it make your decision different versus SAH, who's really not presenting as ACLF?
Yeah. So that's what I was coming to. So one criteria which I use in my practice, and now I think it has come in recommendations also. I'm sure others also must be using it. That if you get a non-contrast imaging, because creatinine may be a problem, non-contrast imaging of the upper abdomen, and if you find a large liver, I think those are the patients who predominantly have SAH and possibly not ACLF. Clinically, they may be ACLF. Those are the patients who will respond, and steroids should be tried in them. Those who have a small shrunken liver, please don't use steroids. So just a single imaging can differentiate your patients whom you should give and not give steroids.
I think that point is very, very valid, and I completely agree with that. And there is some data to suggest that. And let me show you, before I show that data, I think what you can see here is this is the, the algorithm for severe alcoholic hepatitis. And, if there's no contraindication, you give them, assess the response, at, day 7. If the Lille score, as I said, is less than 0.45, you continue. If not, then you consider them for, other modalities, which we will discuss, later. So this is the one study, which actually came and which said, they divided these patients of, severe alcoholic hepatitis into, no ACLF, ACLF grade 1, 2, and 3. And look at this, when they gave steroids to these patients, they were all biopsy-proven SAH with the MDF of, say, 32, biopsy-proven alcoholic hepatitis with MDF of more than 32, which means severe alcoholic hepatitis. And the response to steroids, if it was, say, ACLF grade 1, was 52%, but as the ACLF, in grade increased, the response to steroids, went down. So one is that the response went down, number one, but the other important is the infection rate also, went up with the ACLF grade. That's another one. And similarly, the infection rate in responders versus non-responders was also different. So non-responders obviously had higher rate of infection. So I think this is one point, which is, and the same principle, STOPA is a biggest trial on severe alcoholic hepatitis, biopsy proven, which looked at the efficacy of steroids and the pentoxifylline. So then when this study came in, which I showed you, the French study, so the STOPA did a reanalysis of their patients with ACLF to see the patients with SAH, whether they fitted into ACLF because they had given steroids. And they came out with the similar answer that if these patients have ACLF, then the response to steroids is number one, poor. And secondly, the infection rate in them is high. So I think, so the point which, Kaushal made, that based on your patients, and this has been our experience for last now maybe 20, 30 years, we hardly give steroids to our patients with ACLF, alcohol related, if, as Kaushal said, if they have a small liver, typically cirrhotic, now presenting superadded SAH and coming as ACLF. Unless they are clean, clear-cut SAH, big liver, without liver failures, I think there you can consider steroids. Otherwise, our experience has been that not only the non-response, but in our setup, it is the infection which, takes away the patient in this kind of situation. So any thoughts on this before we move further?
But I could ask the simple question, how many patients do we really see in our country having pure SAH?
SAH, that's what I'm saying. Majority, 90%, as you said, maybe 90 to 100% present as ACLF, at least to our setup. The plain SAH without, not without the syndrome as ACLF, at least is not very common with us. Any other thoughts?
So I agree with you. Majority of them will come with the ACLF, but there are a group of people.
Yes.
If you look at, more than half of them will have cirrhosis very quickly. But the place where not consider is when they are definitely over clinically cirrhotic, small livers, big ascites.
Yeah.
Those are the people not. In the others, we would consider. I mean, I understand the muscle mass, but all Indians have low muscle mass. And while it's a point of contention, unless they're obviously, besides being malnourished, also having big ascites, small livers, we should consider, not write them off.
Okay, so I think this patient was then admitted to our liver ICU. He had tachycardia on admission. BP had slightly dropped, but he did maintain his MAP of around 80. He was febrile and his HE had worsened to grade 3. Bill had come down, as I said, to 19 from 24. His counts had gone up 22,000. INR was almost the same. Creatinine was also almost the same. Lactate had gone up to 2.5. His cultures were sent, they were all sterile. He turned out to be having SPP. The acidic fluid had shown predominant polys, 600, and his biomarkers, procal was slightly elevated, procalcitonin 0.5 or 0.45 would be the normal cutoff. Beta DG and GMI, which are the fungal biomarkers, were largely normal. And so he was put on again broad spectrum antibiotics, antihepatic coma measures, IV albumin. Later, when he was not fluid responsive, he was given terlipressin. His sensorium improved to grade 2, creatinine decreased to 1.2. He became afebrile, and his response acidic fluid tap actually also showed response to SPP, and the cells had come down to 100. So with this now, Dr. Kaushal, before I come to you again, residents, can he be considered or is he a candidate for liver transplantation because he has had steroid non-response and he's SAH, ACLF. So can he be considered for liver transplantation? Residents, please. No. So Kaushal, for you.
Yeah, so I think the fact that he has been rendered considered non-responsive to steroids in itself is an indication, and the fact that all his parameters, although the initial sepsis-induced insult has been taken care of, but the basic pathophysiology, the bilirubin is still 19, INR is still high, lactates are still borderline. And if you calculate if you go by the ARC score, if it is more than 11 for at least a week, and if you look at this, the previous profile and now profile, it's almost 11. So I think he has earned a liver transplant. Whether he'll get it or whether he'll do it is a different question.
No, I think I absolutely agree with you again. And this is again the flow diagram, which I think again at residents, you must know it. This is specifically for, ARC ACLF. And then based on this, they divide based on the ARC score to 10 or less and 11 or more, which means these are all grade 3 ACLF as for ARC, right? And these are, less than 10, 5 to 7, as I said, is grade 1, 8 to 10 is grade 2 ACLF. So anybody who has, and he had an ARC score of 11 when he came in, these patients can directly be also considered for liver transplantation. But then if they are not responding, right, at day 4 to day 7, they definitely have to be considered. And especially, I think, and maybe you can try some of the bridging treatments or some of the other therapies, but then if they do not have any contraindication and if their ARC score continues to be more than 11 and without any other contraindication, I think they need to be considered for, liver transplantation. So I'll not show you data on the liver transplantation, but the option for liver transplantation was discussed in this patient. They wanted some time to decide on this. And so based on this, the next question is, we do have certain other therapies available, which we call them as, kind of bridging treatments or alternative treatments short of transplant, especially patients, those who are not eligible, those who cannot afford, or in general, I think, so we need to talk maybe the role of GCSF and maybe the fecal microbiota transplantation, maybe Dr. Shalimar. Before that, residents, anybody wants to take up this role of GCSF or fecal microbiota transplantation? No, Dr. Shalimar. Oh.
So these are upcoming therapies. So
I think somebody wants to try there. Yeah.
So regarding role of FMT, what are the data which is available? Those are historic controls. So based upon that, we cannot take any decisions. But the data which we have published from our center showed improved short-term mortality. Regarding GCSF, we have completing evidence. Most of our studies have favorable data, whereas Western studies did not show such favorable data.
Absolutely. Chocolate for him. Okay, so I think Shalimar.
So these are upcoming studies. We do not have large sample size studies. I think you need to remember that. These are very small sample size studies, which are predominantly taking historical controls, as he rightly said. We lack randomized control trials. Unless you have patients who've been included across severity, you show a response rate, then you can recommend. Right now, either of the two therapies, take-home message, not to be used in any patient of yours, apart from clinical trials. These are only for clinical trials, not for use. Its safety, its efficacy, how they change the natural course is still not known. In such a sick patient who's got an SBP, who's a non-responder to steroids, I would not like to consider upfront. Maybe you can talk to the patient's relatives. If they agree, they want to go in for a clinical trial, yes, maybe worthwhile enrolling them into a clinical trial, but also letting them know that there could be associated risks associated with doing such therapies. Coming to the GCSF per se, the trials have excluded patients with infections. If you look at, those are not that sick patients. So in a specific group of patients, GCSF has been shown to be benefit, not in such a sick patient. Similarly, with the FMT data, the studies are not there including such sick patients. So it has been shown, the data from PGI also shows that it's safe in decompensated. So we have reached the level of safety. Efficacy is still, we need more data.
Absolutely. I think again, I would say these are still not the standard accepted modalities for treating severe alcoholic hepatitis or ACLF. And the data from the Asian studies, though
do favor, GCSF as modality for SAH, but the European studies do not favor that. And then the reason for these could be multifactorial. Maybe the Asian studies followed the partial definition where it's only the liver failure, whereas the European studies had the canonic definition where you have the extrahepatic organ failures. And then also, it depends on what is the cutoff, which Dr. Shalim was saying, what the severity of, disease is very, very important. Some people would say, obviously infection would be one contraindication. The second would be a very high merit. So maybe some people would take a cutoff, say even 20 or 15. Beyond that, they would say that probably the GCSF may not work. You may have to look at, the hemophagocytosis and various other things, and the bone marrow response, and then decide whether the GCSF is really going to work or not. Similarly, the FMT role is still evolving. There is some data which has been published, but again, not a, still an accepted modality. This is a one work which was done as a PhD thesis, sorry, the MD thesis by Dr. Here in at our department under the supervision of Dr. Dhiman, which was published. And again, very small number, where it was shown that it could be beneficial, but then we have seen that it is really not free of complications in sick patients like these. They are really prone to infections, SPP, and even worsening of HE and all. So finally, coming to the last thing, this, as I said, patient was taking some time to decide on transplant. He continued to have an ARC score of 11. His MDF was high. He had become, kind of infection free. So any role of the liver assist devices there, and in our setup, the Mars and Prometheus has really not shown us a good, data. So what is the role of plasma exchange, which was also discussed as a modality in acute liver failure also. So in the ACLF setting, I think this would be our last discussion, the role of, plasma exchange in the ACLF. So anybody again, residents, please. No. Okay, so Dr. Pankaj.
So I think you're back to the wall. You have very little to offer. Is steroid non-responder. You're not looking at GCSF. You're not looking at FMT. You don't have a transplant option. So plasma exchange definitely needs to be considered as an option. There's some data from Dr. Epan's group of low-dose Plex along with low-dose steroids at half the dose, where he used it across a randomized trial over 50 patients with 40% getting Plex plus low-dose steroids, showing it to be beneficial.
So I think, again, the message would be that the Plex is emerging as a good, safe modality, effective modality in patients with ACLF, though the EASL and some of the other societies do recommend Plex as the modality for patients with ALF. It is still not recommended for ACLF. And if you have to look at the Indian data, at least 2 studies you should know. One is from the ARC group. Again, Dr. Rakhi had done this analysis. There they had shown that there's improvement in various parameters, cytokine levels, and even the outcome. We just completed and published this, very recent paper of very small number of patients of 14 case control study and around 51 therapeutic plasma exchange procedures done in these patients. And we showed that the 90-day mortality was slightly better. But these are, again, very small numbers. These are standard volume plasma exchanges, very small numbers. We probably need, bigger data, to support this, but then the modality really looks promising. And in our setup, where the cost is a constraint, and as I said, Prometheus and the Mars are not available in most of these centers, I think Plex can be considered as a modality. So I think since our time is up, I think let me summarize, which I said. So any patient with ACLF who's coming to you, say severe alcoholic hepatitis or any etiology, try to define him by what definition are you calling it as ACLF, a partial, cliff, and many patients like this patient could fit into both the definitions. Look at the etiology. In this particular patient, it was alcohol, but then you need to look at the etiology of both chronic liver disease as well as the acute precipitating event. Then look at the severity of ACLF, which has to be done by various scores. And the simple scores which you can look at is the number of organ failures for a parcel. The best score would be the ARC score. And for canonic or cliff ACLF, it would be cliff C ACLF. These are all dynamic scores. Keep
doing them maybe every day, and if not every day, maybe at baseline, day 3 and day 7. And day 7 is very, very important, in finally prognosticating. The treatment modalities for ACLF are evolving. Because of the time constraints, I think, ACLF is a syndrome which is associated with so many organ failures, and each organ would require our support. The circulatory failure will require our support. The respiratory failure would require support. Renal would require a separate support, And so organ support, obviously, I think this was beyond the scope of this presentation. So that is part and parcel. The targeting the acute precipitating event is very, very important. May it be infection, may it be severe alcoholic hepatitis, which has to be done in all patients with ACLF. And finally, you have to look at the chronic liver disease and then see whether this patient would require a liver transplant or other modalities. So thank you very much for your kind attention.
I just have one point to end.
Sure.
So I think we should not close the chapter on newer therapies for severe alcoholic hepatitis. Interleukin 22 generally, especially, seems to be very promising because it has in the small studies shown absolutely no adverse events, and on the other hand, it has, because of its regenerative capacity of the hepatocytes getting improved, these patients have shown a significant improvement. So I believe that this is one therapy that should definitely be put on clinical trial, a randomized control trial, and if this comes out to be good, then maybe this is one option which can be tried in steroid unresponsive patients, and even those patients who have infections, because this particular drug has got nothing to do with infections. It's the only role is to improve the liver regeneration.
Yeah, point is well taken. Any other questions and comments?
So supposedly we have started a patient on steroids of severe alcoholic hepatitis, and after 7 days, the Lilly score is not favorable, but there has been an improvement in MELD score by 5. Can that be considered as a soft pointer to continue the steroids further, or one should discontinue it completely?
Yes, Dr. Pankaj?
I think the data is not there. Like you look at this patient itself, you had an early change in bilirubin levels. You had a significant response, but at the same time, the same patient has become septic. So unless there is strong reason or data to support, these are going to be very individualistic decisions, where despite the the Lilly is not improving, you're continuing steroids, but you need to do it with great caution before you make any such decisions.
I differ. The reason for that is we generally don't use steroids. Number one. Number two is most of our patients have a MELD score of more than 30 to 35 to 40. Most of our patients have a discriminant factor that is more than 75. The Lilly score just doesn't apply to our patients. The score that actually applies to our patient is the MELD score. And therefore, by going by a MELD score is improving. I think that should be taken as a criteria for doing whatever you want to do. Not a criterion for which the treatment is not being given to the patient. When you are not giving steroids to these patients, then what is the point of doing a Lilly score in the first place?
If you're giving steroids.
See, that's the point. But what had happened? The steroids was given, and after 7 days, the patients worsened and developed spontaneous bacterial peritonitis. That exactly I was making the point. Our patients with sarcopenia, with low muscle mass, are not candidates for steroids.
I agree with you, but his question is, if you have given steroids, his Lilly is not good, some other parameters are involving, should you continue steroids? It should be done with great caution.
See, these things, you can individualize treatment in a particular patient. Nobody stops you. But these are all guidelines. If the LIL is not improving, that's not 100% that everybody, if you continue, will have issues. Some people can do well also. So if you think that the patient is still aseptic, no infection, bilirubin is coming down, but slowly, you can individualize and prolong it for a few more days. No harm. I think this is my personal take on that. Yeah.
Thank you. So one more question.
Yeah, please.
So patient presenting like a severe alcoholic hepatitis might progress into ACLF later. So patient might be SAH today or a pre-ACLF today. Should we give steroids that time, or should we counsel patient for liver transplant progressing, thinking that he might progress to ACLF as a pre-ACLF type of picture?
Yes, Kaushal.
So I think if the patient meets the criteria for taking steroids, I think steroids should be given in the pre-ACLF stage itself. And at the same time, see, once when these patients come to us in tertiary care center, I told you that most of them are either pre-ACLF or ACLF. At that time also, you have to counsel them regarding future need for transplant, and then you can start them on steroids if they meet the criteria and there are no contraindications.
So, one more question. So in the first question, if the patient is responding to the steroid and later develop the infection, in that case, what should you do?
So the same case, like this patient also started on steroids, now developed infection, right? So if you look at the literature and the data on steroids, they say that the presence of infection per se, if you are able to control the infection, is not a contraindication. Even for that matter, even the study which I showed on steroids also, many of these patients develop infection. Yes, and the outcome obviously was dependent. So you have to individualize. If you're able to control the infection, again, you can individualize and take a decision of continuing the steroids, especially if you're getting a response. But then if you're not able to control the infection, I think then it will be very, very dicey. More thoughts? Okay.
We were searching for chocolates for us.
Okay, so thank you very much for your active participation. Yeah,
just one.
Ajay, please, yeah.
Sorry, I was thinking, asking you something after the postgraduate. See, how can you tell these patients SALF, whatever you decide whether they have degraded, what is the chance of recompensations? And then can that decide your treatment pattern? This is a patient. I have this, okay, I have this data. I know this person is going to recompensate if I do that. Is there any data throughout the world? Then I'll like to treat these patients in a better way. Are you having data on that, or we don't have data? Sorry, I couldn't understand.
No, he's saying what is the data, what percentage of ACLF or SAH who's coming as ACLF will have chances of recompensation. Yeah. In the beginning, you kind of baseline, you're able to assess that. And so what are the chances of recompensation on him?
And then I'll hit that patient more sharply.
No, but that will depend on what grade of ACLF.
And that's why I'm saying that do we have criteria over there that you have a deteriorated patient like that, where you know that this person giving a steroid chance of a SBP and all those. So are we ready to hit that patient and try to back them, recompensate them? Or we know this is beyond our things? Like your oncologist take a decision. This survival span is, this is a BCLC-D and the survival is less than 3 months. I'm not ready to treat this patient, send the patient home and give a palliative therapy.
See, alcohol always evokes strong emotions.
Yeah, I know.
So
we have to take a decision. We see why I have emotions. I do enteral stenting. I am a heroine. And next the patient dies. So what is the fun of doing enteral stenting in that patient, knowing that this patient is going to die, and put it in WhatsApp and 10 people give a big thumbs to me. So this is our satisfaction.
So what we've been discussing so far is what is the risk of him becoming better? What are the chances of him becoming better?
Yeah,
that's what he said. If he's an overtly malnourished cirrhotic with big ascites, small liver, he's not going to involve. There's no hard data on it, but this is a general practice we all follow.
Okay, thank you very much for your active participation. Thank you.
So now we'll have our next session, the state of the art lecture. To chair the session, may I request Professor Sadhana Lalman, Professor, Head of the Department of Pediatric Gastroenterology, PGI Chandigarh, Dr. Monish Chabra, Senior Consultant Gastroenterologist, Fortis Hospital, Mohali, Dr. Pavan Rawal, Senior Consultant Gastroenterologist, New Delhi, Dr. Shalimar Sir, Professor, AIMS, New Delhi, and Dr. Anupam Kumar Singh, Assistant Professor, Department of Gastroenterology, PGI-GI Chandigarh.
Good afternoon, ladies and gentlemen. It's my proud privilege now to invite Professor Serene, who is the head of ILBS, for the state of art lecture, Role of Albumin in Liver Failure. I think he needs no introduction. He's a world-renowned hepatologist, and we're looking forward to hear from him. Professor Serene.
Thank you. I wish I could join. Maybe you could play the video, please. Greetings from ILBS. I'm very grateful to Dr. Usha Gupta for having invited me for this program. I wish I was there amongst all of you. I have no conflict of interest except to say our residents are amongst the best. Serum albumin, which is HSA, the native form of albumin, as you all know, is about 10 to 15 grams produced per day from hepatocytes. 14 grams or so are degraded, goes into amino acid pools and circulates. And the albumin is distributed both extravascular as well as intravascular. Remember these two terms, human serum albumin, the native albumin, and human albumin solution, HAS. Actually, it is a drug. I'll briefly tell you about functions, rationale for use, events which are not favorable, and alternatives. ABC of albumin: antioxidant, anticoagulant, binding and transport, colloidal osmotic pressure, also as a nutrient, corrects immune dysfunctions, capillary integrity, cardiac and positive inotropic effects. In cirrhosis or chronic liver failure, there is cell loss. So you need to replenish albumin, which is produced less. Also, you lose by ascites, tapping, or poor intake. Cell death also leads to inflammation, and the albuminome is changed, which is HNA1 or HNA2, I will show you. In a healthy liver, you can increase synthesis by 2 to 3 times, but in cirrhosis, we don't know. In liver failure, generally chronic, that is cirrhosis, albumin is low and albumin is modified. In a normal person, the albumin is called human mercapt albumin. It's about 95–90% or so. It has at 34 position group a cysteine molecule, cis34, which is the one which allows the oxidation. So this is the reduced form of albumin. It is sometimes modified, which is reversibly by a disulfide bond. This is HNA1, non-mercapt albumin 1. And if it is irreversibly oxidized, then it is called HNA2. HNA2 and HNA1 are toxic. In ACLF, if HNA2 is more than 12% of the total albumin pool, patients are generally sick and they can die. And therefore, whatever albumin you give, we have to see that has it altered, has it been altered. Albumin as a drug in cirrhosis can have several advantages. It is used for ascites and infections, HE, hypervolemia, hypervolemic hyponatremia to maintain oncotic pressure, volume resuscitation, sometimes for albumin dialysis, improving cardiac oxygen delivery and functions, hepatorenal syndrome, and AKI. In a decompensated cirrhosis, there are several changes which occur: circulatory, gut dysfunction, endothelial injury, more ammonia, and oxidized forms of albumin, which I showed you, HNA1 reversibly or HNA2 irreversibly. And ischemia modified albumin also increases. Because of these pathological changes, the endogenous albumin changes. And this change leads to several problems, and there are effects of giving human albumin solutions which can be beneficial. There are several known indications. where you can use SBP, HRS, non-SBP infections, it is a bit debatable, hepatic encephalopathy, hypervolemic hyponatremia, it might increase the serum sodium by 9, but generally I don't find this to happen. Severe sepsis or septic shock. Albumin has also been used for modifying the natural course of the disease. These are two seminal trials. One is the ANSWER study, I'll show you, which is favorable. And the second is the MACT study, where albumin plus midodrine were compared against placebo, which did not show any benefit. The ANSWER study was aimed that compared to standard therapy, if you give human albumin and raise the levels to about 4 grams for 18 months, you find an improved survival overall and compared to standard medical therapy. A later trial called ATTIRE trial published last year by China et al. They aimed differently. Patients who are admitted decompensated cirrhosis to the hospital. Within first 2 or 3 days, they gave so much albumin to raise the albumin levels by day 3 to 3 grams per liter and further to maintain it like that. Their primary composite endpoint, however, was not superior in albumin transfused versus standard care group. That included new infections, AKI, death, and survival. However, very important to remember, albumin group had more severe grade 3 events, lung infections, pulmonary edema, and fluid overload. And the conclusion was giving albumin to make it 3 grams or more was not more beneficial than the standard of care in UK. So my carry home message for you is be judicious and cautious in giving albumin in cirrhotics. Don't write it like you write an iron syrup. In ACLF and cirrhosis with shock, albumin is modified much more in ACLF, and I would say in 15 minutes of your IV infusion. In ACLF, there is an acute insult, so albumin synthesis goes down. There is very high bilirubin, which is bound to albumin, so there is no free good albumin. So more albumin you give, more albumin bound to bilirubin will be circulated. This is labile iron is free, and all these lead to, so albumin might in fact lead to more organ dysfunction. Moreover, the modified albumin changes your immune responses, decreases your adaptive immunity. So very often I feel it is better to remove albumin and replace with fresh, just don't pump albumin. I'll show you some examples. In liver disease, in ACLF, you have the native human serum albumin is oxidized HNA1, HNA2, and this leads to a neutrophil activation and a vicious cycle. Now you're giving external albumin, human albumin solution, and you add to the body's food. You also take leukocytes, the same phenomena, P38, mitogen activated protein kinase, and more inflammation. You take platelets, here HNA1, HNA2, the albumin, they keep on coming and they will change the platelets, they will activate the platelets. Let's take an example of severe alcoholic hepatitis. So more HNA1, HNA2, platelet activation, degranulation of the platelets, inflammatory cytokines, and therefore you have more of thrombosis and ROS generation. So therefore, in my mind, replacing albumin is better than pumping albumin. So platelets, neutrophil, leukocytes, monocytes. So one more time to show you that such patients of severe alcoholic hepatitis or ACLF, all their albumin is bound. Now this can be easily studied by a molecular ellipticity test. Normally, there is the healthy albumin is very elliptical, rounded, but slowly ellipticity increases, and in patients who have got severe alcoholic hepatitis, the albumin solution molecule changes. From the heart-shaped structure, it becomes an elliptical thing, and this predicts mortality. There is limited success with dialysis. I'll come briefly to ACLF and ascites. In patients who are cirrhotics, we do large volume paracentesis, and albumin prevents it. However, in patients with ACLF, there is an acute portal hypertension and a very, very tense abdomen. PICD incidence is high. If we give in these patients albumin, it has an advantage over in survival. And this is survival benefit is seen at 28 days. So if you tap, you can give albumin. Other than tapping, don't give albumin. Also, in such patients, hyponatremia is less, encephalopathy is less in albumin group, and acquired kidney injury. So only if you are tapping, albumin is permitted. In shock, in both cirrhotics and others, patients with cirrhosis already have an increased heart rate, cardiac output. Due to portal hypertension, they have a vasodilated system. There is an arteriolar contractility is down. In such patients, the development of sepsis or development of any other complication will further vasodilate. So cirrhotic with hypertension and sepsis is a very challenging patient. What our aim is that we in 3 hours time bring a goal-directed therapy to improve the mean arterial pressure and improve lactate clearance. In crystalloids, when you give, it is rapidly leaking out from the capillaries. In colloids like albumin, there is an integrity of the glycocalyx and the luminal wall, and therefore colloids are considered superior to crystalloids. This study, which is based on fluid resuscitation in sepsis and cirrhosis protocol, the FRISK protocol, it shows if you give 5% albumin compared to saline, the 7-day survival is superior. And also, you will see these patients have a faster clearance of lactate. So we as a standard therapy, and you will see so many of them, in emergency, give 5% albumin for resuscitation. We also compared 20% albumin with plasma light. It's published very recently, and 20% albumin reverses shock in 3 hours time. Much better, nearly 3 times than plasma light. However, there is many more complications. So almost 1 in 4 patients had to be discontinued albumin within 6 hours. So for first 3 hours, you can give 20% albumin, but carefully monitor pulmonary edema and other reactions. So I have defined for you when you can use albumin. You can use albumin for MVP. You can use 5% albumin. In FRISK protocol, you can use 20% albumin in the very beginning in a patient who has got severe hypertension. The reactions of albumin, you do not look for normally. So look for skin, cardiovascular, respiratory, hematological, especially coagulopathy, worsening of bleeding. Never give albumin in a bleeder, gastrointestinal, nervous system. This is my last slide to show you albumin is good, but it can be bad, like any other known drug. Therefore, be aware of the potential adverse effects and use very judiciously in patients with liver disease. I have not discussed with you acute liver failure. I have discussed only ACLF and cirrhosis with decompensation. In ALF, there is very limited data. However, initially albumin was used to improve the oxygen delivery to the brain. However, it may not be true. In fact, it can worsen cerebral edema. So avoid unless there are more data available. I would like you to consider Hepatology International with a good impact factor for publishing your work in future. Thank you and have a great day.
Thank you, Professor Sareen, for that wonderful talk and clarifying a lot of the concepts for the postgraduates gathered here. And I would like to tell everybody that Dr. Sareen is live and he would be able to answer your queries, questions, and can we have some discussion on this?
A wonderful talk, Dr. Sareen. Just wanted to know, in the commercially available human albumin solutions, what percentage is oxidized and what percentage is reduced? And is there test clinically in patients inside in vivo, how much is the reduced and oxidized forms and how to tackle that?
Normally, all the albumin preparations have impurities which are to the range of 20 to 27%. They cannot be cleared because it's a human product. As far as HNA1 is concerned, it is just less than 5% or so. HNA2 is hardly there in the commercial albumins. However, if you keep the albumin out, and many people take them home after getting them issued and give home, we do not know that kind of albumin. So albumin must be clear, kept in an amber color bottle. If it is in a transparent bottle and exposed to sunlight and temperature change, it can become bad. So if you are using perfect situation, then the commercial albumins are okay.
Thank you.
I would also like to say that now 25% albumin is also available, and we have not compared, but remember 25% albumin is a little more expensive and can cause more pulmonary edema. Therefore, longer duration of giving albumin rather than 6 hours albumin and pumping 100 or 200 ml is not easy. If you just go by any of the guidelines, let's say for SBP and others, 1.5 gram of albumin giving per kilogram in a 70 gram can be very high. So we all need to see whether we should have our own assessment of patients and guidelines rather than use what the Western guidelines and the dosages and the duration is recommended.
Good morning, sir. I'm Dr. Monk from AIMS. I have two questions, sir. One, you alluded to ischemia modified albumin. Could you tell us any clinical relevance or any diagnostic relevance that has for us? And second, sir, and the conditions other than SBP and AKI-HRS in which we have established regimens, in other diseases, do we need to give albumin daily or can we give them every 3 or 5 days in hospitalized patients? Because the half-life is 7 to 14 days for most patients in non-cirrhotic populations.
Very interesting. Firstly, sorry, the first question was on the IMA. The IMA normal values of ischemia modified albumin is less than 3% or so. Nowadays, people use IMAR, ischemia modified albumin ratio compared to the albumin, and the ratio has to be less than 3. Means it should not be higher than the current albumin levels. But we are not using it. The cardiac patients or the MI patients, this is very often used. Diabetics, IMA is very often used. We are not using, but many places it is used. As far as indications of albumin are concerned, I must say the most abused is patient has come with a low albumin of 2.5 or 3, has no pedal edema, no ascites, but just albumin is low and we pump in albumin. I don't think we should request the patient to improve diet, give some oral albumins or whatever form. The indication of an admitted patient for giving albumin are very low. One is, of course, SPP.
2, when you are doing LVP, and 3, if patient has AKI after 24 hours or 48 hours of volume resuscitation, 63% of AKI are pre-renal. So don't give albumin the moment the patient has come into emergency. So the judicious use of albumin in proper indications. Of course, in shock, there is no doubt in my mind a hypotensive or a shock, cirrhotics in critical care, 5% albumin is life-saving. It should be given, but must not continue for long because the nitrosoalbumin which is formed and the coagulopathy, the low platelet count, coagulopathy it induces within 24 hours. So short duration to bring the blood pressure, it is very good.
Good afternoon, sir.
Yes.
So one question regarding refractory ascites. How long the long-term albumin should be used for refractory ascites, and how frequently should we use in routine OPD basis we find these patients?
Refractory ascites, if you are doing LVP regularly, it should be done. Before doing LVP, I suggest you should do PRA, plasma renin activity, and pro-BNP to see the cardiac stretch. In my mind, most refractory ascites are right heart failures because of the poor pumping capacity. After the patient is declared refractory, hyponatremia, yes, give albumin. But if you have to treat like disease modifying agent, just read the new paper in JHEP where I had also written something, then you should not let the patient go to refractory ascites. Once the patient has got refractory ascites and you're doing repeated tapping, in that situation, I don't think after a month or two we should continue giving it. Before refractory ascites develops, you can continue giving it as in the ANSWER trial. It works, it is expensive, it can modify the disease states, it decreases AKI infection. But these are separate groups. You have to maintain them to 4 grams per day and is expensive. And for Indian patients, coming every 2 weeks to hospital is not easy. So I would do a TIPS in refractory ascites much earlier than doing giving albumin.
Thank you, sir.
Sir, myself, Dr. Shiv Pathak. So a question regarding what is the sodium content of albumin, which no one looks. Every company is writing that there is a low salt albumin, but one company is writing not more than 110, while someone is writing 160 to 180 millimole per liter. Where there should be a difference of giving any of it changes in the outcome.
Brilliant question, Shiv, and you share my name. That's good. Low sodium albumin is expensive and they don't make it, and they all mislead us, but the content is very high of sodium in this, and that's how it's not the albumin which raises sodium in a hyponatremia. A patient who has come with ascites and hyponatremia, you think it's all the albumin? Part of that is as if you are giving albumin orally. So I agree with you, we should be careful. Third spacing of bialbumin is because you are giving extra sodium. This is measured by transcapillary escape rate, TCER. The TCER, by giving your sodium containing albumin, increases. Normal TCR is 3 to 5%, but in a cirrhotic, it can be 11%. Means of the given albumin, 1 in 10 part will be, it will escape your capillaries. So you're very right. Third spacing on second and third day of ICU stay is a result of albumin, excessive albumin, and salt in the albumin.
Sir, just one more question. Sir, what is the role of egg albumin to increase levels of serum albumin? And second is, what is the percentage of pre-albumin in preparations as well as the normal bodies?
So pre-albumin is a albumin which is an acute phase reactant. The half-life is about 1.9 days or so, or even less. So it's not a very useful albumin. The egg albumin are of 2 types. One is ova-albumin, ovalbumin, and second is the pure albumin. Ovalbumin is an immune kind of albumin. It goes in and it's like a food for immune cells. And the egg albumin is about 6 grams to 7 grams per egg. And albumin is totally absorbed in the stomach. It doesn't need to go to intestine. So if your patient has taken maybe 4 or 5 eggs, is as good as a 20% 100 ml albumin solution. I encourage it. Absorption is complete, nearly 99%, except patient has a GI bleed. Then albumin orally is good. However, the albumin powders or solutions which you give, which are commercially available, I'm not too sure how much is the albumin which goes in. But pure egg as a natural, animal protein is very good.
Thank you so much for an excellent presentation. We have to close the set of times. Thank you, sir.
Thank you so much. I'm very grateful. I see the hall is packed. Congratulations to PGI team and Dr. Usha and the whole group organizing. Thank you.
We'll start with our next session. This is going to be on acute vascular thrombosis. The chairperson for this session would be Dr. Ananshu Behra. He's a professor at and head of the Department of Gastroenterology of General Surgery at PGI Chandigarh. Then we have Dr. Pankaj Gupta. He's an associate professor in the Department of GE Radiology at PGI Chandigarh. The panelists for this session would be Dr. Nikhil Nankarni. He's a consultant in the Max Super Specialty Hospital, Mohali. Then we have Dr. Sridhar. He's a consultant in the Department of International Radiology at PGI Chandigarh. And we have Dr. Sunil Taneja. He's consultant in the Department of Hepatology at PGI Chandigarh.
So as our panelists are settling down, so as it's supposed to be an interactive session, I have requested that we need to have residents who are going to answer the questions, not the panelists. So may we have the 3 residents, please, on the dais? You can join and come in. Come upstairs. So I think I like you all to be involved. It's an open session, and I've got lots of chocolates. If you don't take them, I'll take them back. Okay, so the case which I have lined up for you is a patient who's been recently admitted. Recently admitted only this is his history. He's seen by one of our residents on this month itself. So she's a 27-year-old lady, and she's symptomatic for 2 months. She complains of pain abdomen, and along with that, she also has fever, and for 20 days, she's developed ascites. So maybe have from you, we can start 1, 2, and 3. Maybe you introduce everyone first, your name, and then let us know how do you want to proceed from here. So in terms of history, what do you want? So what are you thinking with these symptoms?
I'm Dr. Shirish from second year, Toothukudi Medical College, Toothukudi.
Okay.
Patient is symptomatic for 2 months and having pain abdomen on right hypochondriac pain and on and off fever.
Yes. Yeah. So any one of the 3 of you can take a call. Just keep asking, what do you want more further in the history? What are you really thinking in this patient? We can join in from, please. You've got lots of mics over here, please. I want the residents to get involved. Come ahead, please. Just ask, what do you want to ask in this patient regarding his history? So I've given you 3 symptoms: pain, fever, and ascites.
Any previous history of liver disease in this patient?
Excellent. So you want to know his previous history of, so
Yes.
what are you thinking? What could be the possible scenario?
Actually, the patient presented with pain abdomen, fever, and ascites. So I'm thinking that in an underlying liver disease, the patient may have a viral hepatitis, which is moving on to a picture of an ACLF.
Excellent. So that's a very good good point what you raised is you're thinking of possibly an underlying liver disease, which has now led to an acute decompensation. Okay, from the house, please.
So I would see the female pain abdomen, 20 days history ascites. Right. So I would consider HbO2 as one of the possibilities.
Okay, so you want to think about something as a vascular cause that could be responsible, some veins which have got blocked. So beyond HbO2, do you want to think something which could be a more common presentation? Some other vessel involvement, which can present you with pain, ascites.
PVT, portal vein thrombosis.
Okay, good. So you want to also keep portal vein thrombosis over here. Okay. What else do you want in the history? And yeah.
History of any alcohol intake.
Excellent. So you want to look at possible cause which could be responsible, and alcohol is one. So you, again, pointing back to what your friend has said, there's possibly an underlying liver disease, which is there, which may be silent, and then it has now, the patient has come to you with acute decompensation. So anything else somebody wants to ask in the history?
History of any associated leg swelling and breathlessness.
Okay, so where exactly are you thinking about? What are you keeping in mind when you say that you want to ask history of, say, breathlessness? Are you asking for orthopnea, PND? What are you really looking at?
I definitely have to rule out a cardiac cause.
Excellent. So you want to look at, you need to keep a cardiac cause also as, so you're not just focusing on the liver, start thinking, you need to think laterally. Is what could be the other possible causes for the clinical presentation in this patient? Okay, anything else in the history? You want to know, you want to think, well, what's your, yeah.
What drug treatment was she on?
Excellent. So you want to know the background, what kind of drugs. So can you tell me some drugs which could be responsible for this kind of presentation with jaundice and ascites? We'll come back to you. Let him answer first. So what drugs are you thinking of? What are the common drugs which can lead to jaundice, which you'll see in our country?
Most common ATT.
Excellent. So you heard about in the morning in the ALF session, anti-tubercular drugs can cause jaundice. You may have other drugs, even common like something like antibiotics. You may have drug like anti-epileptics. They may all cause drug-induced liver injury. So need to keep in mind these drugs could be, and especially in a female who's out here, you want to look for consumption of oral contraceptive pills. Yes, please.
Oral contraceptive and any history, obstetric history.
Excellent. So you want to look at the obstructive history. So what is written over here? Can somebody, I think you read it over here. She has a last childbirth almost like 4 months back.
Yes.
So that's a very important history when you need to ask in your patient what was her last childbirth. Has she recently delivered? So a pregnancy, you know, all is a hypercoagulation. So that may predispose to some facts, some etiologies which could lead to this kind of presentation. So do you want anything else in the history? Or are we okay? So tell me, what is your differential list quickly? See, this is how you are asked in the exam. You need to get used to it in the word rounds. We're having a case like that. Come on, please.
Subacute presentation.
Okay, so you want to keep chronic liver disease as presentation. One. Okay, give me the other differentials.
Acute on chronic liver failure.
Acute on chronic liver failure. Okay, the duration is almost like 2 months. Going beyond it, the classical, what the apostle will define it as. Okay, then agreed. So chronic liver disease, cirrhosis, no cirrhosis, likely, and then a decompensation. Yes.
Budd-Chiari syndrome.
Budd-Chiari syndrome or hepatic venous outflow tract obstruction.
Yes.
So 2 differentials. Next. So what could be the other differentials? Please go ahead. Yeah. Please give the mic on the third last row over there.
So past history of tuberculosis.
Excellent. You all missed out. How can you miss out tuberculosis in such a patient? But she said as drugs. He said drugs. So tuberculosis is a very important history which you need to elicit in this patient. That's very important. Okay. So you think possibly infective cause. So I'm just broadening what you were thinking. From tuberculosis, I'm just giving you a broad differential as infection. Tuberculosis could be one possible etiology. Can you tell me other etiologies which can be responsible for pain abdomen and ascites?
Liver abscess can also.
Excellent. So are you missing out simple things which you're going to see in your clinical practice? A patient comes with pain abdomen, right upper quadrant, liver abscess. You have to think about it. You cannot miss a liver abscess in such a patient. Tell me more infections which can present with similar kind of.
Cholecystitis. Okay.
Excellent. So you need to think about common things. So think about, you have to keep this in mind. These could be the possible differential diagnosis in such patients. So coming to our main panelists, Dr. Sunil, what do you think? Anything else you want to add up? I think we've had good inputs from our.
Yeah, so for the point of discussion, I think we can divide the causes of ascites into two groups. One is related to the liver and the second group is unrelated to the liver. In the unrelated liver causes, I think tuberculosis is always one differential diagnosis, especially in our country. And other infections, other tropical infections like leptospirosis, scrub typhus, and others can also present with ascites or polycerositis. But though the typical history is not here, but you should keep a differential diagnosis of one you said is liver abscess also can present like this. So let's talk about other causes which are not related to liver. Pancreatitis is one you should keep in mind because there is some history of pain abdomen in this patient, and she has developed ascites later on. And malignancies have to be also kept in mind. So in this age group, tubo-ovarian malignancies can present like this with ascites and pain abdomen. So now coming back to the liver, obviously cirrhosis is the most common cause of ascites, we all know. And second would be non-cirrhotic causes, in which, I think butt cherry would be another one possibility, vascular causes.
Okay, so good. So we've discussed, you said about infective, chronic liver disease, decompensation, connective tissue disorders, another differential diagnosis. SLE can have polycerositis. So do keep in mind that could be a possibility. So broadly, you need to keep these as differentials. So now you've taken a history. So what do you want to examine from our panelists over here? What do you want to look in this patient specifically? So how are you going to see, like this patient is presented in emergency. What things are you going to look at?
Signs of liver failure.
Okay, so you want to look at peripheral stigmata of liver disease. You want to look at signs of liver failure. Okay, next. See, her symptoms are pain abdomen, ascites. What do you want to look at? Anyone, please?
Tender hepatomegaly.
Excellent. So you want to look at the organs over there. Is there a liver which is palpable? Is there a spleen which is palpable? Is there ascites? Are there dilated abdomen? So you need to look at, we talked about differential diagnosis. So you need to look at all these possibles. Now you know, look at the hernial sites. You want to look at from the general physical examination, everything.
Murphy sign,
You want to look at,
GB.
yeah. So you want to look at, is there any Murphy signs positive, or apart from that? Anything from, yeah, please. Excellent. So you want to look at, you're thinking possibility of malignancy over here also, or say tuberculosis. You need to look at, are there any cervical lymph nodes? Are there any other nodes at any other site? So is there any supraclav lymph node? That's very important. You want to look at the umbilicus also. Very rarely, if you're lucky, you will ever see in your life is a Sister Mary Joseph nodule, which is seen at the umbilicus, but rarely we do see, it's seen very rarely these days. You want to look at the anterior abdominal wall for any dilated veins, posterior abdominal wall for any dilated veins. You want to look at pedal edema. So you need to look at all these things in your patient. You need to narrow down from here what could be the possible cause in this patient. So Dr. Nikhil, do you want to add up something to this?
If Budd-Chiari is also a diagnosis, then for seeing the hepatojugular reflex, whether it gets transmitted.
Excellent. So you need to look at, so what will happen to the hepatojugular reflex in Budd-Chiari?
It's absent actually.
So it's absent. So you need to keep that. Really difficult to elicit such a reflex in a patient who's really has a very distended abdomen, but you need to keep this in mind, right? Okay, Dr. Nikhil, do you want to add up something?
Yeah,
to
so
what
one more differential diagnosis that we would miss is that peripartum cardiomyopathy. So she is 4 months post delivery, and a cardiac cause which may cause congestive cardiomyopathy and ascites is very, very common. And that's where cardiac examinations should also basically be a part of your examination, JVP and the complete cardiac examination.
Completely agreed. So you need to look at that. Any other thing you want to tell the residents regarding the examination?
No, I think most of them doesn't.
Okay, that's good. So this was his abdominal exam. A beautiful image made in the emergency by one of our residents. She documented the vitals and shows you what there's gross ascites, and the umbilicus is normal. There are no dilated veins. Okay, so Now we've got history, we've got examination. Do you have any other differential which we missed out, or are you happy with the list what we've kept? Yeah, please go ahead.
Can we keep a flare of autoimmune hepatitis, female patient?
So in the broad, what we've talked about is chronic liver disease. You may have that. If you think that he's got ascites, I'm thinking possibly that patient already has an underlying cirrhosis. So, or an underlying chronic liver disease. So yes, chronic liver disease, all etiologies will come out here. Whether it's autoimmune, Wilson's, whatever you want to, Hep flare, or underlying alcohol. So you need to rule that all out in your history. Plus, you need to go more further, look at specific symptoms, signs, and then go further into the investigations. So that's very important. So you are looking at autoimmune, you need to look at associated, say, hormonal disorders, other kind of could be presentations with the associations with autoimmune. You want to look at overlap syndromes, eye symptoms. So all these things have to be elicited in the history, and you need to look at in the examination. Right? Okay.
So I think I just want to add one more point.
Yeah,
so
please.
we should not forget nephrogenic ascites also. Sometimes nephrotic syndrome can present like this.
Even hypothyroidism.
Hypothyroidism and hypoalbuminemia due to any cause.
But do remember, these are rare causes. You keep them lower down in your differential list. So whenever you're presenting, to keep that, these could be the possible causes of ascites. There are odd problems in this patient, pain abdomen. Unless you say it's infection, then I'm not looking into specifically into thyroid and nephrogenic. So you need to look at specific causes. But broadly, I think we have come down to a possible list of our differentials, and differentials remain same. Okay. So, okay. Right. So how do you want to investigate? You kept your differentials now. What do you want to do next?
First,
So classical thing, whenever you're asked in the rounds, first thing is I'll get an hemogram then. Okay. We'll get an hemogram then?
Yes, sir.
That I help you. Okay. Then what do you want to do next?
Baseline LFT to look for the serum albumin.
So what are you looking at in the LFT? What do you expect in this patient?
I look for the albumin.
So let's come to our differentials. Your friends and you have already raised a list of differential diagnosis: chronic liver disease, would be multiple other causes. So what are you expecting in LFT of a patient with chronic liver disease, and what are you expecting in a hemogram of a chronic liver disease? Or the other differentials?
Hemogram, I would expect a thrombocytopenia.
Okay, good.
And if he's having a associated splenomegaly, that could be pancytopenia also.
So you're looking at cytopenias. Okay, then in the liver functions, what are you looking at?
Whether there is any rise in bilirubin,
Okay.
associated transaminitis, and albumin globulin ratio is reversed, indicating a chronic liver disease.
Okay, excellent. So you need to interpret the LFTs according to as the reports are. Okay, so what we did out here is we got our hemogram LFT KFT done, and then let me show you. This is the LFT. Now interpret this LFT for me. So it's open house. Please, I'll read it for you because it's little small, and this is a copy of the investigation chart. So the hemoglobin is 11.2. Counts are 12,100, platelets are okay. INR is 1.9, urea is slightly elevated. If you come down, the important findings over here are albumin of 3.2, OTPT are 659 and 383, alk phos is 229. What do you interpret? Anyone from the house, please.
The AST is in the range of 1,000 actually, and the bilirubin is well preserved. So, looking
No,
at this-
albumin is 2. So
not albumin, the bilirubin.
Bilirubin,
So vascular can be a acute vascular insult with.
So if you see such a liver function test, leave aside what we talked about in history, what is your interpretation? What is the possible cause for this OTPT in the range of 600? Now look at this, they've gone to 2,000.
It can
So
viral
looking at
etiology.
viral hepatitis, that should be your first differential diagnosis. Before you jump on to anything else as differential, I like to keep as viral hepatitis. Okay, what does this such high rise in OTPT suggest to you in apart from viral?
It can be a drug-induced liver injury.
Drug-induced, viral, drug-induced, next.
Ischemic hepatitis.
Ischemia. So these are common differentials which you need to keep in mind. Among the viral, do keep in mind viral heps are known to cause. When you see also such high, do keep atypical infections like HSV and CMV can also, HSV specifically can give you such high rise in OTPT. So keep that in mind. So viral, drugs, ischemia, right? Okay. What happened? Let me take you through from 4th to 7th. What happened? I have not given you any details beyond 7. So her INR went up from 1.9 to 3.3. The albumin dropped down. Her OTPT went up. Her MELD score, which was calculated, was 26. So there was a deterioration in the hospital. So what do you think what's happening? Yeah, go ahead, please stand. Come. Yeah.
Sir, in this LFT, OT is more than PT. I would
Yes.
like to know what is the LDH of the patient.
Okay, so LDH was normal. Never went into hypertension. There was no ischemia. Sensorium, she's fine. She came with just these symptoms. So there was no altered sensorium till now. But those are very important things. Very important point what you raised is you want to know, is the patient going into what? So is ACLF? Look at the bilirubin, not elevated at all. So doesn't satisfy either the parcel or the criteria for the easel thread, right? Okay. So no significant past history of any kind of decompensation in the past. This is the first presentation of 2 months duration. Okay, please, yeah. Okay, no. So anything else you want to add up, my main panelists?
So I think acute vascular thrombosis has to be considered here as a very strong possibility because there's a rapid worsening of LFTs, INR, and there is no encephalopathy in this patient. So acute vascular thrombosis should be kept in mind.
I think you've raised a very important carry home message for the residents is whenever you see such a patient, do not miss out the common differentials. You know what the topic of this presentation is, but you can't miss out the standard differential diagnosis, standard approach to a patient who comes to you with this kind of presentation, right? That's very important. Okay, so what do you want to do next? So I've already given you want to do an ultrasound and any other investigations you want over here, please. Okay, now you take the mic. Tell everybody what do you do in an ascitic fluid examination. Tell me all tests which you'll do in an ascitic fluid.
A total leukocyte count, differential count, total protein, albumin, good, ADA,
right?
And if we are suspecting a malignancy, then malignant cytology.
Okay, something else?
Cultures.
So you'll send for cultures also. You also first is look at this color. Do not miss out on the color of ascitic fluid. That's very important, right? So you want to do an ascitic fluid examination. So the ascitic fluid examination showed around 100 cells, and it was the protein was high, the SAG was also high. Okay, let's keep this in mind. What next investigation do you want?
Doppler of the hepatoportal axis.
Okay, so apart from Doppler, what do you want to do next? What else are you then thinking? Any other further investigation you want? Yeah, please. So you want to look at the, we'll show you in the Doppler, we've got, we'll show you the images, what came on that. But any other investigation you want more from here, you want to confirm the diagnosis first. Okay. So in addition over here, once you are done with a Doppler or an ultrasound, you would need further other evaluation in terms of an endoscopy, right? Okay, let me just come to, and let me just show you what came on the ultrasound over here. Before I come to my panelist, but to Dr. Sridhara, who's going to interpret these images? I have not given you what's there in the images. Please take the mic and tell me what do you see on these images.
Yeah,
Ascites is there. I'll help you with one this thing. So you see ascites over here. What do you see on these images? Anyone?
Hepatic veins are not visualized and IVC looks compressed.
So, okay, I'll just show you. If you can appreciate over here, maybe Dr. Sridhar, you want to take?
I think there are 4 images. In the first image, we can see that's a sagittal view, and you can see an echogenic line. So that's generally represents a chinked IVC. And in the Morrison space, you can see mild fluid. Whereas the second image is a subcostal view where we are trying to see all three hepatic veins and an IVC. So in this image, we don't see any of the hepatic veins. And moreover, we can see that liver is heterogeneous in echo texture. And in the lower down images, we are trying to do a color Doppler. In the same sagittal view, we try to see a color Doppler and see the flow within the IVC. I don't think we are seeing any flow within the IVC suggesting a thrombosis. And the last image, it shows a moderate to gross ascites.
Okay. So what's your diagnosis now? What do you think is, you heard the image ultrasound report. What do you think?
Budd-Chiari syndrome.
Okay, you think it's a Budd-Chiari syndrome. Do you want to do any other investigation? Are your diagnosis done? Okay, so Dr. Sridhar, how confident are you when you do this Doppler and tell your clinician friend what the diagnosis is? Do you suggest any other imaging, or you are happy with the ultrasound? Sorry? Okay, so CT
Yes.
venography. Maybe I think Dr.
I think
Sridhar
one thing I would like to say is like for the diagnosis, anyway, there are a lot of differentials in this patient. One of them is very much certain that this patient has a Budd-Chiari syndrome because the hepatic veins are not seen. Doppler is almost 85 to 90% sensitive in picking up this. Both sensitivity and specificity is good with the Doppler. And ultrasound being one of the easily accessible modality, radiation free, and can be done cheaply, that should be the first investigation, and it has a very good sensitivity. As I said, it's in the range of 90% almost for both sensitivity and specificity. I would still go on with the next investigation because once we have diagnosed the Budd-Chiari, there is further management needs to be decided. That all depends upon how exactly the collaterals are there, because there are other things other than this. We need to see extrahepatic collaterals are there not, then whether there is a splenomegaly is there or not, what is the status of portal vein, splenoportal axis, is there is a thrombosis that is extending into the portal vein or SME. So we need to look at all other things. So we can go for both CT as well as MR. As far as specificity is considered, MR venography is better, but in Indian scenario, availability, cost, ease of doing, I think CT is better. So CT is just is good for us because it is easily available, lesser cost, can be performed. But if you consider imaging wise, both CT venography and MR venography will equally do well in diagnosing all these things and looking at the parenchymal changes as well as vascular changes.
Okay, so remember what Dr. Sridhar has told you. Whenever you get a report showing that the diagnosis, because we as clinicians or residents, what you would be doing is you need just the last line. What is the diagnosis? You need all those details from your radiology colleagues that will help you in deciding how you're going to plan a management for this patient. So very important. Okay, so this is the CT. So just because we're short of time, I'll just show you over here. What you see over here is a big caudate lobe. And apart from that, IVC is chinked out and we don't see the hepatic. Okay, so you got this report. Now, what are you thinking? You're thinking your diagnosis is Budd-Chiari syndrome in acute presentation. Okay, so how do you want to proceed further from here?
So procoagulant workup.
So you want to do a procoagulant workup. So what procoagulant workup are you going to ask?
Sir, protein Z, protein S, antithrombin 3, myeloproliferative workup, and JAK2 for the JAK2 mutation, APLA workup, factor 5 laden deficiency.
Right. So you want to do a complete workup or you want to be a little choosy? See, a complete workup costs you how much?
More than 10-12,000.
So I'll say more than 25,000 if you start looking at all these things. If you're sitting in a private sector, it'll be more expensive. But you know, in an acute setting, these parameters, like specifically what you antithrombin 3, protein C, protein, these are acute phase reactants. They go up and down. There's no utility of them doing in an acute setting. And the important points which you need to keep in mind is APLA, myeloproliferative receptors, PNH. These three is what you need to work up. The rest of the thing is not needed because they do not have much influence in your management. What is your management in such patient? Anticoagulant. You have a positive result or negative result, how does it matter? You need to treat for PNH, you treat for myeloproliferative disorder, you treat for APLA. These have specific treatments. The rest of them is all anticoagulants. So there is no additional benefit of doing these.
So let me just go a little more further. So this patient is another patient who presented with a portal vein thrombosis. So you see the CT findings over here, the thrombus extending from portal, almost like portal vein going right down into the SME. So do keep in mind that patients whom you're suspecting as Budd-Chiari may also have additional thrombosis at other sites. So this is very important because your management plan would change depending upon what the imaging shows. So we are a little short of time. We'll just run through the couple of slides more. It's like I'll just take you through the background. Any obstructions in the hepatic vein till the opening of IVC into the atrium is what we call as Budd-Chiari or hepatic venous outflow tract obstruction. Fulmin presentation is uncommon. For all residents, remember, they'll present with tender hepatomegaly, jaundice, and ascites. AST-ALT will be very high. Acute will have tender hepatomegaly and ascites, but there will be no HE, whereas ALF will have an HE. AST-ALT will be little less elevated. Subacute and chronic will present with cirrhosis and its complications. Do examine for dilated abdominal veins, leg ulcers, presence of ascites. Take home message from this slide is patients with Budd-Chiari compared to decompensated cirrhosis, the LFTs are preserved, platelet counts may be high, they've got high protein, high SAG ascites. Decompensated cirrhosis, low albumin, high SAG ascites. That's a take home message. There's an obstruction, you don't relieve it, the disease progresses, gets complications, you got inherited and acquired prothrombotic states. Do not work up for these causes, that is protein C, protein S, factor V, antithrombin routinely. Get your hematologist friend in consultation. He'll better guide you what is the relevance of these tests. Look for the JAK2. If negative, CALR can be done. Antiphospholipid and PNS. They have specific treatments. Dr. Sridhar has already highlighted to you about the imaging. Liver biopsy has no role in diagnosis. You do it only when you are in doubt whether the patient has some other cause or your diagnosis is unclear. We'll show you dilated and congested sinusoids, predominantly in the zone 3. Presentations we talked about, they may present with acute, subacute, chronic, or complications of cirrhosis. You intervene and lead to a physiological flow, thus reducing the complication. Management is what we talked about, symptomatic. They've got viruses, you need to manage them. You need to relieve the obstruction, start anticoagulation. And if they have cirrhosis, monitor them for the development of HCC. Medical managements alone have poor outcomes. Anticoagulation, you start in all patients, but they also have associated complications. Do keep in mind they may have bleedings. So you need to monitor the INR if you're using conventional vitamin K antibiotics. Radiology, we heard from Dr. Sridhar, you need to plan. The interventions may be angioplasty or stenting, TIPS or DIPS, or local thrombolysis. I can't go in detail, otherwise I would have had Dr. Sridhar take over this and he would have given you a very good picture. Unfortunately, I've been given strict instructions to finish in time. So for IVC obstructions, you can do angioplasty and stenting. And if you've got hepatic vein, you need to decide whether it is a short segment, ostial, or it's a long segment. So you decide between, for ostial and short segment, between angioplasty and stenting. If you've got a long segment block, think about doing a TIPS. You can do either by a transjugular or transhepatic or combined route. So this is where you puncture into the hepatic vein, you see a contrast not flowing, dilatation has been done, and post that you see good flow across the hepatic vein. So these slides are all courtesy to our intervention radiologist, Dr. Shiva, who does all these things. I'm sure Dr. Sridhar does also an equivalent good job. Hepatic vein stenting, this is what is shown over here. You can do a TIPS or say IVC angioplasty. And then what is important to note is this study which showed us Chinese randomized control trial, only randomized control trial in patients with Budd-Chiari, that angioplasty plus stenting is better than angioplasty alone. This is how TIPS is done. Won't dwell into this. So this patient underwent TIPS on the 7th of September. Okay, let me come to, you may have complications post TIPS. You need to keep in mind when your interventional radiology friend has done it, you need to monitor such patients. Very important. So 7th, she underwent TIPS, and her liver function tests have been showing a gradual improvement with time. The OTPTC have come down from 1900 to 430 and 350. The bilirubin has come down, and on 13th she was discharged, and she is due for her follow-up. So you need to follow their patients. They may present as ALFs, they may present as ACLFs, and intervention is associated with good outcomes in whatever way the patient presents, but you need to see that is the patient in a condition which the patient can undergo a intervention or not. I can't talk to you about all these, but remember, we've got options for vitamin K, DOAX. FibroScan has been shown to, we've shown some our data with it as a predictor of restenosis. Prognostic scores we talked about in ACLF. Similar kind of prognostic scores are there in Budd-Chiari, HCCs occur. Transplantation is an option in those patients who do not respond to tips. And the algorithmic approach would be is when you suspect Budd-Chiari, do a Doppler. Normal flow rules out Budd-Chiari, work up. If you find that what kind of block it is, if it is an IVC block alone, you can just manage with an angioplasty or stenting. If there's a combined block, then you can think about doing angioplasty, stenting. And if there is a long segment block of HVs, consider doing tips in such patients. Short segments can be managed with that, but it's a teamwork. You need to get your radiologist friend, you need to get your, even the gynecologist when it comes to managing such patients, it's very important. Your hematologists all need to be kept in the loop. So this is what I had. We'll be happy to take any questions. Please come to the mic and please. So we've got an excellent panel who's going to respond to you.
So this patient had no prior history of abortions. So if we are in a resource limited setting, then in that case, do we need to keep APLA down the line if we want to evaluate and we are in a resource limited setting for the coagulation workup?
Yeah, you need to work up for APLA, especially in a female patient who's got thrombocytopenia, bad obstetric history, then you keep in mind. But then, even then also, if it's not there, this could be the first presentation. So you need to keep that in mind. You need to work them up because you would need to also decide for anticoagulation. There's an issue. You can't use dabigatran in such patients. You need to use conventional anticoagulants like vitamin K antibiotics.
Thanks.
Sir?
Yeah,
So
please go ahead.
In case of a hyperacute presentation, if the patient comes to us early enough and we do find evidence of a thrombus in either hepatic vein or the IVC, when can we consider thrombolysis in such a patient? And what's the preferred agent to be used?
So we've got our expert, Dr. Sridhar.
In a hyperacute state, you would see a thrombus in a distended hepatic veins or an IVC. Definitely, when we see that, thrombolysis should be the first intervention because, as they said, stepwise is always better if you can do it. Definitely not in this condition.
Dr. Sridhar, please be very short, ma'am. We need to close.
Okay. So the right now, what we are using is TPA because of the safety profile. Otherwise, in a poor conditions like this where patients are not affordable, we are still use streptokinase and urokinase, but preferably we would go for a TPA.
So good. So unfortunately, we can't have more questions. We'll stop out here. And thank you, my esteemed panelists who've had the courage to come over here and sit over here. And so I think this requires a lot of courage. So we've got lots of chocolates. If you've got any questions, we'll be happy to answer after this. I think
we close this session and we can take questions later. Thank you very much. Thank you.
Our next session is Beyond Gastroenterology, where we will have 3 successive lectures. To chair the session, may I please request Dr. Harjeet Singh, sir, Associate Professor, Department of Surgical Gastroenterology, PGI-GI, Chandigarh, Dr. Hari Prasad, Senior Consultant Gastroenterologist, and Dr. Vaneet Jerath, Assistant Professor, Department of Gastroenterology, PGI-GI, Chandigarh. Following this session, we will have quiz.
After this session, we'll have the quiz, and we have a lot of prizes in the quiz. So I request all the delegates to stay back and participate in the quiz actively.
call upon the first speaker for this session. We'll call upon the first speaker of this session. He is Dr. Ashwani Site. He will be speaking on communication to the patient after complicated endoscopy.
Good evening, ladies and gentlemen. Thank you, Dr. Usha, for having invited me to this very stimulating session, not session, the whole conference, because every time I've come here to address you people, I've learned more than possibly I've given you. Before I start, let me ask the house, how many of you have indemnity insurance? Please raise your hands. The number is very, very small. And this is one message that I would like to give you even before starting my talk. Please get yourself insured. That's very, very important. Malpractice insurance is extremely important, and for residents more so, especially in Chandigarh, because one of the judgments has gone extremely against the residents, including intern and a house surgeon. So your post-procedure or post-complication communication shapes up entirely on the basis of your pre-procedure communication. It's extremely important. Let me go straight to the case. A 47-year-old lady was admitted with biliary colic, with cholelithiasis, an MRCP reported CBD sludge. ERCP was done the next day with difficult CBD access. Pancreatic duct was cannulated and a stent placed. Needle knife pre-cut was done. Patient desaturated during the ERCP and was abandoned. She had developed surgical emphysema and large pneumothorax, for which intracostal drainage was placed. Spent over 2 weeks in the ICU with respiratory complications, and the perforation was managed conservatively. She was discharged after a prolonged stay. Bill was much more than what Mediclaim insurance would pay the patient. Readmitted with biliary colic, MRCP done again during this admission showed normal report. Cholecystectomy was done and patient was advised discharge with a plan to remove pancreatic duct stent at a later date. Now, the patient and the relatives created ruckus at this time, because at the time of settling bills, this had overshot insurance, and the patient would have had to pay from his pocket. Questioned why ERCP was done in the first place. And just short of vandalization, heckled the doctors. This is a real case, I'm telling you. Social media videos were made viral by the relatives. Let's see what the likely issues after a botched procedure are there. Because based on that would depend how you conduct yourself before and after procedure. So most dreadful of them is violence, which may be verbal, physical, threats, actual beating, and intimidation. Complaints may be raised at various levels, including the hospital administration, which is least of the trouble, believe me, because the patient can go to State Medical Council and it can escalate to National Medical Council if not satisfied with their decision. Then consumer redressal commissions at various levels, from district to state to national. Patient can press for criminal charges. There may be police complaints, FIR lodged, and eventually, after a long battle, the doctor may even be jailed. I'm not scaring you. I'm just telling you the reality. Human Rights Commission, the case may be filed, and under Clinic Establishment Act and Biomedical Waste Management Rules, other cases can be foisted on you. Mainstream media is involved. Recent, there was PGI was in news because of propofol injection deaths. Just 2 days prior to that, there was a case in Noida where a patient died after propofol injection, and the mainstream media, national channel, ran a headline saying "Bhediye ki khal mein doctor." So you can imagine. Then the trolling on social media starts. You should be beware of every such thing. Why? Because no endoscopist, and I repeat, no endoscopist, whether in a government service, whether in private practice, whether in corporate hospitals, working in NGO or other charitable organizations, is immune. No one. Also, even if the claim doesn't result in the reward of the award of the money, pecuniary award, it still takes away your time and you have to make a lot of effort. So far, there has been no cap on compensation which can be claimed or which can be awarded. So the patient can ask for the moon, and unfortunately, the courts may end up giving him sun. Interest may work out to be more than the compensation itself. And you all know the judiciary and the judicial system in this country, justice delivery system in this country, they may continue for several decades, may continue even after your death. I'm sorry to say that. You can be simultaneously sued in multiple courts, 12 of them at the last count. So why pre-procedure communication is important? I come to the point. Because in a study done in the US, maximum number of cases, malpractice cases, were because of lack of communication, inadequate communication. In an article published in Indian Journal of Gastroenterology a few years ago, I think it was 2017, the commonest cause for negligence being upheld by the courts was shortcomings in consent, which means it was not communicated well to the patient. Secondly, very importantly, with the ease of acceptance of endoscopy and easy availability, patients as well as doctors now see this as a test rather than a procedure, and therefore all of us end up paying a very perfunctory consent for that. As a result, the patient is not mentally prepared for any complications which may arise, even from a simple screening procedure, whether it is upper GI, whether it is colonoscopy. And if not explained properly, an inherent complication may make the situation worse, and it's very difficult to handle. And if you explain it beforehand, it may actually act as a safety valve. Secondly, many a time we find that we cannot complete the procedure. It is not 100% success, even as far as completion is concerned. So at that particular time, because the patient has to pay in many circumstances, it leads to very bad, heated arguments and violence and maximally cyberbullying these days. Whether or not it is a pre or post procedure communication, the components remain the same. You have to involve the patient in decision making, whether before or after complication, by explaining diagnosis, investigation, what happened. Then you have to communicate with the relatives. You have to communicate with other healthcare professionals who you may want to refer the patient to. You have to break the bad news. And now there is added dimension that you may have to communicate with the police, with media, and so many other agencies after the complication has occurred. Documentation, after all, is nothing but written communication. It is communicating to any other agency who goes and sees your case. So communication and documentation before the procedure is most important. I would like every one of you to please take a picture of this slide. Do not claim to be a super specialist. That's against the law, unless you have a recognized qualification or recognized training. Take proper consent. As I mentioned to you before, 60% of the claims are settled because of shortcomings in consent. Follow the Supreme Court guidelines, which are very clear that you have to take consent from the patient only. And if he's an adult, of course, and is of sound mind so as to decide everything for himself. Consent should be real and valid. What does that mean? You have to tell why the procedure is being done, indications, its benefits, its risks, other available alternatives, and any other information that any reasonable person would like to have. Take consent in the language that patient understands, otherwise the interpreter must sign as a witness. Again, very, very important thing is do not do any procedure other than what has been consented for. For example, if you're doing something and unexpectedly you find varices, please don't rush into banding. If you do a colonoscopy, screening colonoscopy, and there's a polyp, do not rush in for doing a polypectomy without taking a consent. Right now, the patient is under either propofol or sedation and therefore not compos mentis. So you cannot ask even on the table whether you should do a polypectomy. Finish this procedure and take a separate consent for next time whenever you want to do the procedure. Consent not signed by the doctor is not having any legal sanctity. Sometimes what happens is that the patient is bleeding during the procedure and you want to do something and the patient refuses to give consent, or even otherwise, patient is in the ward and refuses to give consent. Please have that written. Please document that and have it. Negative consent must also be signed by the patient. Now, many times what happens is that the patient refuses and is belligerent. In that particular case, ask your colleagues to stand a witness and inform your head of institution that this particular patient is not signing the negative consent. I've explained all the risks associated. A word about complications. Counterintuitive as it may seem, but lower GI procedures are attended with maximum number of claims because of complications. ERCP is very low down in the list, and certainly upper GI endoscopy is the least. And the most prevalent reason for medical liability is diagnostic error and missed complications, for example, perforation, and delayed diagnosis of that. Remember one thing, that those claims which had perforation as complication but were explained beforehand always favored the defendants, that's the doctors. On the other hand, if you fail to appropriately recognize the perforation and therefore fail to manage it properly, the cases of the plaintiff prevail. Document the communication, because good records are good defense in the court of law. Poor records, poor defense. There is no records, no defense at all. Unsigned medical records, as I mentioned earlier, have no legal validity. Very important thing again is in the records, please do not use non-standard, vague and confusing abbreviations. Bombay High Court has upheld this as negligence, as one sentence written as complaints of SCOOR, S-C-O-O-R. The doctor had written that. And after a lot of search, because this case ran for several years, the doctor was called to the court and asked, what is this SCOOR? He said it means something coming out of rectum. So you can imagine the price that he had to pay. Contemporaneous descriptive documentation of procedure, which means as you do, you write, although that is not possible. But courts expect that. So soon after you do the procedure, please write immediately what you have done, especially write rational, reasonable explanations for actions taken in case of a complication. I cannot overemphasize the use of photographs. Please do not cook up, do not change, write addendum instead. And these days when everything is computerized, you cannot even cook up, you cannot overwrite, you have to write addendum. Medical records which are written after discharge or hours after death do not stand the scrutiny of court. Again, extremely important, and that is why I have highlighted this, doctor's notes and nurse's notes must tally, which means that if you have written the patient in shock, but perfunctorily the staff nurse on the round has usually written all vitals normal, and you are in a soup. Post-complication communication, actually this topic on the ground of which I have now made this building is that whenever adverse events take place, Do not stonewall questions. Silence would lead to mistrust. Increasing transparency after an adverse event is one approach that can actually decrease the potential subsequent litigation. Physicians should work very closely with risk managers. Now, what is this animal? Risk manager can be anybody who can mitigate your risk as far as any other thing is concerned, like violence, like court cases, etc. And it can be as much as a person as, say, even your head of the department at that particular time, or risk managers who are trained, or medical superintendent of the institution. After a botched procedures, inform the insurance company immediately. You may not go to the court, etc. The case may not go, but you must inform your insurance company immediately. Very obviously or very expectedly, I'll take 2 minutes more, can I? Expectedly, the patient who's had complication is up in arms against you, so be prepared for his reaction and read the body language. Manner of communicating is very important, especially if bad news. So give him time to assimilate, give him time to cry. You be silent, hold, and just explain very clearly. Be very soft, at the same time be firm with the facts. Listen effectively to the patient and use a very clear language. Do not lie, because you do not have to remember the truth later on in the court. Disclosure of errors and apologizing at that time sometimes may act as a double-edged sword, and you'll have to weigh this, because in India, at least, if you apologize, they say that you are liable for it, come what may. Empathize, and that's extremely important. Do not overreact. Avoid direct confrontation. Be polite but firm, as I told you, because a sympathetic touch can avert a lawsuit. Communicating with attendants is extremely important, and as important possibly as with the patient himself. Never be informal with them. Conduct conferences, and if possible, twice daily in ICU settings. Attendants these days surf net, so counter them with more better references. Explain to them that no endoscopic procedure, even for that matter, no consultation is without a risk, because patient, it doesn't cross his mind. Patient has come taking a car, he might have met with an accident. But similarly, tell them that no procedure is risk-free. There is disease which is dynamic in nature. Everything, it changes every second. Again, I urge upon you to not ego come in between. Second opinion should be sought proactively. Important not only when one is doubt, but it helps build the attendant's confidence. Get the family to sign the briefings. Document the communication and communicate the documentation of communication. Tell him, जो आपसे मेरी बात हुई है, जहां मैंने साइन कराए हैं, वो मैं आपको बता रहा हूं. मैंने लिख दिया है records में. Because that happens as real deterrent. Because later on, patients normally what happens is they these days record this thing surreptitiously and present it in the court of law as evidence. This is nothing but an acronym of whatever I have told you. Its cones means set the context, opening shot, narrative, emotions, and summarize, and tell them that let them know that the situation is a priority. Again, communicating with colleagues is very important, because you got to refer the patient. Never talk low about your colleagues or try to shift accountability of the complication to someone else. Never scold residents, fellows, or other students or other subordinates in front of patients or attendants when the complication occurs, because you lose your cool. Greatest courtesy has to be shown to the staff nurses. Lead by setting examples, because supporting staff will then actually support you. Try to teach them the basics and the principles of management of commonly encountered complications. This will keep them motivated to work. All involved in the team should be taken in confidence, and they should be truthfully explained what happened, so that everybody is not talking in different language and they are on the same page. Make a common descriptive note in the case sheet, which may be shared with referring physician, referred expert, and possibly even investigative agency, etc., if later on the need comes. Communication doesn't stop at this, because you've got to communicate with mainstream media as well as the press and the police. So you should mark a person who should communicate. Give the information to media and use the same sheet as I told you, wherein everything has been written. Communicating with police may be a little tricky, because best is to cooperate, but ask for documents pertaining to the complaint and FIR lodged. You may refuse to go to the police station, especially the ladies, and request them gently to come to your clinic or to the hospital to take your statement. Consult your lawyer and medical legal expert before giving a written reply. That's a very, very important message that I would like to put across. Social media, trolling, cyberbullying, cyber stalking, for the want of time, I'm just saying ignore. And that's all. Unless, because they want a reaction and they want their own likes, they want it to go into, snowball into various, this thing, but it boomerangs. So therefore, just ignore is the best policy. Takeaways are, outcome of the post-complication communication depends largely on pre-procedure communication. So please do that very well. Take a real and valid consent. I've explained it details. After the complication, be prepared for the reaction and allow this to sink into the patient. Listen effectively, and by using clear language, establish a dialogue. Empathize. A common descriptive note goes a long way in protecting you. Structured communication with mainstream media and social media, best to ignore. So ladies and gentlemen, thank you very much for giving me your valuable time and attention. And thank you, Usha, for inviting me for this.
Thank you, sir. This excellent talk and highlighting this important issue. So we will have discussion at the end of the session.
No, if there are any questions,
okay.
I'm
So
happy
if
to
there are any
answer.
questions,
I can give you my emails also in case there are any questions. You're more than welcome to please write to me.
Yes, any question, Dr. Jimil, Anupam, anything? Because every day in and day out with all the endoscopies, any queries you have? And can you tell us if you have to have a professional indemnity insurance, how much should be the amount? And is it different for interventional people versus non-interventional people?
No, so interventional, all endoscopists, all those people who are doing endoscopy should take a policy which is for surgeons. Okay. And not physicians. And my advice to youngsters would be to take a policy at least for 50 lakhs and for all the consultants, at least for 1 crore. The premium is not as much as you expect it to be. Don't fear that.
So may I ask?
Sure. Yes.
So, sir, you have written in consent that consent without doctor sign is not valid. So the doctor sign has to be the same doctor who has done the procedure?
No.
Or any doctor who is taking care of the member of the team?
Member of the team. Very good question. If you have explained the procedure to the patient, and any team member can take this consent, but it should be a doctor, not a nurse.
Sir, I have a question.
Sir, yes, please.
Sir, many of times what happens here in PGI that many of our patients only understand the language in which we are not comfortable. For let us take many of our patients just understand Punjabi, in which we are not so much comfortable. So in such case, how to communicate with them effectively? I mean, there is a language barrier.
So you have to have, unfortunately, at that particular time, find an interpreter for you who can understand Punjabi and your language, possibly English, etc. The consent should be necessarily in the language where you're situated, along with, if possible, English or Hindi, whatever. But at least I would presume that in Chandigarh, it should be in Punjabi, written in Gurmukhi.
So, sir, in such cases, is it, I mean, would it be legally acceptable if we use something and we can use something like Google Translator and we convert it and get it printed and then sign?
As long as both you and the patient are on the same page after Google translation, I'm fine with that.
Thank you, sir.
Sir,
sir,
in case of any discrepancy between a doctor's finding and a nurse's finding. So if you think that nurse's finding are not appropriate, they might have written in a might have written a wrong vitals or anything. At that time, who is responsible? Because nurse is within your team, so you are accountable for nurse's mistake or any error, or nurse are responsible at their own.
So this is a very big topic of what is called as primary liability and vicarious liability. The nurse is an employee of the hospital. So the hospital has the primary liability, vicarious liability for employing that nurse. But the primary liability stands that of nurse. If she's found to be deficient, she'll be hauled up.
So,
Yes.
so yes, good evening, sir. So like there are so many insurance companies, so many policies, like what do you suggest, sir? Which one should be? Any suggestions?
I can't confess for any one of them, but wherever you can get a good deal, but good deal doesn't mean they fool you left, right, and center. They are actually sometimes they stab in their back. So my suggestion to you would be that you write to Medico's Legal Action Group, situated in Chandigarh itself, right? It is www.mlag.in, and they would facilitate your insurance. They have kind of negotiated great terms for this. I also take this opportunity to invite you all to the annual conference, 9th annual conference of Medico's Legal Action Group, being held in Chandigarh on 12th of February 2023.
Sir, thank you for this excellent talk. Sir, I want to highlight one very important point. Being a surgeon, we face this problem. Like if the complication is done by endoscopies and the patient has been shifted to the surgery side. So I think the person, the gastroenterologist should not be in this view that his responsibility has gone. I think the same is true for the surgeon. If someone is here, if you have done some complication, iatrogenic injuries like bile duct injury, and patient has gone to some other center or to the endoscopies for ERCP, that doesn't mean the surgeon is spared. Because what happens, the person who has done the iatrogenic problem, ultimately patient will sue him. So I think it's the point which you have highlighted, very important, is communication. Communication not only to the patient, but the person to whom you are referring also. Yeah, that's very important thing. And you should always be in constant touch with that patient.
Please do not let egos come in between. You are working as a team, because if you say, this is not my job, this is his job, you are also in soup because you are in the same case.
Because the patient, he showed the iatrogenic injuries, and patient was managing the surgery without for around 2 weeks or something. So there's a possibility that the more injury is done by the second person. So, but the patient will ultimately sue the first person because the first iatrogenic injury was done by the endoscopist. So I think
there are many legal complications. I think what if Dr. Usha permits, I can run a course on this, full 1-day course I'll come from Delhi. There's no problem at all.
Sir, may I ask one question? Sir, do we have any web page or any forum where we can have updated version that which cases are there and what is the conversion rate where doctors are being held accountable or they are found to be negligent? Do we have any record or data of something like that, or state-wise registry or anything?
The data is available on very many legal sites also, and it is available not entirely, but to an extent on this site which I told you, mlag.in.
Thank you.
Sir, yes, sir.
He has a flight to catch. 6:55 is his flight, so he has 45 minutes of travel time. So I think we'll have to come to a close of his talk. Thank you so much, Dr. Ashwini, for being here.
Thank you. Thank you very much.
So then,
Carry on with the next.
so the next speaker is Dr. A.C. Anand, who will speak on another important topic, work-life balance.
Can you open my presentation?
So for all of your knowledge, Professor A.C. Anand was Lieutenant General in the Army. He rose to the highest rank which any medical officer has risen to. And we are really privileged to have him here. And he's presently the head of the Department of Gastroenterology at KIMS in Bhubaneswar. So he has to teach us how to balance life at home as well as at work, because that's something which all of us need to learn.
Thank you very much for that introduction. Last year, a survey was carried out which showed that 1 in 2 physicians undergo burnout by the time they reach middle age. Maximum emergency medicine physicians, but gastroenterologists are not very far behind. And therefore, I would like to congratulate Professor Usha Datta for selecting this topic. But I may not have agreed with her choice of speaker, because in Army, we really don't respect work-life balance. There are times when you have to days together on the work and forget about any balance in life. First 4 minutes, I'll talk about what is the conventional view about work-life balance. And then I'll introduce you to 3 philosophies of life, which are very well known, prevalent all over the world. And I'll take 3 minutes with each of them. The conventional view of work-life balance is that you should balance your career and ambition on one side and health, pleasure, leisure, and family on the other side. It is commonly believed that work-life balance means that you spend 50% of your time at work and 50% of time at home. Your work life should not spill over into your home life. Can I be heard? All right. Getting to do everything you want to do in a day is also considered a part of work-life balance. Getting a break frequently from one's hectic work environment is also considered a work-life balance. And some people say that women desire more work-life balance than men, but all these statements are false. For definition, the work-life balance means balanced priorities between workplace obligations and personal responsibilities. This term has been coined to address the unhealthy life choices made by many when they choose to neglect important areas of their life, such as health, family, friends, and hobbies in favor of work-related tasks and goals. We all have finite amount of mental, physical, and emotional resources. And how you allocate your resources corresponding to your personal and professional goals is all that work-life balance means. There will be many demands on you, but no matter what the number of hours you will have will only be 24. Therefore, you must choose wisely how you use these 24 hours. When I was a resident, this book was released by Stephen Covey, and it talked about 7 habits of highly effective people. And these are the 7 habits that he listed. In fact, this seems to be a good roadmap for following a work-life practice. And these 7 habits were divided into 3 parts. First was the personal victory. That is, you should be proactive rather than reactive. Keep your goals in sight. And first things first, I have put that in bold because I'm going to talk a little more about it. Then victory over others. Think win-win. In every relationship, both parties should benefit equally. Communicate effectively and synergize your actions. And the last point was look after your own health. Let's talk about first things first. Stephen Covey said that all your activities can be divided into 4 quadrants. These can be divided as urgent and non-urgent on one side and important and non-important on the other side. The urgent and important ones usually take the most time, but he says that may not be the correct thing to do. The really productive and creative work is done in the second quadrant, that is, which is important and not urgent. And therefore, he says, if you divide your time like this into all four quadrants, it may not work out very well for you. You should try to divide your time like this, spending most of your time with the important but not urgent things, while pushing the urgent things and which are important to a very small area. And that is where you should not spend most time, because they are generally, they take up a lot of time and they don't give you enough productivity. So basically you have to make a to-do list every morning in which you need to prioritize very ruthlessly. You should focus on productive and creative work, downsize crisis management. An average person looks at WhatsApp or Insta or Tinder 65 times in a work day. I think that is what I want you to avoid. Silence the unknown numbers, because you attend a lot of calls which are unsolicited, and there is a facility in your phone to silence all the unknown numbers. Then you should learn to say no, and say no very firmly to workplace gossip and unnecessary arguments that take place in the workplace. Some people say that work-life balance means that you should follow a middle path. Give adequate time to your boss as well as to your wife. But your definition of adequate may not satisfy either. You must keep that in mind. 25 years after writing this book, Stephen Covey came up with another book, and this book's name was The Eighth Habit. He said, to-do lists are things of past. You should only focus on your compass. That is, whatever you are doing in the right direction. And this is something which you have been learning right from your childhood, from Indian mythology, where it was shown that your focus should be on what you want to achieve in life and not on what things are there around, the distractions. So I would suggest we can view the life from a different angle right from here. I'm closing the chapter on the conventional view of work-life balance, and we are going now to the unconventional area. And I want you to have a different look at life. If you look at life from a zoom or a macro lens, you may find it very dirty and unpleasant. But if the same thing you look at from a tele lens, you'll find it's very pleasant and beautiful. And therefore, let's see whether we can look at life from a different angle. Life is a sexually transmitted disease. It has very poor prognosis, 100% mortality. We all come to life like this. It's painful. We are unhappy. You immediately need to learn a new skill to survive, and you did not want to come here. You are very happy inside the womb. And this is how we are going to end, which is also going to be painful. We'll be unhappy going because we don't want to go from here. And how do we spend the time in between? We spend the time in between by keeping up with Joneses, listening to someone else's commentary about us, and worrying about कि लोग क्या कहें. Therefore, you feel you are not in control. So what can we do so that you feel that you know everything about life? I'll take you through these three philosophies. First one is a French philosophy about the absurd hero, that is the smiling Sisyphus. Second has originated from India, and it's about journey inwards. And third is a Japanese philosophy of Karoshi and Ikigai. A small disclaimer, these are complex philosophies. I have simplified for you, and I have compressed them to 3 minutes each. So if you have any doubts, I'll give you in my summary slide what to do. Albert Camus was a French civilian who earned a Nobel Prize in 1957 for his philosophy, and this philosophy was The Myth of Sisyphus. That is a book which is available for 89 rupees today. The book is about a mythological story of two people. One is Zeus, the powerful god, something like Raja Indra in Indian mythology. And second is Sisyphus, who was a clever king. And the event took place in Corinth, which is the place which Sisyphus was ruling. The two events are important in this story. It's a long story, but I'll cut it short. Zeus abducts the daughter of river god, and the Sisyphus witnesses it. There is a famine in Corinth city, and Sisyphus uses that first information to get a spring of water for his city. And Zeus is very angry with him, so he curses him for eternity. The punishment of Sisyphus is that he is to endure an eternity of hopeless struggle. He has to carry a large boulder of stone up the hill. And when he reaches the top of the hill, he has to come back and carry another boulder to the top of the hill. Now, Sisyphus displays scorn for the gods, a hatred of death, and a passion for life, just as we all do. Even in a Hindi song, you have been given this philosophy, Jeevan chalne ka naam, chalte raho subah sham. Now, what does Professor Usha Datta thinks every day morning? Every class I teach is like a new rock. I have to take them up the hill to their DM exam, make them fit for it, and then I have to begin with another new class right from the bottom. And the students that pass out from my DM examination do exactly what they wish, and they will not even listen to what I have said. Albert Camus said, the struggle itself towards the height is enough to fill a man's heart, and one must imagine the Sisyphus as happy person. The philosophy is that life is a wiggle. It's not a problem, it's a wiggle. The fundamental conflict is that we want a meaning in life, but what we are going to find is a formless chaos. He says the opposite of depression is not happiness, but it is action. And it is your choice in doing whatever you do, either do it smilingly or cryingly. And we must always imagine that Sisyphus is smiling. We move from Europe to India. Another philosophy. Now, lots of people are traveling from Western countries to India to learn this philosophy. Indian philosophy or Vedanta says that the period between birth and death is a string of experiences. Every moment in our life is an experience. Then they go to define what the experience is. Experience is an interaction between the objects and the experiencer, which is the subject. Let us say you are the experiencer. But then you are not the body because you can experience your body. You are not the mind because you can experience your thoughts also. You are pure Chaitanya, or the real experiencer is the one who has been given this body, mind, and intellect with the instruments as instruments to function, and these are directed outwards. It is the consciousness that illuminates every thought that comes in your mind. For short time, I would like you to forget that it is reticular formation which is sending impulses to cortex, and that is how you are conscious. Because that is what the science has been telling you, it is all bunkum. Consciousness is the one which illuminates every thought you have. Otherwise, in your brain, you only have scattered electrical impulses all over the cortex. What it forms into an object or a thought is the consciousness. Chaitanya is the only reality, and it is blissful, and that is why it is also known as Sat Chit Anand. And when your mind is quiet, you can experience that blissfulness. But when you have desires, it makes the water and you very muddy, and you can't see anything. Let us take a day-to-day life. Every day night you sleep and you have dreams. In the dream, you are the first person. As a first person, you are also there. And you interact with other people who are also creation of your mind. And other people have independent opinion. They even fight with you. They don't always agree with you. And everything appears at that time real, because if there is a lion or a tiger jumping at you, you will start sweating because it seems real to you. So basically dreams are a virtual reality created by your mind. And when you wake up, the reality is entirely different. Everything in the dream dissolves, and you even forget that you saw a particular dream. Now move little more further. I would say that this real world is also a virtual reality created by Chaitanya. This is what Vedanta says. And this Chaitanya is also called as the Brahm. You may say that scientifically it looks a useless idea. I don't agree with it. So let us see what physics says about it. Richard Dawkins is one of the workers who has said that God doesn't exist. But when it comes to physics, the modern physics has found that reality is made of atoms, of protons and neutrons finally. And even below that, bosons and gravitons, there are 17 basic particles which are there. And the string theory of quantum field shows that subatomic particles appear and disappear as vibrations in the quantum field. Actually, there is nothing there. Russell Peter, a famous physicist, says that Advaita Vedanta seems to be true and is plausible from the physics point of view. Chaitanya is the quantum field. And you will get to know that Brahm is Satyam and Jagat is Mithya. Therefore, do your duty, don't be attached to it. Nothing will be there when you wake up at the end of your life. Let's move. For those who are grounded to reality, let's move from India to Japan. Karoshi means overworked death. This is in Japanese. Major medical college of Karoshi are actually heart attacks, strokes due to stress and starvation. And the phenomena is also widespread in Asia. Karoshi results when Sisyphus doesn't smile. The opposite concept of Karoshi is Ikigai. If you don't feel motivated and energized every day, when you get out of bed, it is time for you to start for looking for your Ikigai. Ikigai means the reason for living. And how do I find my Ikigai? If that is the question you have in your mind, you just ask 4 questions from yourself and look for answers within you. The first question is, what is it that you love to do? What would you do if money was no object, if nobody else was there to tell me what to do? Second question is, do what you are good at. What skills have you picked up over your lifetime? Third question is, do something for the world. What could you do to make things better for other people around you? And the last question is, do something that can sustain you. What service can I offer so that the others may be willing to pay for it? Now combine these 4 questions into a single diagram. When you work between what you love and what you are good at, that is your passion. What you are good at and what pays is your profession. What your pays and what world needs is your vocation. And what you love and what the world needs should be your mission. If you work in the triangular space in between passion and profession, you will be satisfied, but you will keep feeling worthless. If you work in the space between profession and vocation, you'll be comfortable, but you'll have emptiness inside you. When you work between mission and vocation, there'll be excitement and complacency, but there'll be a sense of uncertainty. When you work between your passion and mission, you'll be delighted, full, and there will be fullness, but there'll be no wealth with you, there'll be no money. And therefore, it is important that you move into the central square that is called your Ikigai. Choose a place to work, choose a job which will give you all these 4 issues. So I'll summarize for you. Find your Ikigai, that is your own problem. You have to do it yourself. My time is up, so I'd like to summarize by saying that accept that there is no perfect work-life balance. Decide what you want in life, and that is what will decide what you will do. The time you enjoy wasting is not actually a wasted time. This is what Dr. Tyagi used to tell me. And the message that I want to give you is, every now and then, pause, prioritize, and reset your goals. Priorities change with the change in situation. What is it today? Whether it is doing your DM, whether it is looking after your health, earning money, looking after the loved ones, or serving others without any gains, you have to decide. Consider alternatives and implement change. If you are still lost after this, remember a very famous saying, traveler, there is no path, path is made by walking.
Thank you, sir, for this excellent talk. We can have a discussion after the next talk.
Okay.
So we can take questions. Okay. Okay. We can have a questions from the floor.
Burnout is a little far away for them. Okay, thank you very much.
Thank you, sir. So I welcome the next speaker. He will be speaking online. He's a Dr. S.K. Tyagi. He will be speaking on life beyond gastroenterology. Over to Dr. S.K. Tyagi.
Can you all hear me? Just say yes. Somebody say yes, then I'll know.
Yes, you are audible.
All right. Now, I wrote something while Dr. Anand was speaking, so I'll start with that. The pleasures of being the speaker last. You can be terribly slow or super fast. For much as you might prepare, there'll be few present to care. But if to AC Anand you have to follow, good or bad, you will sound hollow. So thank you, Usha, for putting me last. And thank you for putting me after AC Anand. Because after all the Ikigai and all the change that you'll try to bring into yourself, I will start by telling you my story. Now, I kept on asking myself, why was I asked to deliver this talk on life beyond gastroenterology? Then, Dr. Kocher, your former head of department, told me, he brought me back to earth and told me, because Tyagi, you've done a lot of things beyond gastroenterology and very little within gastroenterology. And that actually got me thinking. It got me thinking, why did I land up where I am? And I realized I landed up here because I had no motive. It was not for any moralistic reasons. You see, in class 12, I had to make a terrible choice as to what I want to become. It was either in those days, you become a lawyer, or you became an engineer, or you became a doctor. Well, as far as lawyer was concerned, there were none in my family. My elder brother was an engineer, and for the life of me, I couldn't actually get my table of 7 correct till I was 7. And therefore, there was very little I could do with mathematics. Forget Pythagoras, which I never understood even to date. So there was little I could do but to do biology. I took up biology, and once I had finished my pre-medical, I had a choice whether I wanted to actually continue dissecting earthworms and making other biologists, or do something a little more. And therefore, because I couldn't think about just cutting earthworms all my life, I appeared for the AFMC examination, which was round the corner. As luck would have it, I passed it. Then, when I had finished my MBBS, it was again a choice I had to make as to whether I want to become a surgeon or a physician. Now, I told you by class, when I was 7, I couldn't count, I couldn't do the table of 7, but when I was 7, I couldn't really tie my shoelaces. So I knew I can cut, but I didn't know how to stitch. And that was a terrible thing for a surgeon to be. So I opted for medicine. As again, luck would have it, and by chance, I passed, I got into medicine, and I became a physician. Then why did I become a gastroenterologist of all things? There was more money in those days in cardiology than in gastroenterology. But I had a professor who came to work in a Porsche, in a sports Porsche. And I said, wow, that's what I want to be. I want to have a Porsche, forget gastroenterology. And that's how, gentlemen, I landed up here. I started without a mission, expediency rather than choice. Not chosen, but chanced to. My vocation was being on stage. My passion was to communicate. And that's why I think I'm here. Well, as far as Dr. Kocha's assessment is concerned, let me get back to the previous lecture about Ikigai and about change. Well, to begin with, Ikigai, with all those circles, with all those triangles, and with Ikigai in the center, is far too organized for a chaotic person like me, because I wanted to be everywhere, in all those circles, in all those triangles, everywhere. I would work on a day-to-day basis. My profession was not really my calling, but it was essential, like it is essential for each one of you, to be a part of a profession, to make a living. But I did a lot of things which I enjoyed, and I did it because I had to do it. I read that there was somewhere an audition going on for some acting a job in one of the Bollywood films. I appeared for it. I got selected and I went and spent 10 days shooting for a movie. I came back and I was approached whether I could actually go and interview PV Sindhu. And I did that for an hour. I never did anything before that, but why not? I like the Nike saying, just do it. So I went and just do it. Just as I, in 2018, went and did zip lining in Costa Rica over their rainforest, about 900 meters above the ground. I don't know how to swim, but I did kayaking in Halong Bay in 2017. I trekked within the Amazon rainforests in Peru in 2015. And then in winters with a temperature of -25, I did snowmobile in the Arctic Circle for about 5 kilometers and my eyelids were frozen. I went photographing the snow monkeys in Japan, who live the only mammals that live above 12,000 feet. And then just a few days back, I went to the Everest camp and enjoyed myself. Well, so you see, there is life beyond gastroenterology. And even for that, even in that chaotic life, and not that organized day, 8-hour life that we spend in gastroenterology, you would be recognized. I'm here in my own institution, my alma mater, giving a talk. That is recognition. And that has come not entirely from my work in gastroenterology, but my work beyond gastroenterology. What our problem really is, that basically not having a life is what we look up to. We glorify noxious work culture, and our jobs can easily become our entire entities. So that is what we all have to avoid. There are 3 A's in quest of excellence, and we all want to be excellent doctors. That is able, affable, and available. Being able is the easiest part to perfect. Believe me, no great shakes. By the time you pass out from your institution, you are able. Being affable, that's being good nature, is an effort. And then with a little bit of effort, you become affable. But being available is what our pride is. We take pride in the fact that we are available. And that, gentlemen, is precisely our problem. We want to be available within our profession for our patients all the time. And that's what Dr. Anand has also told you, that that's not entirely necessary. You need a work-life balance. Life beyond medicine is not a cliche. Believe me, it's not a cliche. The most famous person I know who, despite being a doctor, attained something great is Roger Bannister. We all remember Roger Bannister. He broke the 4-minute barrier while he was a medical student. We also know that the very first person who captained the Indian football team and who actually captained Mohan Bagan and was the flag bearer for the Indian Olympic contingent in 1948 was a doctor. He was Talimeren Ao. We also, those of us who've been hearing commentary, cricket commentary, know that Dr. Narottam Puri was an ENT surgeon, and he did what is beyond ENT and became a commentator. And there's somebody who said that when there were no replays, if Narottam Puri had said that there was a bit of a snick that I heard, well, then there was a snick that was heard. There is life beyond medicine is not a cliche, I repeat. Look at Sri Ram Lagu, an ENT surgeon, Mohan Agase, a film actor, both of them film actors, who was a psychiatrist, and Palash Sen, again ENT, who did something beyond medicine. There were been doctors in politics. The most famous of them, probably YSR, who became a chief minister. And before that, when he became an MLA, he was a doctor. Samvit Patra, whom we see every day on television, is a doctor. And therefore, many of us have actually gone beyond doing what our profession wants us to do. And that truly is going beyond your profession. Well, I can remember two people very clearly who became from PGI. One is my own batchmate, the late Dr. H.S. Risam. He did his MD with me, and then did his cardiology. He wrote a book, The Scalpel, did pretty well in the market, but he followed his passion. He wrote a book. And how many of us would do that? I know A.C. Anand might ultimately do that. He's such a beautiful writer. Recently, there's a book, When the Heart Speaks, by a cardiologist, an ex-PGI faculty, though he's not the alumni of PGI, Upendra Kaul. So beyond this also, there is life. One of the gastroenterologists, very famous in IBD, has actually gone and done special services in the UK Army, David Travis. So you see, there is life beyond gastroenterology and beyond your profession. It is just that we don't want to look at that part of life. We get so involved in everything, in our own being, that we refuse to look beyond it. A profession is not a personality. When everyone looks at you through your professional identity, you start losing perspective as a human being. And therefore, even you should not look at yourself as just a doctor. You look at yourself as a human being, as a person, as somebody with diverse thoughts and diverse intelligence and diverse capabilities and diverse hobbies, which you have to develop from the very beginning to the end. No one falls in love by choice. It is by chance. And no one stays in love by chance. It is by work. And no one falls out of love by chance. It's by choice. So basically, we all make choices. It's the kind of choice that we make is what determines our personalities. No one on his deathbed ever said, I wish I had spent more time in the wards. No, sir, nobody. What you enjoy working really is what you do. You might make a name by being in the wards, by all those that you publish, by all the time you spend doing your rounds, seeing your patients. You might make a lot of money doing it. But the smile, the joy, the bragging rights that come when you do a zip line, when you do a free fall from 30,000 feet, from an airplane down onto the earth is what gives you the true pleasure. So, gentlemen, there's more to life than just gastroenterology. Don't get so busy making a living that you forget to make a life. Thank you very much. I think that's about the time I was allotted to, and I think that's what I have completed it in.
Thank you, sir, for a very enlightening talk. So we can take some questions.
Well, you can hardly have questions on things. The people who are here in this hall are the ones who are actually waiting to listen to Life Beyond Gastroenterology. They want Life Beyond Gastroenterology. The questions were to be asked by those who actually stayed listening to all the gastroenterology and then left the hall. So all those who had to actually ask the questions have already left. And for those who are present here, I think thank you very much for listening to my ad lib. And if you enjoyed it, thank you very much. And if you didn't, well, this is yet another achievement or another day doing things beyond gastroenterology for me. Thank you very much. Goodbye.
Thank you, sir.
So with this, we can conclude this session. There's one more session. So I hand over mic to for the next session to the organizers.
So with these three beautiful thought-provoking lectures, we have come up to the last session. I sincerely believe all of you have enjoyed all the lectures for last 2 days, and you will return with good amount of knowledge and wisdom. So in the last session, the most eagerly awaited session, the quiz. For this, I will invite Dr. Ravinder Goyal sir, consultant gastroenterologist and hepatologist, Chandigarh, to chair the session. The quiz masters will be introduced by the chairperson.
Good evening, ladies and gentlemen. This is the last and probably the very exciting session. We have two quiz masters in this session. One is Dr. Pankaj Gupta. He is Associate Professor, Department of GE Radiology at PGI. And another one is Dr. Anurag Jaina. He is a Senior Research Associate in Department of Gastroenterology, PGI Chandigarh.
Okay, this is the last session. Basically, the quiz is consisted of 20 questions. Each question total, you will be given 1 minute. The voting time will be approx 30 seconds. You have to take out all of your mobile phones in your pockets. Just log into slido.com, or you can just scan this code. You can go to the web, just log in slido.com. Did everyone enter the code 9911? Is there anyone still struggling to get in? Mr. Tarun, everyone has logged in?
Around 46 people have logged in. We need to wait at least 1 minute. Thank you.
We'll wait 1 more minute. You will get a voting time of only 30 seconds. Your questions and your options all will come up on that.
Has anyone not managed until now? If you haven't, just put up your hand so that we know. Okay.
Ma'am, we have almost 67 logins right now.
67.
Yes.
Okay.
So shall we start?
Yes.
Professor
please.
Kartar Singh is also logging in.
Yes, we can start.
Okay, here comes the first question. A 30-year-old man suffered from repeated episodes of ileus and melena, for which he received multiple transfusions. He had past history of intestinal obstruction and required surgical intervention at least thrice. No history of NSAIDs. ESR and CRP were normal. Endoscopy bidirectional was normal. CT enterography revealed multiple persisting stenosis of the small intestine. The capsule endoscopy image is shown here. I think it's being flashed on the option itself. What is the most probable diagnosis? NSID enteropathy, IPSID, cryptogenic multifocal ulcerous stenosing enteritis, or autoimmune enteropathy. The voting time starts.
Next, please.
Next question, 48-year-old male underwent a screening colonoscopy and a single 10 mm polyp was identified. What is the ideal surveillance colonoscopy time post removal of this lesion? When will you do the next colonoscopy after removal of this lesion? The lesion measures 10 mm in size. The options are 1 year, 3 years, 5 years, or surveillance is not required.
Next.
Case 3, 87-year-old man, female, a known hypertension and severe aortic stenosis, present to emergency with melena and lightheadedness. Endoscopy revealed a 5 centimeter hiatal hernia with a lesion in cardia at zone. What is the diagnosis? A Dilophois, a malorivis, a Cameron ulcer, or angiectasia?
Next, please.
A 59-year-old woman, history of coronary artery disease, presented with sudden onset abdominal pain along with bloody diarrhea since 12 hours. This is the sigmoidoscopic image. What is false for the diagnosis? Mesenteric angiography is not indicated in mild cases. Single strip sign is seen in severe cases. Drugs like pseudoephedrine can cause similar adverse event. Right-sided colonic involvement tends to have more severe prognosis. You have to mark which is false for the diagnosis shown in the sigmoidoscopic image.
Next, please.
A 17-year-old girl presented with history of acute pancreatitis. She had LFT of AST, ALT 50 and 48. ALP was 196, borderline elevated. No evidence of gallstone disease, alcohol, trauma, drugs, hypercalcemia or hypertriglyceridemia. MRCP was suspected to have a distal CVD stricture. ERCP was planned for brushings, and cholangiogram revealed the following. Now, what is false regarding the diagnosis of this patient? Usually have hyperactive sphincter mechanism. They are associated with colorectal cysts. They are associated with gallbladder cancer. A type 3 Comey classification is a double papilla type. The clue in this question is probably the Comey classification.
Next, please.
A 56-year-old man post-renal transplant 5 months back was admitted with dysphagia and retrocerebral chest pain for 2 weeks. Upper GI endoscopy was done, which showed esophageal appearance like this. What is the diagnosis? There is a smaller clue in the histopath image also, whether it is pseudomelanosis, CMD esophagitis, mucormycosis, pemphigus.
Next.
16-year-old female presented to emergency with grade 2 dysphagia. There was history of suicidal acid ingestion 8 hours ago. What is the Jargard staging?
Next, please.
A 24-year-old with dysphagia since 1 year to both solids and liquids. This is the manometric pattern shown during his swallowing. What is the diagnosis? The DCI mentioned is here 764. What is the diagnosis? Whether it is achalasia type 2, whether it is GERD, whether it is EGJ outflow obstruction, or whether it is diffuse esophageal spasm.
Next, please.
A 58-year-old man with 20-year history of schizophrenia presented with acute onset diffuse abdominal pain. What are the signs? There are more number of signs in the X-ray. You have to identify which of the signs is not on the X-ray. To give a clue, there are black arrow. There is a arrowhead. There is an asterisk. There is one sign which is absent in this X-ray.
Next, please.
A 37-year-old woman post-cholecystectomy status came to emergency with cholangitis. Ultrasound abdomen demonstrated dilated CBD with a stone. ERCP was planned. The post-sphincterotomy cholangiogram is shown. I think this image was shown in one of the lectures also. What is the most concerning finding here? Biliary stricture, pancreatic divisum, perforation, or anomalous pancreatic biliary junction?
Next, please.
A patient has come with lower GI bleed to emergency. Colonoscopy revealed a sickle dilophosis lesion. You have a resolution clip of 155 centimeter long. Now, should we go ahead with that or not? That will depend upon what is the working length of the working channel of adult colonoscope. 150, 168 centimeter, 178 centimeter, 180 centimeter. Whether you will use this clip or not.
Next, please.
A 44-year-old female presented with pain abdomen. There was a lesion on the fundus of the stomach. Identify the lesion seen in proximal stomach. US image is also seen. Whether it is an pancreatic rest, cyst, duplication cyst, or a lipoma.
Next, please.
This is a novel device. It is a telemetric capsule with optical sensor for immediate detection of acute bleeding. The OTSC group are about to launch this product in the market. What is this product? It's a PillCam SB3. It's a Gilopil P3. It's a Hemopil or it's an Endopil.
Next, please.
A patient of ulcerative colitis came to emergency with stool frequency of 5 per day with all blood. These are the findings of this entire colon. What is the modified Mayo endoscopic score? The clue here is actually you can calculate individual subscores of all the segments, then apply the formula.
Next, please.
So these are a few imaging-based questions. So it's a 50-year-old female with abdominal pain and abdominal distension for past 2 weeks. So I'll just have you look over here, identify the pattern of the dilated bowel, and then you should be able to answer it very easily. And for your ease, I have also given CT, so it's basically a spotter only, but just identify the pattern of bowel on X-ray. I think that is more useful. So what is the diagnosis? Small bowel obstruction, large bowel obstruction, paralytic ileus, or pseudo obstruction? I think I can keep my slide here and just have a look if you want.
Next question, please.
38-year-old male with persistent pain abdomen, distension, and a recent history of melena since 2 days. So there are a lot of images, but I think just focus your attention on this image and just look at the bowel pattern. You should be able to answer it. And we also have a MIP image here. So these are two major mesenteric arteries that are shown here. So what is the diagnosis? Is it mechanical bowel obstruction, venous mesenteric ischemia, arterial mesenteric ischemia, or a combined type of mesenteric ischemia?
Next question, please.
A 71-year-old male with cough and progressive dysphagia to solids comes to emergency with acute history of coughing and infection. So this is a CT that is done with injection of oral contrast. So this is the contrast in the esophagus. And then we have this image. I also have shown coronal image here. So just focus at this side. So this is esophagus and this is trachea. So what is the diagnosis? Esophageal diverticulum, esophageal polyp, tracheoesophageal fistula, esophageal stricture.
Next, please.
So not really a question related to emergency, but I just wanted to show this case just to know the insight of residents about the various procedures that we perform. So this is a patient who has a metastatic pancreatic adenocarcinoma and now has presented with a very severe pain, which is not really responding to the analgesics and other therapies. So he already has a biliary statine that is done. Now he is taken up for some image-guided procedure. So just identify the procedure which patient has undergone. This is a CT scan done during that procedure. So identify the procedure, whether we have performed percutaneous biopsy, aspiration, whether it is celiac plexus neurolysis, CT fistula.
Next, please.
So another easy question. A 23-year-old male with incidentally detected lesion on ultrasound. He underwent a percutaneous intervention. So this is the CT that is done prior to the procedure. And this is the fluoroscoping image that is taken during the procedure. So the question is whether it's a liver abscess, cholecystitis, hydrated cyst or choledochal duodenal fistula. When we discuss these solutions, I will maybe delve more on this case, but for the sake of the question, we have kept it a bit simple.
Next, please.
Which of these is not true for the Ultratome XL? I think this was shown in the hands-on training that occurred in last day. The distal tip, which of these is not true? The distal tip is 3.5 French, the tip length is 5 mm, the wire length is 20 mm, the catheter length is 200 cm. I think all those who have attended the hands-on, at least around the ERCP table, could have guessed the answer.
End. Thank you.
Thank you. I think I'll just go through the answers. The first question, it was a case of, there was no history of NSID. It was a case of CMUs, what is called the cryptogenic multifocal ulcerous sclerosing nephritis. The second question, this was a serrated polyp, serrated adenoma. The ideal surveillance time of 1 centimeter lesion is 3 years. You have to screen after 3 years. So case number 3, this lesion was a Cameron's ulcer, mostly associated with hiatus hernia. Case 4, this was an ischemic colitis. Mesenteric angiography is not indicated in mild cases. A single strip sign usually seen in mild cases, not in severe cases. Case number 5, this was acute pancreatitis. The image shown is of anomalous pancreatobiliary junction. And they usually, the sphincter mechanism is lost in anomalous pancreatobiliary junction. They don't have an hyperactive sphincter. This is case number 6, the patient with dysphagia. This appearance is of mucormycosis. The arrow shown is of accepted hyphae of seen in mucormycosis. Case number 7, this is a corrosive patient. You can see necrosis not throughout circumferential. It would land up in grade 3A. If the necrosis would have been circumferential, it would have been 3B. The answer for this is 3A. It's a 24-year-old male with dysphagia since 1 year, both to solids and liquids. The diagnosis here is EGG outflow obstruction. There is some amount of peristalsis going on, and the IRPs are not that much. This question, the black arrow is the arrow in the black is falciparum ligament sign. The arrowheads are the regular sign, and the asterisk is in the hyperlucent liver sign. So the answer for this is football sign. Case number 10, the finding here is perforation. You can see the contrast leakage at the just lower end of the bile duct. Case number 11, the colonoscope 190, the length is approximately 168 centimeters. So this catheter, this clip would not have been useful. You need a longer clip, at least up to 220 centimeters. Case number 12, the classical appearance is of duplication cysts. Lipoma is usually hyperechoic, and this is arising from the third layer. So it is a duplication cyst. This is a novel thing. It's a hemo pill. It is being launched by OTSC very soon. In COVID, it had some use. Case number 14. This is the modified Mayo score would come down to 9. The way to calculate modified Mayo score is the sum of all the endoscopic scores into the number of segments that have been examined divided by the number of inflamed segments. Case number 15.
So it was, I think the takeaway was that there were frustrations in the center. You see a dilated colon and a cutoff here. And here on CT, you can see that there is asymmetric neural thickening of the colon. This was a case of colonic cancer causing large bowel obstruction. So in this case, obviously, what I wanted to show was this distended superior mesenteric vein with a thrombus, and on this sagittal image, we can see that there is stenosis of the SMA. So this was a combined arterial and venous type of mesenteric ischemia. In this case, I think most of you would have been correct. We can see that there is contrast in the esophagus, which shows marked asymmetric mural thickening. And also we can note that there is contrast in the trachea also, which should not show contrast normally. It should just show us here. And this was also seen on this coronal image, that there is a lot of contrast within the trachea. This was a case of tracheoesophageal fistula, which was confirmed on endoscopy. And in this case, obviously, there is the instillation of the neurolytic agent that is being done along the celiac plexus. So this was a case of celiac plexus neurolysis. In this case, it was a hydrated cyst. You can see that there is appearance of these filling defects, which are suggestive of membrane. But the important point was that we did not perform the procedure because the cystogram showed that there was cystobiliary communication and the precipitation of CBD could be seen.
The last question, what is not true for ultrasound XL? The distal tip was 5.5 French. It is not 3.5 French. The rest of the parameters are fine. Thank you.
So the results of the quiz are ready. First is Dr. Pardu. Second is Dr. Anish. And third, two people are there, and they are both Dr. Umang and Dr. Dinu Abiran.
So I would like to propose a vote of thanks to all those who made this 6th PGI-GI update program a success. I would like to thank Professor Usha Datta, who is the driving force behind the program. As the organizing chairperson of this program, she has very aptly steered the planning and execution of program, including the selection of topics and speakers. I'm grateful to all the members of the faculty of gastroenterology and organizing committee for their support. I also express my gratitude to eminent faculty members from across the globe who spared their valuable time to teach the student delegates and share the knowledge and wisdom. This program would not have been possible without the assistance of faculty, members of our allied departments, Department of Hepatology and Surgery in PGIMR. I'm very thankful to them. Resident doctors and pool officers form the backbone of any organizing committee of any conference. So they are the ones who work silently behind the scenes, and I would like to take this opportunity to thank each of them for the hard work they have done. I would like to thank all the sponsors for pharma sponsors for this program. They have been a constant source of support, and without the financial assistance and organization, this program would not have seen the light of day. And lastly, I would like to thank all the students who reposed their trust in this program and on the PJ in particular. It is your presence that made the whole exercise worthwhile. I thank you all. We end this conference now with the hope to meet you soon again. Good night.
Thank you, everyone. So now we will just give the certificates to the winners. So I'll request Professor Kartar Singh sir to be on the stage to give the certificates. So the first prize is to Dr. Pardu Bharat Neelam, and he has won the first prize, which is cash prize of 15,000 rupees. So now I'll request for the second prize, Dr. Anish, to come on the stage. And the prize money for the second prize is 10,000 rupees. Dr. Anish. And for the third prize, there is a tie between two people, Dr. Umang and Dr. Dinu Abhirami. So please, both of you come on the stage, and the prize money for the third prize is 5,000 rupees each. Photo.
At this point, I would like to really thank all the faculty, all the students, all the people who have supported us through this venture, the support staff at PGI, as well as all the pharma companies which have wholeheartedly given us an educational grant so that we can organize the travel and the stay at the local site. And also my faculty members who have been my backbone, my residents who have been like my extended hands. And it is because of them that we could bring in all of us, all our concerted efforts to bring this program to a conclusion. And I really heartily thank all of you, especially Anupam, for tirelessly working for the last couple of months with me, and Vaneet Jirat, who was always there whenever called to come and work for this program. Jimil, who organized the alumni meeting so nicely yesterday. And we have had Dr. Prasad helping us at every step wherever it was required. Dr. Ravinder has come today, it's wonderful. And Mr. Pranav, who has managed all the travel accommodation so seamlessly that never did I have to even worry about it. Thank you, Mr. Pranav, and thank you, Pankaj, for always being there to take care of not only the radiological aspects of our patients, but always being there as a pillar of support to help the department move further. And we have our PhD students, PhD scholars, Harish, Priyanka, Deepa, Ankita, and Neha, and Priya. So all of these people have worked silently at the back end without, expecting an applause from us, without knowing what is happening here also, because these are not topics which are of their primary interest, but they have just spent their valuable time with us to just help us coordinate the events. And if I'm forgetting somebody, we have had the camera people, we have had Anil, who has been there for the last 3 months, working tirelessly, organizing, coordinating the whole process of not only printing, but anything you need, you just troubleshoot, tell Anil, he will get it done. And this time, Vicky Nagpal, I think all of us have to give him a round of applause for, despite the rains, because of his hanger and the wooden platforms, we could still carry through the conference. Otherwise, we would have had to shut down the whole thing. And thanks to Vicky, we did pray to rain god, we did pray to Surya, everybody, but I think Vicky is the one who saved our day. Thank you, Vicky. And I really am very grateful to Professor Kartar Singh, who has been a pillar of support for the department. Anytime there's an academic meeting, you can see that he is there from the beginning to the end. And it is not that it is something which, despite his other personal commitments and other things, he has always been there as a support. Whenever you ask him, he's always there. Thank you so much, sir. And Professor Anand, he is such an enlightened person amongst gastroenterologists. I find him such an enlightened person that I quite often ring him up and ask him, what should I do? And there he gives me a sage-like advice. Previously people used to go to rishis and munis. So for me, it is Dr. Anand. And not but the least is Rishabh, who works so efficiently. I have every time tell him, teach me Excel. He is so good in Excel and so fast in Excel that I just have to tell him, do this in 2 minutes. He tells me the answer. And Dimple, I can't see Dimple here, and Dimple has been, has my secretarial help, Jitinder, all the office staff have worked beyond time to bring this program to you. The reason why we do this program is only one thing, is that we think our postgraduates should know what they need to know so that the patient they are treating is benefited. So we teach you so that you can treat your patients better. I've had another one rock solid person in the department, and we are going to miss him because we're going to lose him today. And that is Anurag Jaina. So he has been a pool officer in the department. Please come, Anurag. And he would be leaving us soon. He may come back to us as faculty, but right now he has to fulfill a commitment in Maharashtra for about 8 months. So we'll miss him for that period of time. Please come, Anurag. So he has been in the department for the last 4 or 5 years. I can't imagine the department without him being there, because he was there whenever anything was required. And I will ask Anurag to say a few words.
First of all, thank you for this. PGI has always been my second home. All day long OPDs, all day long endoscopies, night rounds. My wife and daughter have managed my first home. This is my second home. I've spent more time here than my home actually. I thank all my faculties. Professor Usha Datta has been my mother, actually my mother. She has helped me through all the financial troubles, all the family troubles and the health issues. And all the consultants, especially Visal sir, Sinha sir, Jamil sir, Anupam sir, they all have been, not only have hold my scope while teaching me, but also have held me my rope of my life also. All my seniors, all my juniors, my batchmates, Nikhil, Chagan and Antriksh, I miss them. They all have left. So I was the last one to go. Lastly, apologies if I have hurt anyone unintentionally. I thank all the staff, endoscopy technicians and the office staff and the PhD students also. Whatever I am, I will always owe this to PGI, and I will take all my memories till my last breath. Thank you.
Today again, we are going to miss out on one more person, that is Wrinkle. Wrinkle, please come here. Wrinkle has finished her DM with us, and a brilliant lady gastroenterologist. In a batch of 4 people, she did the best, and I'm proud of her achievements. She's very straightforward, simple, doesn't get into any controversies, is very clear of her goals, and you tell her a job and it is done. And wonderful experience we have had with her for nearly 3.5 years. We are again going to miss her because she wants to go back to her home state, Gujarat. So I wish her all the success. Thank you. Please.
So I have been here in the PGI for 3 years and 3 months exactly. So I don't know what to say, how to explain my gratitude for the PGI, for everyone, starting from madam to staff member, office staff, endoscopy, everyone. Just thank you. One word wouldn't be sufficient, but I have no words to explain my gratitude. Thank you.
Thank you all. With this, we come to a close. Thank you, everybody. Thank you, sir.